Okay, if we could make a start, if I can ask you all just to take your seats. My name's Peter Bruce. I'm the Physical Secretary and one of the Vice Presidents here at the Royal Society. So it's a great pleasure for me to welcome all of you here to Carlton House Terrace and the many people who are joining us also online to this what I think will be an excellent meeting. Now, for those of you who are not familiar, the Royal Society was founded in 1660, a royal charter from Charles II, and it's the oldest continuously operating Academy of Sciences in the world. And of course, as the National Academy of Sciences, it has a key role in national challenges such as the COVID pandemic. And back in March 2020, the Royal Society launched 3 initiatives, DELVE, and the acronym starts for Data Evaluation and Learning for Viral Pandemics. And they carried out a number of studies, including one of the early pieces of work advocating the greater use of masks. We also set up something called SETC, Science and Emergency Tasking, for COVID, and that's a committee that I chaired, and that brought together a group of epidemiologists, immunologists, virologists, etc., really convening, I think, our strengths in the UK in those areas, both to provide very rapid reviews to government within 24 to 72 hours of questions they would have, but also to use their more extended networks around the world to garner information that was not yet published so that we could be right up to date and supply government with up-to-date understanding of COVID-19 as it developed. And the third, of course, and clearly the most important one, is the one that we're celebrating here today, which is RAMP, Rapid Assistance in Modelling the Pandemic. And that was to bring together the wider modelling community, outside the epidemic modelling community principally, to support the epidemic modellers, but also to complement them in the activities that they carried out. And all of these 3 initiatives under the Royal Society umbrella fed into SAGE and other parts of the government machine grappling with the COVID-19 pandemic. Now, the credit for RAMP really must go to Mike Cates, because Mike came to us as the Royal Society in those early days in March 2020 and proposed this idea. I was fortunate to be on the steering committee and to be the Royal Society representative working with Mike. And within, I think, 3 or 4 days of the call going out, we had over 1,200, I think it reached about 2,000, but I may be wrong in the numbers, but certainly a huge number of people responded within a very short space of time. And the vast majority, as I said, not in the epidemic modelling community, but in other types of modelling, other types of agent-based modelling in particular. Now, RAMP has provided rapid review of the literature. It has brought together communities in modelling to work intensively on these challenges, and I think very effectively and very creatively over the last couple of years. I think it's great today that there's a strong element of celebrating early career researchers. I think that's really important. And I also think it's important, I think this afternoon, when we start looking at the lessons learned and how we can be better prepared in the modelling area for the next threat that will come to the UK and globally. And clearly data will be a key issue in that discussion. So without further ado, I look forward to an excellent meeting over the next few hours, and I want to hand over now to Mike Cates. Thank you.
Thank you very much, Peter. So as Peter just said, RAMP started off as a kind of convening of people willing to work voluntarily on supporting the modelling effort, and did that fairly successfully for the first 6 months or so of its existence. I think it's very important, though, that since then we also had some UKRI funding, which is about to come to an end, started 18 months ago. Particularly in collaboration with the Newton Institute, RAMP has sort of morphed into a forum, if you like, or a range of meetings and events, of which this is a major one. And it's fantastic to be able to be here physically in this room. The room is not full, which is probably good. but the numbers I'm sure will wax and wane during the day. And even if you don't individually think of yourself as particularly connected to RAMP, that's not the point of this day. This day is to celebrate the contribution of early career workers to the modelling effort. Early career academics and postdocs and students have had a very unpleasant time during the pandemic, as have all young people. So us oldies want to express our gratitude enormously to those who've contributed so much to the national effort, and this is a first step, I hope, to acknowledging that role of many of those present in the room and speaking today. So without further delay, I'd like to hand over to Ellen Brooks-Pollock, who is going to chair our first session of Early Career Talks. Ellen.
Thanks, Mike. Yeah, welcome to everyone here, and I think we've got some people online as well. This is a great opportunity to find out about work that's been done by early career researchers during the pandemic, although while I was looking up everyone's biography, it's a bit surprising they're all early career because they've done an enormous amount of stuff in the last 2 years and in very short spaces of time. So every speaker has 15 minutes, which includes questions. I've got a big number 2 that I'll hold up when we're coming to the end. And if we do run up to the 15 minutes, then you could try and grab the person over coffee or over lunch and ask them your burning questions. So we've got 9 talks today. The first is from Sam Moore. Now, Sam Moore finished his PhD in networks and epidemic spread on networks just at the beginning of the pandemic. And during the pandemic, he's been particularly modelling vaccination, has done some really great work looking at modelling vaccine rollout, particularly in the UK. And he's just won a faculty postdoctoral prize in mathematics at the University of Warwick for his work on vaccination. That definitely deserves a clap. But today he's going to talk about some other work he's been doing on global vaccination sharing. Yeah, take your time. Sam, the lectern's over here. Looks too... Oh, there's this thing. Yeah. Do you want us to show you? Okay, great.
Mic for you. So.
This thing that doesn't move. But I'll be just at the front if you want me to do anything else.
Okay. So just want to open your app. I'll spin this for you so you can see your preview. So that's your next slide and the current slide. Great.
Cool. Right, okay. Is my mic working? Excellent. Hi everyone. Sorry about that drama. Yeah, so I'm going to talk a bit about some work I've been doing, looking at what has happened if we redistributed vaccines a bit more differently during the pandemic. So the vaccination was really a massive achievement, which we all know about. We managed to vaccinate about 50% of the globe across 2021, which had a massive impact on stopping the spread of COVID and stopping the huge mortalities which were involved. But it was extremely heterogeneous. The vaccines were developed by the richer first world countries, and naturally the high-income countries are the ones which took up the first dose of the vaccine, and lower-income countries typically didn't get vaccines until much, much later on, which has had a big impact in itself. So, like, the coverage on average across first world countries was about 75% of people over 2021, but in many lower income countries it was more like sort of 5% or even less. And the result of this is you've got similar patterns in infections and mortalities, respecting the fact that many third world countries or lower income countries didn't get the vaccines that the higher income countries did, or as early on. Obviously this is quite difficult to tell, as tracking and tracing is not really done in the same way in all countries involved as we did in the UK. But by basing estimates on mortality surplus, so mortality beyond what is normal, we can get some sort of estimate of the effects of COVID across the globe, and we can see that many lower income countries have suffered worse because of the lack of vaccine available. And deaths is a more complicated picture again, as it's typically the fact that in lower income countries the populations tend to be quite a lot younger, and therefore get affected less by necessarily direct impact of COVID, which really affects the most elderly and most vulnerable. But there's also many other bad things which happen because of COVID. I mean, it's blocks up healthcare systems, and in lots of third world countries which have already got big things like tuberculosis stuff going on. The fact that COVID is stopping these healthcare systems would have a massive impact as well. So obviously, the more vaccine to third world countries would have a great benefit in this respect. So I was thinking about what would have happened if we distributed things a bit more differently. Why is the way things have been done not optimal? I mean, for a start, the very first vaccine doses we gave, they're the ones which had the biggest impact. We carefully decided to give them to the most vulnerable people. So, like, the first doses went to the most elderly, the people who are most likely to have these big health risks. So they're the doses which had the biggest impacts. And then later on, as we gave out more and more vaccine, we ended up doing booster doses and vaccinating the younger and those who aren't so vulnerable, and the impact gets less and less. But if instead we got that same high impact in other countries as well, which didn't have the such high coverage, when we were giving out doses to which had a much lower impact, we could have a greater impact overall. Also, what was very interesting is there's obviously this, the COVID pandemic was marked by a driving and variants coming through, which had transmission advantages, and like the Alpha and Delta. And you could say that this is in some respect tracked to the spread of COVID around the world, and the number of infections. The number of infections is driving this evolution, and then just the amount of transmission around the world means these evolved variants then spread around the world. So by delaying infection, we could have had a benefit to all of society, not just those countries which might get some extra vaccination. So how do I tackle this question? It's a big modelling challenge. So I made a massive model, big messy model. It's basically a compartmental model of 152 countries globally. And then it's got interactions between them in terms of redistributing vaccines, or in terms of this correlation between how the variants spread with the number of infections overall between all countries. So these are the important dynamics I was playing with. So by using this global model, I then looked at some different possible sharing thresholds. So instead of just looking at things how they have been up until the end of 2021, so I'm just simulating 2021 here, I did that alongside looking at what would happen if we vaccinated up to a certain, all countries vaccinated up to a certain threshold, so usually an age-dependent threshold, as we did age-targeted vaccination. So if we vaccinated up to, say, all adults, and then once we've managed this, then we start giving more vaccine away to other countries which haven't had that benefit. What impact might this have had? And funnily enough, it has a great impact in terms of saving mortalities. So because you vaccinate these vulnerable people earlier in all countries, then you could potentially save a lot of lives. But that's not the whole message, though. Interestingly, the number of infections, if you redistribute vaccines, doesn't change a huge amount, because these infections still happen, just in different people by distributing the vaccines in different ways. If you look along the top line of these figures here, so these are sort of time scales or timelines, and the coloured regions above and below the central line are whether you get more infections or less infections in each region. So the big red going negative, that's saying that the high-income countries are getting lots more infections later on, whereas the stuff above the line in the other colours, the blues and the greens in particular, they're the lower-income countries which are having gains from the redistributive vaccination. And you can see in the full sharing scenarios, although we get lots of gains in the lower-income countries in terms of infections, later on, as the higher-income countries start giving vaccines away, and because of that, and we're relying on these vaccines to stop the infections, and that's the things which allowed us to open up and remove other restrictions, that we end up in many more infections because of this, although they don't necessarily translate to mortalities, because we've already got a certain amount of vaccines in place. But obviously, throughout the entire pandemic, we didn't just stop and stand by while lots of COVID infections happen. We tend to respond to these infections and use reactive sort of non-pharmaceutical intervention measures to mitigate. And if that had been done instead, to stop the negative impacts of redistributing this vaccine later on, then we could have maybe seen lower infections across the globe. And by having lower infections across the globe, this could have potentially delayed the spread of variants, and that could have had a huge impact for everyone. So looking at sort of a scenarios where we change behaviour when we start sharing vaccines, you can see you get this positive feedback loop kicking in, where because we've got less infections, then there's less spread of variants across the world, and therefore the sort of average transmission of COVID is lower in time, and therefore there's less infections, and therefore less spread. So we had this, we could have driven into a much sort of lower infection place just by distributing vaccines differently, potentially, which is the sort of message I wanted to give. But thanks. Yeah.
Perfect timing. Do we have any questions from the audience? Emily?
I was wondering, did you always look at vaccinating vulnerable people first, or did you ever look at scenarios where you might have vaccinated people that, like key workers or people who have a lot of contacts first?
I looked just at doing vulnerable first in this instance. I mean, that is another good question to look at, but it's quite difficult to say in different countries who the key people are and who the spreaders are. I mean, each country's got its own dynamics and own populations, but it would certainly be an interesting question. And I think one thing I do want to look at is which sections of society would be best to vaccinate in different countries. Because with countries who've got much younger populations or mix in different ways, the question of who to vaccinate first is not an obvious one.
Yep, question over there in the middle.
So how do you account for the difficulty of delivering vaccines in less developed countries?
Yeah, that's another good question. I mean, I'm just concentrated here on supply limitations as being the things which have slowed down vaccines in other countries rather than distribution limitations. Obviously, some of the poorer countries don't have the same sort of healthcare networks that we've been blessed with here. And due to cold storage and things, which are necessary for vaccines like Pfizer, in hotter countries as well, that's been a big challenge. And also the uptake has been progressively more of the challenge. It's possible that if vaccines have been offered earlier, you might have got a higher uptake, as people have sort of, in a lot of countries, have there seems to be some sort of feeling that they've got this far. So why do they want to take the vaccine now? They've been okay until now. So I think that's been keeping vaccination numbers down as well. But certainly getting the vaccine out there and getting it to the people is not a straightforward task at all.
I think there was another question. Yeah.
Thank you, Sam. I think this might have been partly answered by the first question, but is your model capable of shedding light on I think what you describe as the difficult issue of who to vaccinate first, in terms of whether it's better to vaccinate those most likely to spread infection rather than those most likely to die from the infection? So, in other words, would it make more sense to vaccinate students, say, or is it absolutely obvious in your view that you always vaccinate the most vulnerable first?
So yes, as I said before, this is something I want to look into more, and the model is potentially useful for doing exactly that. But in different countries, the populations are very different, so it's could be a variable across the globe who those people are best to vaccinate first. I mean, I was involved in quite a lot of work early on in the pandemic within the UK of working out who the best people to vaccinate in the UK are. We had a much more sensitive model for this with a lot more dynamics involved. We found that vaccinating the elderly and most vulnerable first was definitely the right thing to do. Just mainly because these vaccines are better at giving direct protection to individuals rather than necessarily protection against infection, but protection against like severe disease and hospitalisation. But whether this is the case in all countries is definitely not straightforward and would be worth looking at.
Brill. Okay, thanks very much. Is Ruth here? Oh, great. Do you want to come up? Well, I think we've got 10 seconds and I've got a question. Is that okay? My question is, did you look at any kind of intelligent vaccine sharing, like where you just share with your nearest neighbours or something rather than sharing globally?
No, I haven't. That will be an interesting thing to do. obviously that the neighbours of countries have a bigger impact on the country itself than countries further away, or not necessarily geographical neighbours, but countries which are more linked together.
Yeah.
As in the world's a bit of a network, and there's certainly stronger links between certain countries than there are between other countries. And that will be something interesting to look at.
Great. Well, let's thank Sam again. Thanks. Well done, Sam.
Thank you.
Do you need a hand with that, or are you okay? Is there an AV hand with the microphone? Oh, he says just go off and they'll sort you out at the side. So next up, we've got Ruth McCabe. She's a NIHR-funded PhD student at the University of Oxford, and she's got a maths degree and an MSc in statistics. And she's previously worked on malaria, looking at spectroscopy data, analysing mosquitoes. And during the pandemic, many of us had contact with her because she was interviewing and conducting surveys of modellers involved in the COVID response. And I think that's the work she's going to talk about today, resulted in a very nice paper. So come up, Ruth. Thanks very much. No, you're fine, don't worry. Okay. Okay, great. Thanks. So hi, I'm Ruth McCabe, and as Ellen said, I'm a PhD student in the Department of Statistics at the University of Oxford. So my thesis is all about the modelling and analysis of high-consequence infectious diseases, of which I spend most of my time working on COVID. So today I want to give an overview of the first chapter of my thesis. So this consists of 3 distinct pieces of work, but they are very much interlinked, all about the use of modelling in informing policy. So the first of these is disease transmission and control modelling at the science policy interface. So this is one that Ellen mentioned. I've been speaking to lots of people in the room about their work on modelling at the science policy interface. This is going to form the basis of the talk today. The second piece of work is inspired by some modelling work I was doing around 2 years ago now, looking at intensive care unit capacity. And this links really nicely to one of the findings of the first piece of work. And then finally, I'm going to talk about a survey on the awareness and opinions on the use of modelling in informing policy. So just to flag, the first 2 pieces of work have been peer-reviewed, they are published, but this last one has not been. So, yeah. Thanks. Sorry. So yeah, before getting started on the results, I just want to give a brief overview of how science advisory mechanisms have worked in the UK during the pandemic. So we've got the Scientific Advisory Group for Emergencies, known as SAGE, is a central advisory body responsible for providing government decision makers with scientific and technical advice during emergencies. So the Scientific Pandemic Influenza Group on Modelling, known as SPI-M, is a specialist subgroup of SAGE, that feeds into their evidence. So it's then the responsibility of the government chief scientific advisor, and in this instance also the chief medical officer, to communicate the findings of SAGE to government decision makers. So by a government decision maker, we mean an elected official, so someone like the Prime Minister or the Secretary of State for Health. And it's just, to be really clear, I think we all know that it is their job and their job alone to decide whether or not to implement any policy based on the findings of the scientists. So in the first piece of work, disease transmission and control modelling at the science policy interface, we synthesise information coming from 3 different sources. So this is the first of which was a literature review. So we just looked at some of the key studies that had been used to inform policy. So we found a real breadth of studies that had been used in informing policy in the UK. And I've just got an example here of a study done by Nick Davies and colleagues at the London School. So We then decided that we wanted to speak to the people who were involved themselves in conducting this to find out a little bit more about how the process of developing models worked and how they communicated it to the people who were making decisions. So to do this, we sent a survey of 8 multiple choice and 2 longer answer questions to 189 individuals publicly listed as being a member of or having attended a meeting of SAGE or SPI-M, and for which an email address could be found. We then also conducted 11 longer style interviews with people including science communication experts, former chief scientific advisors, just again to supplement the findings of the survey. So we can break the results down into 2 broad categories, the first of which is the communication between modellers and decision makers. So here I'm just showing the results of our multiple choice questions. So what we can see is that the majority of our respondents said that they believed that the modelling had influenced both the scientific understanding of the decision makers in addition to the decision making itself. We saw that most of the scenarios that were modelled were informed by policymakers, that these scenarios were broad, but that different modelling groups generally made similar assumptions about the underlying transmission dynamics of SARS-CoV-2. Finally, what we saw, which is quite interesting, was that far more of our respondents said that they believed that they had a minimal influence on policy compared to those who believed that they were highly influential. So from the longer answer questions and from our interviews, we found that generally people felt that the structures of SAGE and SPI-M had worked really well during the pandemic. And lots of people actually noted that they'd been really proud of the way the community had responded to the crisis. So in terms of things to improve upon, some people noted that they would like to see more bi-directional communication between the modellers and the policymakers. This was not a view that was shared by everyone, but there was a general consensus that we need to improve the communication of uncertainty to non-technical audiences. And this leads us on really nicely to the second piece of work, which is about communicating uncertainty in epidemic models. So as mentioned, about 2 years ago, I was working on a modelling study with colleagues at Imperial, where we were looking at different measures being implemented and the effect that that would have on intensive care unit capacity. So in blue on the left-hand side, we've got our scheduled suppression measures. So in this instance, we say that, okay, on the 1st of the month or whatever, we're going to implement our measures regardless of what else is going on. And in purple on the right-hand side, we have a reactive scenario. So this is instead of having it on that fixed date, we say, okay, dependent on the number of patients already in intensive care, that's when we're going to decide when to lock down. So we've got our trajectories in the top row there, and then we provided some key metrics that we thought would be of interest to policymakers. So namely the size of the peak of deaths, hospital demand and ICU demand, and the timing of that peak. So we've summarised it in the way that's most common to do so with this type of model, so just using simple summary statistics. So looking at the median trajectories in that thick line in the middle, basically, they look more or less the same. There doesn't really appear to be a lot of difference between them. But what we found actually, when you look at it on a power realisation basis, quite a different picture of the potentially unfolding epidemics emerge, and that's particularly the case in the reactive scenario. So we've plotted the same data as we had before, but we're just using colour to link the individual trajectories in the top row to the key metrics on the bottom row. So we think by looking at the data in this way, it helps to give a clearer idea of the action that has to be taken at hospital level to prepare for what could happen. So, for example, the Secretary of State for Health might decide that we're going to go with a scheduled strategy. And in that instance, hospital level decision makers then have to think, okay, there's a really big number of beds indicated by the model that we might have to procure, like to deal with the influx in patients. However, if it's the reactive scenario, there's this additional layer of uncertainty in the timing of the peak. So hospital-level decision makers are going to have to think about how quickly they procure those beds in addition to how many. So we think presenting it in this way allows for these messages to be more clearly communicated to people who may be less familiar with summary statistics and with modelling in general. So we come back to the first piece of work and we go to that second results category, which is the communication of modelling decision making to the public. And this is something that people thought had been quite difficult to do during the pandemic. So the people that we spoke with said that they felt a real personal responsibility to ensure that the public were well informed on the evidence underpinning decision making. But they said it was really difficult to do so because obviously models are these very complex things to explain. So it's difficult to be clear about the model results in a clear way, while also, saying, well, it's based on these assumptions. Finally, a lot of people also said that they thought the distinction between the roles of scientists and decision makers had often been blurred, but obviously it's really important that the public understand the difference because ultimately they are responsible for electing their decision makers. So based on this, we wanted to try and get a better understanding of how the public might feel about the use of modelling and informing policy. So we sought further ethical approval to conduct a survey of 10 multiple choice and 6 longer answer questions. So obviously it's very difficult to get a representative sample of the public, especially on the budget that we had. So we decided that we would go with a sample from Prolific Academic. We got 509 responses last summer from doing so. And then we thought, it's free to tweet out the link, so why don't we just do that and see if we can compare the results that we were going to get. So we got 207 responses from doing that. So I've got the preliminary results here, and again, just to flag that these have not yet been peer-reviewed. So we asked people if they were aware of modelling being used to inform policy, and we asked that for 2 time points, before and during the pandemic. We then asked them for a number between 1 and 10 about how reliable they felt it was to do so. So with 1 being extremely unreliable and 10 being extremely reliable. So what we saw was that in general, our Twitter cohort were more aware of models being used to inform policy. So we had that in the pandemic period, only 1% of our Twitter respondents said they were not aware of modelling being used to inform policy, and that was compared to 15% of our prolific respondents. So really starting to see the bias in those 2 cohorts. So in general, there was a greater awareness in both cohorts during the pandemic compared to the pre-pandemic periods. I don't think that's a particularly interesting result, but what I do think is interesting is that there was not an increase in reliability or feelings of reliability to go alongside that self-reported awareness. So although we see in the right-hand corner in green that the median reliability score either stayed the same or slightly increased, what I can't show here for reasons of deductive disclosure is that there are actually far more responses falling in the lower half of the scale during the pandemic compared to the pre-pandemic periods. So just to sum up, we really hope that our research contributes to this important discussion about the interplay between modellers, decision makers, the media and the public in the era of COVID. Of course, the findings of this research are very much based on people's opinions and experiences, and most of the people that we invited to take part in our surveys didn't respond. So we're in no way claiming that this is the definitive piece of work on modelling and informing policy, but we really do hope that it contributes towards the discussion. So I just want to thank everyone who took part in our research for being so generous with their time. We're very grateful, and I'm also very grateful to the amazing supervision of Oliver Watson and Crystal Donnelly. So thank you for listening.
Great timing, excellent talk, thanks. Are there any questions from the audience straight away? You're welcome to pick people as well.
Yeah.
I'm Susan Gray. Thank you very much for such an interesting lecture talk. I'm interested in the reason that nobody responded to your invitation about the effects of the pandemic on foreign policy, because this is totally unconnected to COVID. And I've gone on and on about it, but I organised an event for a charity and nobody turned up. And yet we had the place, the people were interested in the subject. So do you think it's another force that we've got to consider that I truly don't know? And maybe somebody can tell me why people don't want to do something, and yet on another time they will be inundating somewhere with what they want. Thanks for listening.
Yeah, thanks. I think, so for us, I think when we sent this survey, we were right in the middle of the I think, was it the alpha wave at that point? So obviously everyone was like extremely busy. So I think we were actually very happy we weren't expecting to get quite as many responses as we did. Yeah, I think it's obviously really difficult to tell when people are busy and when they're not. But yeah, no, I agree. It's always a bit unpredictable.
It's a good idea to introduce yourself as well. Sam, if you can just say who you are.
Hi, I'm Sam. I'm a modeller at the Zeeman Institute at the University of Warwick. Yeah, quick question. In your survey data that you had to show really quickly, was there any indication of why there might be more people having lower confidence in modelling? Or was that not one of the questions that people responded to?
Yes, so we didn't actually ask like a specific question. Like we had lots of comment boxes for people to indicate. No, like I was really surprised at that finding. I think maybe one of the things I was thinking was that honestly people were just really tired of sort of living with restrictions, and if you see modelling as telling us that we're going to have to lock down, then I could see why people would then think that, you know, like that would be a reason to not find it reliable. But yeah, no, I would hope when I go through the results in full and go through those comments, I'm hoping that I can unpick a bit more of that.
And we've got time for one last question before Sam's up. I've got a question then about, do you have anything to say about differences between the UK and other countries in terms of modelling and interaction with policy and the public?
Yes, so we did actually have a couple of people not from the UK in our survey. So we did have someone from New Zealand and someone from the US. So it's obviously not like a very big sample size to draw huge conclusions on. But I think generally one of the things that people were saying, I think it was in New Zealand, that I think they really looked to the UK as sort of a model for like the science advisory structures and based it off of those, I think, yeah.
Great, thanks. Let's thank Ruth again. Well done. So next up, we've got Sam Brand. Lots of people know Sam, especially if you've been through Warwick in the last 15 years. He's
I'm so early career.
Yeah. He's a postdoc at the University of Warwick, who's worked on livestock diseases, vector-borne diseases, and immediately prior to the pandemic, he was working on respiratory diseases in Kenya. Mm-hmm. And then he pivoted his work to look at COVID in Kenya and wrote a nice science paper, and he's going to talk about it now.
Cheers.
Over to you, Sam.
Thanks a lot, Ellen. So I guess I just press left and right. Hi, I'm Sam Brand. I've just been introduced, so that's great. Yeah, I've been working at the University of Warwick for a really long time. I'm one of Matt Keeling's many PhD students, but for a few years leading into the pandemic, I was working very closely with people at the Kemri Wellcome Trust research program based in Nairobi and Kilifi. On respiratory viruses in East Africa and mainly in Kenya. So we were like quite well placed to give some modelling advice to the Kenyan government. So quick overview of the talk. I'm going to quickly introduce the team from a Kemri Wellcome point of view mainly, because more people here know people from the Zeeman Institute. Do just some quick pointers about the early epidemiology we were seeing in Kenya, because it may not be familiar to most people here. I'm going to highlight one bit of data which is probably different to how you would sort of build a model from a high-income country perspective, and then like a brief overview of our modelling outputs, and then conclude. Right, okay, so the team. Okay, so there's a snapshot of some of the people that have worked on the modelling in Kenya. So I'm down there with longer hair. And in the bottom left is John Ojal, the Kenyan statistician who's led a lot of this work in collaboration with me, the actual sort of coding and the nitty-gritty. So we work in quite a multidisciplinary way. So as well as the modelers, we have like a highly established health economics group at the Kemri Wellcome who were inputting things into the modelling pretty much continuously. And we've had a really long-running virus epidemiology group in Kenya as well, because we they've been working on respiratory viruses, mainly RSV, but also other respiratory viruses in East Africa for decades, led by our PI out there, James Noakes, who's third in from the right at the bottom. And what we were doing, so focusing on our team, is we were giving modelling input mainly to these 3 different organisations, which were also talking to each other, and I'll get onto that in the next slide. So the National COVID-19 Modelling Technical Committee, this kind of worked a bit like SPI-M did in the UK, so you can imagine replacing the word SPI-M with that. And those are some of the institutions that were putting policy recommendations and modelling input into that discussion. We were also talking directly to the Kenyan Ministry of Health and also via this modelling committee because the Ministry of Health will give out different requests for policy advice to different groups at different times. And we were also talking to Africa's CDC quite a lot, especially on the health economics side of things. Okay, so zooming out from our personal group, this was the basic structure of communicating modelling advice to policy in Kenya. And actually, it's pretty familiar from the previous talk, and I might even have not bothered with this slide if I'd known what Ruth was going to present. But yeah, so we're putting in, we're basically having a very wide-ranging discussion based on requests for modelling advice from the Director General of the Ministry of Health in Kenya. He's making requests to the technical committee, and we're basically arguing things out. This is kind of where RAMP comes in, because I'm also on some informal discussions on the Warwick side. So basically, I'm getting all the great ideas about modelling for COVID in the UK and copy and pasting them, and then like bringing them to Kenya and then tweaking them until they worked in a Kenyan context. In parallel to that, there was the actual small group, reasonably small group that they put together to actually implement the policies that they called the National Task Force. And so they were making their own policy requests, they're making their own requests about modelling advice to us. And there was basically this big back and forth with the 2 main hinge individuals being the Director General of the Kenyan Ministry of Health and the Cabinet Secretary. And they basically filtered the advice, which then went into the ministerial committee of the Kenyan government and ultimately to the office of the president, who has to action these things. Okay, right, so we cast our minds back to March 2020. What we were seeing in Kenya is that they knew that a pandemic was coming because by mid-March it was getting into multiple countries. Blocking on the border based on like catching people with symptoms was not 100% effective. We knew that in February 2020. So we'd done a preprint where we were like, right, this is probably going to be a big epidemic in Kenya. And then finally we got our first PCR confirmed case on the 12th of March. Now, the Kenyan government was basically waiting for that trigger point of getting that first confirmed case. And then they moved rapidly with a package of measures that they planned in the weeks leading into the first case. So you can see they closed all public events the day after the first PCR confirmed case. The schools were closed the week after that, and they were closed for a really long time through to January 2021. They shut down all the flights. So first they shut down flights for non-Kenyan nationals, then all flights. They did county restrictions. They closed the borders with like Tanzania and other neighbouring East African countries. They closed like pubs, eateries, religious venues, and so on and so forth. But the case rate kept on going up, so this wasn't enough to turn the pandemic over in Kenya. So the kind of questions we were asked to do policy, or the kind of questions we were asked to give a modelling input to are probably very familiar. The first one was, if we've done this whole package of measures, why haven't we killed, why is RT clearly not below 1? But it's going very slowly. This is like a sort of 16-day doubling time. How big do you think it'll be? When will the peak be? Like what kind of health capacity will we hit? All the kind of questions I'm sure everyone's highly familiar with here. And what we were seeing was, it was growing. It was growing slow exponential. By mid-June, we had 125 confirmed deaths. The Kenry Wellcome team has done a lot of work on talking to communities about actual numbers of deaths and comparing it to reported deaths. And usually in Kenya, you have about a 3-to-1 under ascertainment. So you tend to see about 25 to 33% of the real deaths that you can find by going out into communities and talking to people actually end up in their system. So you expect an underassertment with COVID-19 as well. But from the people that have smartphones in Kenya, which is a highly non-representative sub-selection of the population, there were basically UK-level, evidence of UK-level-ish drops in mobility from the Google mobility data, which I'm sure loads of people have used here. Right, so leading into June, we got our first reasonably large seroprevalence surveys, and they were kind of highly surprising because in the two main cities in Kenya, you were getting essentially London-sized S-gene seropositivity, which even when we were factoring maybe there was 3 times as many deaths as were getting reported, this was kind of like more in the sort of 10 to 100 times, evidence of about 10 to 100 times more infections than we were expecting from looking at the deaths, even when we're factoring in things we knew about the underinsertment of deaths just in general in Kenya over a long time period, which meant that something was going on that we didn't really understand. I could give a very long talk on that. I won't. That I'm just putting that's like the setting. So that's like where we were with modelling in June 2020, where it was a big shocker. It spread much more in Kenya, despite really fast-moving and highly restrictive measures that the Kenyan government had put in. And I'm sort of going to take a slight step away from that into like what is actual reliable data for modelling in Kenya. So this is from the fantastic resource, Our World in Data. I see someone from there is talking later. It's an absolutely amazing resource. But in Kenya, the reporting rate of death also changes over time radically because they're doing different things in the background. When you hit this middle bit, which is essentially the alpha and delta waves kind of allied with each other, they get the reporting goes really weird for complicated reasons. But what was happening was that the Cabinet Office was essentially, they were looking at like RT estimates that were getting published on sort of internet sites. And obviously when you get these weird up and down drops, often Kenya was reporting really high RT and they're like, what's happening? We're like, well, you're putting this into Our World in Data and it's not, you know it's not reliable and that's why you're not getting reliable estimates. And so there was actually a really long conversation about how you interpret this. The way we sidestepped that was basically not using deaths and not using, because you have to realize in Kenya, the deaths in the ICUs are really, really noisy. And we find out months later what really happened from doing long conversations with clinicians in hospital settings. But what we found had stronger predictive power was using basically fractional estimates. So basically, if we have PCR positive and negative, we expect that to be biased. We got some reasonably good cross-sectional seroassays, which then happened a number of times over time. And that let you somewhat correct for the bias. And you end up getting much better projections if you use the data on the left. And then once you have a feel for how the actual infection process is going in different parts of Kenya, you can then say, like, right, how is this looking like the deaths? Does it look like it? Does it not? What does it look like the underreporting is? And once again, I can talk about that for absolutely ages, but I won't. And I'll just do a few examples of the modelling we were doing for the Kenyan Ministry of Health, and mention some papers we got out there, and then close up because I tend to overrun. Sniggers. So most of what we've been doing is creating these sort of brief summary packet papers that we call policy briefs. And so the stuff that goes into the policy briefs is our modelling where we've had a conversation with the National Committee about what is appropriate and inappropriate modelling in Kenya. And we've basically marked each other's homeworks in terms of like forecast accuracy and that kind of stuff. So most of what we've done are these things where you can see the Kenbury Wellcome Trust branding on. So that has either been when the Ministry of Health has come to us with a particular question like, what do you think the impact of opening schools will be? What will be the immediate impact over the first couple of months after reopening schools? Versus things where we've gone to them and we've said, we now know there's this thing called Delta. It's almost certainly going to get into Kenya. And you need to be advised that there will be an uptick in cases and some pressure on ICUs and hospitals. And we won't be able to know what that pressure will be, but we'll do some forecasts, and then in a few months we'll find out if we were any good or not. Also, the Ministry of Health have been very keen for us to publish, because that lets them, when they're talking to journalists, basically in Kenya, they can go like, look, here is the evidence. It's not just a bunch of guys in a room. Some other people had to check their homework as well. I don't know why I put the one in the top right. That's actually not a very great forecast. That was when Omicron came in, so we did a forecast in December. It was a bit lower than that. It's basically the red dotted line, but Omicron wasn't as nasty. Thankfully, wasn't as nasty as we feared it could have been. To wrap up, I would say my takeaways for talking to a community of modelers is that, firstly, this is something that's in demand in low and middle income countries. They really want to see modelling evidence. And I saw from Ruth's talk that talking to policy, I think one of the things was that policymakers did take this under advisement, and that is very much the experience I've had in Kenya, that people are highly interested in this. But the data reporting mechanisms are fragile, inevitably, and things that you would naturally say are probably the best asserted things, like the death time series, aren't necessarily the best asserted things in an LMIC setting. So basically, if you go in with that mindset, just be ready to tweak what you're doing in an HIC for the LMIC. Talking directly to the people collecting the data is absolutely invaluable, because then you find out why you get weird up and down spikes in the data sets. And don't fit on one time series. Terrible idea. Fit to multiple time series at the same time. So I'd just like to acknowledge the Wellcome Trust for the funding on this, NIHR. I probably should have put RAMP in there, I'm sorry. I'm a downstream beneficiary of RAMP, because I steal all Matt Keeling's modelling ideas and apply them to Kenya. And a thank you to all the other people in the National Modelling Technical Committee in Kenya. So these are some of the institutions, mainly Kenyan institutions, but also CDC, WHO Africa, and other stakeholders. Okay, thank you for listening.
Well done. Thanks, Sam. I think we've got time for one question, if there's a question. Or you can choose whoever you want.
Ben?
Thanks, Sam. So, Ben Swallow, University of Glasgow. Just wanted to pick up on one of your final comments about the multiple time series aspect. And one of the challenges there is there are often non-independence between multiple time series, and they can be measured on different scales or with different biases. I just wondered if you had any comments on how you go about dealing with those sorts of issues when you've got multiple time series.
So the nice thing in our particular case is it's reasonable to treat the PCR positives and the seropositives as independent, because they're basically sampled at different times and different sort of sample sizes. In general, it's like any stats, right? You have to imagine what the mechanistic process of that data being collected is. And if you believe that the same person is getting collected twice, you can put that into a model. You just need to be aware that that is a statistical issue.
Great, thanks. Thanks, Sam, again. So from my understanding, our next speaker is online. Is that right? I can't... Oh, she's there. Great. Hi, Kate. So Kate Mitchell holds a Wellcome Trust Fellowship at Imperial College, looking at socioeconomic status and infection risk. She previously did work on human schistosomiasis and also work in the clinical trials as part of the HIV prevention network. Everything okay, Kate? Are you happy to start? Great.
Yeah.
Okay, great. Over to you.
Thanks, Ellen. Yes. So first of all, apologies for not being there in person this morning. I hope to be, but unfortunately I tested positive for COVID yesterday, so I'm keeping my distance. But today I'm going to be talking about some work I did in 2020 when I was working for the HIV Prevention Trials Network, modelling the impact of COVID-related disruptions on HIV in the United States. So in the US, there's very high HIV incidence among gay, bisexual and other men who have sex with men, or MSM, with particularly high incidence among younger MSM and among Black MSM. And the US has quite an ambitious initiative to end the HIV epidemic, and they're aiming to reduce the number of new HIV infections by 2030 by at least 90% compared to 2017. And they've got this multi-pronged approach for doing that. So they're aiming to improve HIV diagnosis through HIV testing, to improve antiretroviral therapy or ART use, and viral suppression among those who are using ART, and also by improving prevention for HIV. And that includes HIV pre-exposure prophylaxis, or PrEP, which involves giving antiretroviral medicines to people who don't have HIV to reduce their risk of contracting it. During the first wave of the COVID-19 pandemic in the US, so in around April and May 2020, MSM in the US reported having similar or fewer numbers of sexual partners compared with prior to the pandemic. They also reported having reduced access to HIV testing, reduced access to HIV care, which includes treatment services, and reduced use of pre-exposure prophylaxis. So our aim was to quantify the potential impact of COVID-19 and those disruptions resulting from COVID-19 on HIV incidence and HIV-related mortality among men who have sex with men in the United States. We used a model that we'd previously developed for our work with the HIV Prevention Trials Network. We developed it for some trials that were going on in the States. So it's a deterministic compartmental HIV transmission model, modelling HIV transmission among MSM populations in the US. The model I used for this particular analysis was parameterised to the MSM population and their epidemic in Baltimore in Maryland. The model is stratified by age and race, and it includes a lot of detail about HIV testing, treatment, viral suppression, and PrEP use. And the model had previously been calibrated to data for MSM in Baltimore, and the data we calibrated to included HIV prevalence by age and race, ART coverage and viral suppression by race, and overall levels of PrEP use. In the calibration process, we identified 169 different model fits, different combinations of parameters that were consistent with that calibration data, and we used all of those parameter combinations for the analysis. So we modelled a number of different disruptions that we were aware of based on the data that was available at the time. So the data all came from the first wave, again, of the COVID pandemic in the States. It was all collected in April and May of 2020. And the data came from a number of different online surveys that had been done of MSM across the US. We also had additional data on PrEP use from a clinic in Boston. So we modelled disruptions to HIV testing, to ART treatment initiations, to viral suppression among those on treatment, disruptions to PrEP initiations and adherence, HIV testing among those who are using PrEP, and disruptions to condom use and partner numbers. This second column here shows overall reductions that we modelled based on those data sources. I haven't shown it, but we also took into account any differences in the data by age and race. Those quite important factors were incorporated. I'm just showing here the overall reduction. Note for partner numbers, we looked at some different scenarios. So we looked at no change in partner numbers. We also looked at scenarios with 25 or 50% fewer partners, and that was based on those different surveys suggesting different things about people's behaviour. After doing that main scenario based on the data, we also did some sensitivity analysis looking at different magnitudes of disruption, sort of pre-specified ranges that we looked at, quite large disruptions as well, just to see what would happen if there were really big disruptions in these different parameters. We also did a sensitivity analysis around the duration of the disruptions. We didn't know at the time how long those disruptions were going to last. So in the main scenario, we looked at 6-month duration. In sensitivity analysis, we also looked at 3 and 12 months. And the outcomes from the analysis were, first of all, a relative change in cumulative new HIV infections, and then a relative change in cumulative HIV-related deaths compared to a scenario with no COVID-related disruptions. And those outcomes were measured over 1 and 5 years from the start of the pandemic. So the results, first of all, I'm showing that the main scenarios, these data-driven disruptions based on the available data we had, assuming the disruptions last for 6 months. This plot on the left shows the effect on new HIV infections. And at the top of the graph, I'm showing the effect of each of those disruptions modelled individually. So we can see that reductions in partner numbers at the top. If we assume there was no disruptions to any of the rest of HIV care and testing, but there were reductions in partner numbers, we estimated that you would see reductions in new HIV infections. So, for example, a 25% reduction in partner numbers, we estimated would lead to 12% fewer new HIV infections over 1 year, and about 3% fewer infections over 5 years. On the other hand, a 10% reduction in viral suppression, in line with the survey data, would give us the biggest increase in new HIV infections. So we estimated you'd see a 6.5% increase in new HIV infections over 1 year, 1.5% increase over 5 years. And those other disruptions to HIV testing and PrEP and condom use each had smaller impacts, going to lead to a slight increase in new HIV infections. At the bottom of the plot, when we look at combined disruptions, so first of all of those disruptions together, but with no change in partner numbers, we estimated that you'd get about 1.5% more new HIV infections over 1 year, about 3.5% more over 5 years. But that increase in HIV infections that you get from all those different disruptions to HIV testing and care would be completely offset by 25% or greater reduction in partner numbers, where we estimate you can see no change in infections or even a reduction if there were reductions in partner numbers. Now showing the effect on HIV-related deaths on the right for those same disruptions. And here we see that a reduction in ART initiation, so people starting treatment, and particularly a reduction in viral suppression among those on treatment, would lead to the biggest impacts on HIV-related deaths. So we estimate with that 10% reduction in viral suppression, again, you'd get 9.5% fewer HIV-related deaths over the following year, 2% fewer over the following 5 years, while disruptions to partner numbers or HIV testing and so on would give very small impacts on mortality over that time frame. Looking again at the impact of those combined disruptions, again with no reduction in partner numbers, there's disruptions for everything else, we estimate it would give you about an 11% increase in HIV-related deaths over the first year and about 3% over the following 5 years. And unlike what we saw for HIV infections, including reductions in partner numbers, even quite substantial reductions, did not offset that impact on HIV-related deaths, which would remain quite substantial. Just to briefly talk about what we found in our sensitivity analysis. So first of all, varying the magnitude of the disruption to see which factors would have a substantial effect. We found, as we already knew, that sort of reductions in partner numbers and reductions in viral suppression would have a really big effect. The only other thing that we found would really have a big effect on new HIV infections on its own would be a reduction in condom use of 25% or more, which was not what was reported. MSM reported as still having quite high condom use in actuality. But even complete cessation of HIV testing and initiation would have quite a small impact on new HIV infections. Really for HIV-related deaths, again, it was as we'd already seen, reductions in ART initiation or viral suppression that were really predicted to have a big impact here over sort of 1 or 5 years. And for these key disruptions, so viral suppression, condom use, partner numbers, we thought the effects were proportional to the magnitude of the reduction. So if you doubled the reduction in them, you'd expect a doubling in impact. Similarly, when we tested the impact of varying the duration of the disruption, on the whole, that was proportional. So partner numbers, condom use, viral suppression, if you pulled the duration of the disruption, we tended to see a doubling in the effect on new HIV infections, shown here, and also on HIV-related mortality. ART initiations, it's not quite linear. When we measure the effect over 1 year, again, we're seeing that sort of doubling effect over a slightly longer evaluation period. In conclusion, we found that a reduction in viral suppression of 10% could have negative consequences for both HIV incidence and HIV-related mortality in the US. And any reductions in sexual partnerships could offset those increases in incidence, but not mortality. And so in practice, what we recommended was that maintaining access to antiretroviral therapy and adherence support for those on therapy really was important to minimise excess HIV-related mortality due to those COVID restrictions in the US, even if there were reductions in sexual partnerships happening alongside that. And to achieve that, practically maintaining access to treatment and adherence support, we recommended scaling up and evaluating telemedicine services and other delivery models for HIV treatments. In addition, a sort of triaging face-to-face support for those who really needed it as well. Just like to finish by thanking all of my co-authors on this work, thanking our funders, and thank you very much for listening.
Great, thanks Kate, well done for doing it while you've got COVID as well.
Thank you.
Do we have any questions in the audience? Yeah.
Hi, Ben Swallow, Glasgow. Thanks, Kate. That was a really, really interesting talk and some great work. I just wondered, one of the difficulties with these sorts of surveys is the proportion of the population that you miss, so those not engaging in regular testing or treatment. I just wondered, did you consider that in your model calibration at all, or in the sensitivity analysis that you've done? And if not, what sort of impact do you think that would have on the results if you incorporated those who aren't engaging?
So the base model, thanks. Yeah, the base model incorporates that. There's a proportion of people in there who aren't testing at all. And in the US, we see quite a lot of people who know their status, who have tested, but are not engaged in care. But that's partly to do with the sort of healthcare system and the way people can sort of drop out of it and fall through the gaps in terms of health insurance. So that's all taken into account. Yeah, then the surveys that we were using to estimate the disruptions due to COVID were all distributed online, so it wasn't necessarily people who were engaged in the system, and the people reporting varying levels of engagement in those surveys as well. Yeah, so we've done our best, I think, to take into account the people who are not in the system as well as those who are.
Question at the front.
Darren Austin, GSK. Thanks for the great talk. Could you comment on the relative insensitivity to PrEP compared with changing numbers of partners and condom use? Presumably it's down to the low usage at the moment, and would that change with time?
Yeah, that's a good question. So I was specifically modelling Baltimore here, where usage was relatively low. I haven't checked the latest numbers, but yeah, it was a fairly small proportion that were using PrEP, which just meant, yeah, compared to the transmission you've got from the larger HIV infected population, you'd see smaller effects there. But yes, I think if and as PrEP becomes more widespread, you would expect to see bigger effects from disruptions to it. Yeah.
One last question, Deirdre at the back.
Hi, Kate. Deirdre Hollingsworth at University of Oxford. Lovely study, thank you. I just wonder how much more recent evidence there is of the actual impact of COVID on HIV, maybe in other settings. How much do we know now?
Yeah, that's a good question. So I think a lot more data is now coming in. So in the US setting where I've been working, we've seen that some of those early sort of disruptions have sort of partially recovered But HIV testing, for example, there were big reductions all across the country early on, and it's recovered, but it's still not come back up to the levels it was, which is causing problems for estimating things like incidence, which tend to be based on diagnoses as well. In other areas, so I'm also aware in sub-Saharan Africa there were reductions in HIV testing, big reductions in voluntary medical male circumcision as well. We saw huge reductions in that. I haven't seen, yes, I can't remember the latest stage. I think those are partially recovered. On the other hand, certainly in the sub-Saharan African setting, I think maintaining people on treatments and keeping them virally suppressed was quite successful, which our model and many other models suggested would be, have the biggest immediate impact. So that's been a good news story there, I think.
Great. Thanks very much, Kate. Thanks for an excellent talk. If we can thank Kate again and hope you feel better. So next up, we've got a double act. We've got either of the people here. Oh, great. So it's Juliet Unwin and Alexandra Blenkinsop, both at Imperial and maybe also in Amsterdam. Juliet's previous work was on malaria, included targeted vaccination and looking at the impact of resistance against bed nets. And Alexandra worked on HIV elimination, I think, transmission. So you will set up?
Yes, great, thank you. Thank you for inviting Alex and me here to speak to you today. As I'm sure most of the people are aware in the audience, the World Health Organization has recently estimated that there are over 10 million excess deaths up until the end of 2021 all around the world. And as countries are beginning to relax their COVID restrictions, we found that there's a group of people whose lives will never be the same again after COVID-19. And these are the children who've lost care from parents and caregivers. This work began through our collaborator, Susan Hillis at CDC. She realised after working a lot on the HIV pandemic that when people die, they leave behind children. So she put together a group of experts with varying experience. Some of us, which Alex and I are part of, focused on the analytics, creating the estimates of the number of children who are affected. And then there are others who are more experts in helping children who have lost their parents and caregivers.
So we use the UNICEF definition of orphanhood, which is death of either or both parents. And we define primary caregivers as parents or grandparents who live with their grandchild without the parent of the child present. And we define secondary caregivers as grandparents or kin who live with their grandchildren and the parent of the child may be present. So our approach is based on methods which have previously been used to estimate children who are orphaned by AIDS. And to do this, we leverage three sources of data. So first, we use mortality data, and we use both COVID-19 reported deaths and excess deaths. And in this context, excess deaths are the number of deaths that occurred in excess of what would be expected in an equivalent period pre-pandemic. And we use excess mortality because we're interested in children who have lost a caregiver either as a direct or an indirect result of COVID-19. We also use fertility data, and where possible we try to use live birth counts and population data to estimate fertility rates directly. However, in some cases this wasn't available, and also we found that live birth data by father's characteristics is very hard to find, in which case we use survey data, which is representative of the population. And thirdly, we use household composition data, which is generally survey data which reports on intergenerational housing to estimate how many adults live with grandchildren for whom they may provide care. So we stratify this by the type of caregiver. So in order to estimate children orphaned, we first estimate the expected number of children that a man or woman of a given age would have had by the start of 2020 when the pandemic began, by using fertility rates for the preceding 17 years. Then we multiply this by the number of deaths that occurred in the equivalent age group. We next deduplicate for children who may have lost both parents by using published secondary attack rates and infection fatality ratios. To estimate grandparent caregiver loss, we use the household composition data and population data to estimate adults aged 60 to 85 who live with their grandchildren. And we multiply these proportions by the number of men and women in this age group who died throughout the pandemic. And the assumption that we make here is that each grandparent lives with at most one grandchild, because we just don't have better data in general on how many children are in the household. So this might lead to conservative estimates.
As simple as Alex makes the methodology, the main problem with our approach was data availability. So we wanted to get global estimates, so we wanted to know how many children there were across the whole world. But not every country in the world had age-segregated COVID deaths or excess deaths, and not every country has any record of fertility data. So we took an approach of developing a model to go from countries which did have data, which are the 21 countries shown on the slide, to calculate the number of orphans or children who've lost care in all the other countries in the world. We found that there was a strong relationship between the total fertility rate, which is along the bottom of the slide, on the image on your slide on the left, and we found that that was had a good relationship where we could predict using the ratio of children orphaned to deaths. So we fit a logistic model here, and originally we just fit one model to every country in the world, but we found that we were overestimating countries in Europe, so then we added a fixed effect, which is the red line shown. The image on the right shows our observed versus predicted, and we felt that we got a good fit to our data. Iran is shown in red because we had limited fertility data, so we didn't use this in our model, but we just used it to predict. We ended up with some quite stark numbers of children who are affected, and up until the beginning of May, we predicted that 10.5 million children across the world are affected. These children are kind of more in Southeast Asian countries and African countries, and with, I think, the largest numbers being in India, partially due to the large population there. Another piece of analysis that was interesting was that we found that nearly two-thirds of the children who were affected were adolescents, and aged 10 to 17. And this makes sense because, as previous talks have also mentioned, the older generation are more at risk, and older people tend to have older children. We also found that nearly 3/4 of children lost a father rather than a mother. This is due to the fact that more men have died globally of COVID than women. These numbers are purely based on that. And we find that the age of the child and the gender of the parents really matter in terms of the policy response that we're going to talk about a little bit later.
So the US has experienced very high mortality as a result of the pandemic and has recently surpassed 1 million reported COVID-19 deaths. So we carried out a US-specific analysis at a higher resolution using data that was available by state and also by race and ethnicity. We also quantified uncertainty using bootstrap sampling of the raw mortality and fertility data. We estimate that by the end of March this year, over 200,000 children had lost a parent, one or both parents as a result of the pandemic, and over 260,000 children had lost a primary or secondary caregiver. We find spatial variation with generally states with the largest population sizes most heavily burdened. So non-Hispanic white children experience the highest losses in absolute terms. However, relative to their population size, we found evidence of racial and ethnic disparities. So when we calculate rates of lost caregivers to account for population size, we estimate that Hispanic children were 1.5 times elevated risk of losing a caregiver compared to white children. Black children had twice the risk, and American Indian and Alaska Native children had more than 3 times the risk. So we attribute these disparities to differences in fertility rates between different race and ethnicities, and also to differences in the age composition, the age profile of COVID-19 associated mortality. So we've developed some tools to report up-to-date estimates as data becomes available. So we report estimates for all countries globally in near real time. And for the US, we update estimates quarterly as the mortality data becomes available.
So far we've kind of left you with a quite sad picture of all these children who have lost care, but there are some things evidence-based that we can do to help these children. This isn't actually our area of expertise, but I hate to give a talk and leave it on such a sad note. To help children reach their full potential, we suggest that there are 3 things that you can do. First is prevent COVID-19 deaths of caregivers by treatment, equitable vaccines. The second is to prepare family-based support and avoid institutionalization. When people think of orphans, maybe immediately they jump to orphanages, and evidence shows that these are not the best places for children to be brought up. Helping support family-based or care is evidentially better. Finally, you can protect children from poverty, adversity and violence. Children who've lost caregivers are more at risk of violence, more at risk of sexual abuse and loss of education. And these really vary, as I was saying earlier, on the age of the child. A small child needs very hands-on care, which is very different from a 17-year-old who's lost their parents. So it was really important that we found out more about the children. Another really interesting piece of this work was actually the policy engagement side and working really closely with policy makers. We started off in a place where children who had lost caregivers wasn't on anyone's agenda. There's been lots of articles since we started doing this work, especially in the US, and 2 countries have made a commitment to children who've lost care. The first is in Peru, and the second is the US. And Biden mentioned this research in his COVID summit earlier in the year, raising awareness of all these children who need our help. We have ongoing work in extending analyses like Alex's on the USA to Brazil and Colombia, and we're trying to work really closely with the policymakers to make a difference for these children. Just want to end on some thanks, especially to the CDC and the Imperial College COVID response team for funding Alex and the MRC Centre. And just finally, a few references.
Great, thanks very much. Do we have any questions, live questions in the audience? One at the back. I mean, you can pick people you want to.
Thank you very much. Hi, I'm Joe. I'm a researcher at the United Nations and Durham University. So just a question. So you mentioned the ethnic disparities that you saw, and I was wondering if you've also managed to segregate this by maybe household structure and composition, because you said you used some of that data earlier. We know that particularly in the UK, different ethnicities have different household structures. They often live in multi-generational households, and this is also mirrored in other countries around the world. So are you able to disaggregate by that? Because or maybe you can say more about that. Thanks.
Yes, so when we consider grandparent caregivers, we kind of substratify these as those who live with or without the parents present. And in the US, we were actually even able to stratify this further because the data that was available was really good quality. So actually, we do report in a published manuscript, we have the makeup of the difference of these by race and ethnicities, and we do, as you're quite right, that the household structure is quite different. Grandparents play a much larger role in care and tend to live more in the home in non-white families. So as a result, the impact of a death among someone in the strata is obviously likely to have a larger impact.
Hi, Joe Hilton. I'm postdoc at Warwick. I think this is a very sort of related question to the one that was just asked. Have you thought at all about whether, if there is a link between household size and rates of orphanhood, or even just baseline mortality rates, what that might say about the epidemiology of how overcrowding or even dose response might impact mortality?
Yeah, I mean, the focus of the paper wasn't really to unpack differences in mortality rates by race and ethnicity, but of course, if you're trying to understand why we see these disparities emerging, it's quite important to understand why we observe these differences in mortality rates. And particularly something we noticed was that among non-white populations, we saw mortality rates were higher among younger age groups. So what this may be associated with size of household, but also could be connected to the kinds of jobs that people are working and number of contacts. So it's a complicated topic. I think there are probably other papers that have looked more into understanding differences in mortality rates by race and ethnicity in the US.
Great, thanks very much. I think that's all we've got time for, but please find them at lunch and ask them some more questions. Thank you again. Next up, we've got Rob Challen from the University of Bristol. There's quite a lot to say about Rob. He started life as a hospital paediatrician. He's also been head of health informatics at the BMJ, started a consultancy company, and when I first met Rob at the beginning of the pandemic, he was in the middle of his PhD using natural language processing to analyse the free text and electronic patient data. But he paused that to work on COVID, and he's been one of the people who's contributed to SPI-M, estimating the reproduction number every week for, 18 months? And he also did some of the first estimates of the severity of new variants of SARS-CoV-2 in the UK, and I think that's what he's going to talk about.
Thank you, Ellen. So my name is Rob Challen, as Ellen just said, and my role at Exeter really was not particularly involved in infectious diseases, and so I started with a bit of a learning curve during the pandemic and feeding my work into SPI-M. I'm going to talk about some of the work that I did during that time, and then this really harks back to the beginning of, or the sort of first wave of the pandemic, second wave of the pandemic. The impact of genomics on the pandemic has been incredible and given us a real insight into the different pandemic waves. But one of the issues with the genomics is because it takes quite a long time to process the samples, the delay processing limits the usefulness of that information in certain situations, especially when the situation's evolving rapidly. We have another piece of information that we used, this TACPath PCR test, which detects, which is part of the routine testing, routine S-gene testing, and detects 3 targets that are amplified to give you a positive COVID test. If all three were amplified, that gave you a triple positive or S-gene positive test, and that was what you saw in the wild type. But in some situations, we only saw 2 out of 3 of those because of a deletion in one of the sequences in the S-gene, and that gave you an S-gene negative test. And that's the thing that we've been looking at and following. One of the things about this, and the reason that it's useful, is it has a very quick turnaround, and it was done at scale. So the sort of background to this was all really about the alpha variant in December 2020. So saw the alpha variant being identified in Kent, and then spreading rapidly throughout the UK. And at the same time, and that was sort of identified through genomics and routine epidemiology, but we also saw this S gene signal spreading from the southeast throughout the UK. At the same time, we started to see a few sequences come through COG UK for the beta variant from South Africa and the P1 variant from Brazil. Now, these ones, so the alpha variant we detected because it had this S gene dropout feature, but the beta and gamma variants didn't. So there were different signals. And about the same time, we were sort of seeing vaccination starting, just for context. Sort of in December, so whilst just before the second lockdown in the UK, there were samples taken in India and Maharashtra, which had a different pattern, and these cases started to rise in February 2021, and really then exploded rapidly throughout March and April. And that was due to this Delta variant, or B16172, and that Delta variant didn't have the deletion that's associated with S gene dropout, so it was also an S gene positive. So really that gave us the opportunity to look for emergence of the Delta variant in the UK using the S gene status test. So on the red curves here, we're seeing this sort of stable situation in March time towards the end of the second lockdown, where S gene positive cases, S gene negative cases, alpha cases, were declining gradually over the period of the lockdown, and the S gene positive cases, which were mostly at that stage composed of pre-alpha wild type, with one or two South African and Brazilian variants mixed in. Those were declining quicker. So we looked to see whether there was any kind of any obvious evidence of any outbreaks in the S gene signal and in the sequencing signal. And what we found is that there were, sort of over March to May, there were various different places where we saw clusters of S gene tests coming out. These are kind of spread out around the country, but some of them were, and so that's the central panel, sorry. Some of them on the left-hand panel were associated with places that we also saw sequences of the Delta variant coming up. And then others were on the right-hand panel, which were more to do with other variants. So we kind of monitoring these areas and investigated them a bit more closely. So these are epidemic curves which show you some of the case numbers. So small case numbers we're talking about in these little areas. And in the different areas, we saw different patterns. So in East London, for example, there was a real mix of different variants, which were all S gene positive, but included the South African variant, Brazilian variant, and a bit of the India variant. But if we focus on Bolton, we saw a slightly different pattern where we didn't have the sequencing information. There was this rapid rise in cases, in S+ cases. And it really looked very suspicious. And that was maybe there were other softer signs that this might be to do with the Delta variant, one of which was the ethnicity of these cases, which was largely based in the Asian population. So, I mean, at this point, we kind of, without sequencing results, we had an opportunity really to try and intervene. And with contact tracing and those kind of measures, but you know, over the next few weeks, we saw that this pattern of specific to Bolton was becoming slightly more widespread, and really you could see the case numbers in the blue here, the S positive case numbers start to grow exponentially. They still couldn't really see that over the declining alpha cases in red in the national case numbers, and it looked fairly stable nationally. But underneath that, there was this rapid growth. And once those sequences started to come back, you could see clearly that the variant that was driving all of this was Delta. We wanted to know for the predictive models what the transmission advantage of Delta was. Now, with these graphs, you could sort of see in the top left here for Bolton, it's particularly clearest to Bolton. In early January, the S-negative cases were declining gradually, the alpha cases, and the S-positive cases were declining quicker. Declining quicker. And then at some point in mid-March, that pattern switched around. So the S-positive cases we just saw in the other graph growing faster, and whilst the S-negative cases still continuing to decline. When we sort of looked around the different areas, we couldn't get a consistent pattern, really. Blackburn and Bedford were giving us the most positive signals, but some of the other areas, the difference in growth rate wasn't really that clear. And later on, when we got the sequencing result back, that sort of became more clear, as you see in places like East London. The sort of shorter, smaller growth rate difference is potentially because the composition of the S-positive signal was mixed with lots of South African, Brazilian, and a little bit of Delta variant. So we couldn't get a sort of clear transmission advantage estimate out of that until a bit later, when we started to get more widespread across the country. So by late June 2021, the number of Delta cases had overtaken the declining alpha cases. The blue line there sort of taking over, and everything, all of those were coming back. Well, the vast majority of those were coming back sequenced as Delta now. So that gave us a little bit of a window in the data during which, in panel C here, you can sort of see that there's both positive and negative S gene cases co-circulating, being alpha and delta. In the middle panel, you can see that those S positive cases were all delta, more or less. And then in the top panel, you see a nice consistent difference between the growth rates of the two signals. So we got to estimate some effective reproduction number ratios out of those, and that helped us to sort of calculate a transmission advantage for Delta. It was still slightly different in different regions, which was quite difficult to be clear why that was. Some of that has to do with the fact that the S gene tests were not really as done consistently across the country. Sort of another possible reason might be the different ages and the different immunity in the different ages and the different locations, as London had probably the most impact from just the alpha wave just beforehand. Well, one of the things that sort of we can look at now and sort of retrospectively, we know that Delta was actually as we were describing it then, was actually a mixture of different lineages that we've subsequently identified. The one in Bolton was actually reclassified as AY4, whereas some of the other areas had different variants. And you can see that over May to September, AY4 was the one that really took over. So at least some of the difference that we saw in those regional estimates of the transmission advantage was due to the fact that there were what we call Delta initially were various sublineages. But we wouldn't have been able to differentiate those by their S gene status because they all had the same. just about time to just say, you know, the S gene story kind of continued. Omicron came along, that was S gene negative, and by that stage we had S gene positive Delta pretty much throughout the country, so we were able to yet again use it the other way around this time to sort of look at the Omicron outbreak with a set of very similar analysis. Just in conclusion really, S-gene has been a useful proxy for all the different major variants. It's flipped backwards and forwards throughout the pandemic, and really interestingly now the BA4, BA5 variants of Omicron are S positive, so we might, if we had the data, we might be able to, if we were testing and doing S-gene tests, we might be able to see it. We could have used the S-gene signal to inform contact tracing, but it gave us a little bit of a window earlier where we could have done that before the genomic testing was available. And you know, just the last point there is we had to prove beyond doubt that Delta was a more transmissible and not due to, and the signals we weren't seeing was not due to imports before public health interventions occurred, and it's possible that it would be maybe sensible to expect that Delta was there, expect that it was more transmissible, intervene and try and prove that it's not. This has been a lot of people involved in this kind of work, and it's a bit of a rapid summary, so thanks to everyone that's been involved. Yes, thank you.
Hold on. I think we've got a minute for questions. Any preferences over there?
Graham Ackland from Edinburgh. Why is it that when a new variant comes in, the old variant starts to decline even more quickly? What's the interference between them?
Yeah, I don't know. It's a kind of fascinating. There is like a moment where the old variant collapses suddenly, and I don't have a good answer, don't have a modelled answer for this, but my sense is that the in-host competition means that people that are co-infected with old and new variants almost always will end up with the most transmissible variant becoming the key one in that person. And that actually, surprisingly, the people that mix a lot are at higher risk of getting co-infected and therefore passing that on to a large amount of people. So I think there's a sort of pruning of the epidemic tree that happens, and the new variant selectively takes out those that do the most damage. That is my guess.
Yeah. Question back there.
Hi, thanks very much. I'm Pablo from Imperial College. Really fascinating topic, definitely. And for us in the Imperial real-time modeling team and some of the other teams that collaborated for the real-time modeling for SPI-M, definitely having had that incredible resource of looking at just S-gene data in real time to better inform our estimates of transmission advantage, reproduction number, and so on was really paramount. I was wondering what your perspective is, given that you spend quite a lot of hours looking at this data for a long time as well. What your perspective is going forward in terms of preparedness. As we know, and all the talks is being highlighted, how important having the right data is for all this sort of analysis. So what sort of essential resources would you like to see in data streams going forward, so we could do this analysis in not a reactive manner, but
yeah. I
Thank
think one of my things I didn't say was one of my biggest wishes would be a standard data set across all 4 nations. That would have been the most useful thing. I spent a lot of time trying to massage data. You only saw stuff from England today because it was, became too tricky to do all that stuff. The S-gene data was done in Scotland, was done in Wales, but it came in a different format, so I didn't use it for this analysis. I think, you know, discovering something like the S gene signal, you know, it's fortuitous, really, but for the next pandemic, who knows what that might be. I don't know whether the technology exists in the PCR world to design for highly mutagenic targets and to try and, you know, preempt that. But it strikes me that that is certainly something that's worth planning for.
Great, thanks. Thanks, Rob. Our next speaker might be able to say, yeah, well done. Our next speaker can probably tell us whether Rob's guess about within-host competition between strains is correct or not. She did her PhD in astronomy. She's originally an astronomer, but now does within-host modelling, and she's worked on tuberculosis and antimicrobial resistance, and then pivoted to work on SARS-CoV-2, and she got a RAMP Early Career Investigator Award for her work. So great, over to you, Ruth.
Thanks. So yes, Ruth Bonus, now based at the University of Bath. When the pandemic started, I was still a research fellow in St Andrews, but got a lectureship and moved during the pandemic. So yeah, I'm going to tell you a bit about the within-host modelling that myself and my postdoc Chris Rowlett have been doing. So as you know, much of the modelling for the COVID pandemic has been at a between-host scale, but my models typically look at what happens within the body, looking at the transmission, the spread of the disease within the host, with the aim for understanding more about the pathogen, also working with virologists and bacteriologists to inform their lab experiments, and ultimately trying to look at different treatment strategies in the future. So we've constructed a spatial model. It's a hybrid multi-scale individual or agent-based model. And just to describe the setup, it's a 2D model. So we have this uniform grid of long epithelial cells. Distributed randomly are a collection of cross-sections of blood vessels. And we also, we seed the monolayer with a user-defined number of virions, which we provide via a multiplicity of infections, so the MOI. And we also have a number of resident tissue resident immune cells in the system. So just a quick schematic of the model. So I mentioned we have these epithelial cells, we have viral entry and replication models within that, and then the macrophages. We also have a collection of cytokines, which I'll talk a bit more about in a second. There's obviously a lot here. There's a lot of immunology and virology. I'm going to skirt over a lot of it, but if you're interested, I'll be here for the rest of the day. And also I'll give you a link to preprint on this work later. So for the extracellular virus, we model this as a continuous field via a reaction diffusion equation. So V here is the concentration of virions in millimeter squared. We then have a diffusion term. I don't know if you can see a pointer, I'll just use this. So we've got diffusion term. The SV here is the source of virions from exocytosed virions following replication. The UV is the uptake of the virus as it binds to the ACE2 receptors, the epithelial cells, and then we have a decay. So the cytokines and chemokines. So we know that elevated levels of many pro- and anti-inflammatory molecules can correlate with severe COVID-19. There's a whole host of different cytokines we could consider, but we've chosen to focus on this subset. So we have type 1 interferon in the system. We know that this expresses genes that can inhibit the viral entry and replication. It's also been linked to genetic susceptibility, and also a delay in the type 1 interferon correlates quite well with severe disease. We have interleukins in the system, so IL-6 and IL-10 because of their inflammation processes. And then we also have a generic mononuclear phagocyte chemokine, which helps to direct the macrophages to the apoptotic cells. And similar to the equation I showed you previously, we model these as continuous fields via reaction diffusion equations. So for the viral entry and replication, so in our grid of epithelial cells, each epithelial cell has its own pathway model, basically, so all of the parameters can vary, so they're not all the same. We base these models on models that have been described by the Physicell group. So there's a group out in the States, if you're not familiar with Paul Macklin's group there, who've also been working on within-host models. So we use their model and then modify it slightly to include cytokine inhibition of the viral entry and replication. And the epithelial cells can exist in 5 states. So it can be a healthy epithelial cell, an infected but not yet virus-producing, an infectious, which is virus-producing, and then apoptotic or removed, where that epithelial cell is then removed and we have a blank space on the grid. So the figure here that I'm showing is from our testing phase of the model. This is with one virion placed in a central epithelial cell and allowed to spread. It has no immune cells in this simulation, and something to note here is that for all of the epithelial cells in this simulation, we have the same number of ACE2 receptors, and that's why you see this uniform spread. So you can see the blue dots in this simulation show the number of epithelial cells infected or infectious, and you can see this boundary layer of infected cells in these simulations, which is quite a typical feature. So the immune cells, so when we started this code, we sort of threw everything at it. So the code supports macrophages, monocytes, neutrophils, and natural killer cells. But as we were doing the simulations, it was too complex, and actually trying to find out anything that was going on was too hard. So in collaboration with the virologists on the project, we scaled it right back and focused on macrophages, because all of the data was suggesting that they're the immune cells that really are important with SARS-CoV-2. So we allow, so similar to a lot of agent-based models for this kind of thing, we have immune cells can migrate from cell to cell. Only one cell can be on a grid cell at one time. And the movement of the resting macrophages is in a pseudo random fashion, whereas the activated ones move chemotactically. They're recruited through the blood vessels, and they recruit and activate via viral load and combination of viral load and cytokine levels. So some results then. So one of the first things that we wanted to look at, as we know that during the pandemic, a lot of healthcare workers were common, they were the common people to go on to have severe disease, and this was hypothesized, the hypothesis behind that was that they were close to the patients and inhaling this big initial viral load. So we wanted to try and simulate and try and understand a bit more about what's going on there. So we ran 3 different sets of simulations with MOIs increasing from 0.001 up to 0.1. And you can see here, as we increased the initial viral deposition, we see this higher spread, this bigger spread, and we see this in the cell numbers as well, so higher infectious, apoptotic, and removed epithelial cells. This correlates with increase in the interferon and the cytokines, and also the generic chemokine levels. Something sort of unexpected came up here, which was quite interesting, so that we saw on the left-hand plot here, you see the intracellular viral load, and you see this local maximum that occurred, and this local maximum appeared earlier in the simulation as we increased the MOI. And we hypothesized, I won't go into the reasons why, due to time restraints, but we hypothesized that this is due to an increased interferon levels. It correlated at the same time when we looked, there was a peak in that value, and there didn't seem to be other factors that it could have been. We saw no evidence of that. And the virologists on the project are really interested in this, and I've been trying to simulate they're trying to see if there's anything there in the lab, and experiments are ongoing with that. Okay, so another hallmark feature in severe COVID-19 patients is this. So in the immunological studies is this delayed type 1 interferon secretion. So again, we looked at delaying this value, and we find that as we delay the response from left to right on the figures, you see a larger spread of the virions. And again, this is shown in the cell numbers as well. For the longest secretion delay, we see reduced levels of interferon, which is expected. This also correlates with higher IL-6 values. And one thing to note here is that for the highest MOI here, sorry, not MOI, the highest delay, we didn't see that maximum appear in the intracellular load, so further supporting the idea that it is the interferon causing that feature. We then looked at increasing the secretion rate of the interferon. As we increase this secretion rate, we see on the left-hand plot of the infectious epithelial cells with the different secretion values. You can see the dot-dashed line is the highest, and you can see a clear decrease in the spread of infection. And one last thing to talk about here, we played around quite a bit with the parameters for the macrophages. The activation of the macrophage, so changing the half-max value, resulted in these plots. So for the largest activation rate, we saw a huge influx in resting macrophages. We do see in the middle plot there that the infection also reduces as we increase this half-max value, and a small decrease in the IL-6 values. Taking all things into account, we think that there's some sort of feedback between the apoptotic cells and the recruitment of macrophages. Basically, as more of the macrophages and epithelial cells become apoptotic, they secrete this generic chemokine, which then recruits more macrophages, and we think that that's what's happening here. And this could be quite important in severe patients in causing tissue damage. So many things that we want to do to extend this work. Obviously, there's a lot of immunology that we want to add in. The parameter estimation, I should say, it's been a long time developing this model because we've been going with the data. So as the lab experiments have been progressing and we've been getting a bit more certain with our parameter values, we've been adding more in, obviously extensive sensitivity and certainty analysis as well, but there's more and more data being collected. Also with new variants, so for example the Omicron variant seems to display an altered tissue tropism, so being able to look at that would be quite interesting. And ultimately these two things that we want to do with this. One is that we want to be able to use the model to look at certain subsets of patients and see why they're more prone to severe disease. And also trying to link this with a between host model. So if we can understand what goes on more in the body and how a person is more infectious during the course of its disease, that person's disease, and then link it to transmission, that would be obviously very useful. Just a quick note, we've submitted this to the Royal Society of Open Science not long ago. There's preprint there, and the data is available on GitHub if anyone's interested. And thank you very much, first of all, to my postdoc, Chris, who's done the modelling here. The collaborators on the project, particularly Mark Chaplin up in St Andrews, and then the virologist and the clinicians involved, we wouldn't have been able to do it without them. And of course my funders, and I should say that I've recently, Chris and I have been awarded a RAMP Outreach Innovation Award, and we'll be hopefully creating some resources soon. So, thank you.
Great. Time for one question. Sam? Oh, right, at the front here.
Yeah, quick question. I was really interested in your results on dose dependence. Yeah, so the timeline, things still kept on going up and we hadn't hit a plateau. Was the dose dependence, did it just mean earlier or did it mean fundamentally more?
Which dose dependent? Sorry.
I think it was the initial inoculation levels. You looked on like a log scale.
Sure. So that's a good question. If I could go back on my slide, I don't know. It does seem to tail off, which is why we stopped the simulations there. But I think we only wanted to look at the sort of that first bit, but it would be interesting to see if there was any more features.
Cheers.
Great, well done. Thanks very much. Let's thank Ruth again. Our next speaker is Laura Guzman-Rincon from the University of Warwick. She's got 2 degrees in maths and physics, is that right?
Yeah.
Oh, right, very good. She moved to Warwick in 2015, and during the pandemic she's been part of the COVID-19 response at Warwick, particularly educating everyone in Gaussian processes, and I think that's what she's going to talk about today.
Good. Thank you. Good. So, my name is Laura Guzman, and today I'm going to talk about a project that we worked on with our team in Warwick, and this is a project part of Juniper Consortium, and it's all about estimation of growth rate and the applications that you can do in positive cases of COVID in England. And so just to motivate, the reason of the work is that when you want to talk about how the pandemic is going, then you usually get these kind of pictures where you have the snapshot of how many cases per day do you have, like in the picture in the left. And for example, also how this data was taken, that for example in the right you can have the number of tests reported. So from this kind of picture, you want to know something else. You want to understand the dynamic of the pandemic beyond the picture of how cases are. And for that, there are many statistics that have been proposed, that have been used during the pandemic. One of them is a very common one, reproduction number. So here I'm showing you just a snapshot of the reproduction number in the left, in a month randomly selected during the pandemic per region in England. And then with this kind of information, you can understand what is the infectiousness potential of the pandemic. But then there is another set of statistics that you can use for this purpose. And then that's why here I'm focusing on growth rates. So in the right-hand side of the picture, I have an example, again, from a random month during the pandemic that I took a snapshot of the growth rate estimation. And then this is different than the reproduction number in the sense that here you measure it, if it's greater than 0, you know that the epidemic is growing, and if it's lower than 0, you know it's decreasing. But then, of course, there is a discussion of which methods do you use better than others, and I think both of them measure different things, and they have advantages and disadvantages. And for that reason, a lot of groups were reporting reproduction numbers, and others started to do growth rates. And there is a nice discussion in a recently published paper that I'm citing here, where the question is, are growth rates better or not? And I think both of them have advantages and disadvantages. So here I'm going to focus only on the growth rate. And for that, we made this work that it's a Bayesian statistical model where we want to estimate growth rates. And it had some advantages because it was flexible, fast, and easy to use. So fast, not only on running it, but also on coding it and preparing it because you are in an emergency. And also, you can incorporate certain types of data. You have cases, you have testing data as well if you want to get more information about the growth rates. Of course, the model has caveats and limitations, especially because you are trusting the data you're using, and there are some other limitations based in the fact that this is a statistical model, not a mechanistic model, and it does not have any epidemiological assumptions in it. It's an advantage but a disadvantage as well. So all of work was based on this work. I'm not going to talk about the details of the development, so I'm posting here the preprint. But what I'm going to talk about is how this helped us to work in some applications and to shape the way you understand what's going on in the pandemic. So one of the good things of these kind of models is that you can use it in several types of groups of people. So for example, for starting, I can show you what happens if you look at the England as a whole. And in this example, I'm showing you in the top the number of cases in a period of almost 2 years. And I'm showing to you, each point is showing what is the proportion of positives, meaning the number of positives divided by the number of tests that gave that number. And then with this information, if you input in these kind of models, then you can get your estimated growth rate with certain uncertainty. And then you can use this information to try to understand what the dynamics are of the England as a whole are. So just before keep going, I just want to give some details of why I put these lines in here. So, for example, if you look at the green lines, they are located towards the time where we had lockdowns. Then we have some time when you have opening, easing restrictions in yellow. And you also have the time when Alpha came, Delta came, and Omicron came. So then you can start understanding how these different things relate to each other. That is a very difficult question. So just to understand this from this two-dimensional point of view, we tend to report things as these figures here. So I'm going to focus on the one in the left-hand side. So you have in the x-axis the growth rate, and in the y-axis you have the proportion of positives. And then I'm showing in the bigger square the location at a certain date. So in this case it's the 6th of January, where we were in the lockdown, in one of the lockdowns. So here is where we are. But then you can understand that this is a dynamic process, and then you have some past that was leading to this behavior. And seeing these dynamics in this kind of picture were really helpful to understand what was going on exactly before and where is this going towards. And then here in the right-hand side, I have a similar picture, but that was in July 2021. And then there was an ease on restrictions, and you can see that there was a negative growth rate at this time. I'm in the left-hand side of the zero. But then we were going towards a positive growth rate. So this is a way of seeing these dynamics, but again, I'm showing you only England, and then we wanted to do this in a lower scale. So we started doing it for local authorities to check weekly what was going on. And again, I have this picture as the one I showed you before, but then instead of having a national picture, we got one of these curves per local authority. And here I'm showing you the 317 mean of these estimations per local authority, and you have different dynamics. Sometimes you have more heterogeneous behavior, sometimes you have a more coherent behavior in the whole country, sometimes you have some problems with data sources. So if you don't adjust your data, that we did adjust it, you will get these kind of peaks that are misleading. And then, just to show you these same dynamics I showed you before, but now per local authority, I'm going to focus in 3 times in this timeline. So one of these times was, again, in January 2021, when we were in this lockdown, and you see this coherent trend. The second one I'm going to focus on is when Delta was starting, is roughly this time. And the other one is when we were easing restrictions, that is around this time. So first, in the time when we were in the lockdown, so in the left-hand side, you have the map of proportion of cases. And again, you see there is high proportion in certain parts and lower in others. But if you look at the growth rate, then you see that this is going towards negative growth rate. And now, if I show you the same picture I did before in a two-dimensional plot, then we have that all local authorities with having a trend to go towards the negative growth rate region. So this is useful to understand that even though you have this picture here that you see there is a snapshot of things going on, then you know that the dynamics are going coherently alongside the whole country. And then I can do the same exercise, but by the time that Delta was here. So this picture was 7 days later than the Public Health in England declared the Delta as a variant of concern. So we have, again, a snapshot of how the proportions are. And then in the center, we have the growth rates. So To understand what was going on, you can look at the plot in the right-hand side, and then you start seeing that there is some heterogeneity in the behavior. And then, although a lot of things are going on, some regions are growing, some regions are decreasing in growth rate, you have some locations that are high incidence and also high growth rate. So this is helpful to realize that some things were going on early before it started happening. I'm not showing the picture earlier, but you can start doing this exercise weeks before and start seeing that things weren't going okay. And then we have the other picture when we were opening. So you see again coherent behavior going towards positive growth rate this time. So we have an align in what's going on. A lot of local authorities were in negative growth rate, but you can see they are moving towards a positive growth rate region. So this exercise, we can repeat it in many other ways, and one of the ways we did it is based on what Rob Challen was presenting earlier today, and it's using variance S-gene target failure as an approximation of how variants are doing. So in this case, instead of using positive cases, we are using a timeline of cases marked as S-gene positives or S-gene negatives. Positives in yellow, negatives in blue here. And positives is an approximation in, for example, what's the wild type or what was delta and other variants. And then we have alpha and omicron as the typical ones with S-gene negatives. So what we did was to do the same exercise, but now subsetting the data in these two different groups. And then, for example, I'm going to focus on the 10th of May, again, 3 days later, after Delta was considered variants of concern. And then you can see that the blue squares here are going to be the S positives counts, approximating Delta, and the blue ones are going to be approximating the other variants that are S negatives. And then you can see that something is going on, again, with these dynamics, where you have high growth rate and high proportion of positives. And then you can repeat it a week later, and then we had to remove Bolton here because it was too high, but you can see some points also emerging, while the blues are going down, as we saw in the previous talk of Rob. So this is an overview of this kind of routine analysis we were involved at, and you can explore more other things that I'm not going to go through, but other applications that are more routine and other are more about retrospective analysis. But of course we have to create some ways of communicating and exploring easily, like these visualizations that are helpful to understand what's going on. And we have public, the code, it's public in GitHub such that it's easy to access and easy to use. And as I was mentioning, there are more applications that I'm not going to talk about, but we can try to use this information and higher derivatives to understand what is the effect of interventions. And also we can use these derivatives to try to understand a short-term projection of cases. Not forecasting, but a projection. And just to review, I was talking about these applications of these methods that we were using routinely in England. And we developed this method that was using growth rates, and it was fast and easy to use at the time, and it had a lot of applications during the pandemic, but it has some caveats, and it does not have certain epidemiological assumptions that other approaches have, for example, for reproductive numbers. But we understood that mixing methods, measures, and different groups estimates, so other universities doing different estimates, was very useful to try to understand what was going on. And that's the review. And finally, I want to thank the group, Ed Hill, Louise Dyson, Mike Tildesley, and Matt Killing, because I was at work with it together. And of course, thanks to Juniper, because they were the ones funding the project. Thank you for listening.
Thanks, Laura. I think we've got time for one really quick question. Is the next speaker around as well?
Hi, Laura. Pablo from Imperial College. Thank you. That was pretty cool. Just a quick one. Have you had a chance, because the data that you need for this exercise is quite specific, have you had a chance to explore your framework outside of the England context in other settings where data has been made available as well? And how does that work? How has that worked? Thank you.
We've done this also with other nations, with Scotland and Wales, but again we have these problems of data format that made it just to be focused on England. So no more exploration apart from England has been done at this extent, this level of detail. Right now there is a routine that involves Scotland as well, but apart from that, that's been the only level we've worked with routinely.
Thanks. Great. Let's thank Laura again. And well done. So I think our next speaker is online. Oh yeah, there she is. Great. Fiona Spooner is a senior data scientist at Our World in Data. Previously did her PhD at UCL and has got an MSc in conservation science at Imperial. Everything okay, Fiona?
Yes, all good. Can you hear me okay?
Yeah, sounds fine.
Perfect. Thank you. Yes, so I do work at Our World in Data now, but this was work that I undertook whilst a postdoc at University of Exeter. So despite Our World in Data's work on COVID, I won't be talking about that today. I hope that doesn't disappoint anyone. So this was work that we undertook as part of RAMP, and with 15 other colleagues, we built a dynamic microsimulation model for looking at epidemics, particularly COVID. So I'll just start with a quick overview of the model and then dig into it in more detail in the following slides. So our overall aim was to really model the daily links, the links between individuals' daily activities and behaviours with COVID-19 transmission. And we did this looking at a case study of Devon, a county in the UK. This was largely because several of us were based at University of Exeter, and we had some links with NHS Devon, which was useful in the early stages. So I think about the model in terms of like a tiered cake, with several models kind of building on top of each other. So the base layer is really the kind of individual level synthetic population that we built, and this had individual level data on age, sex, individuals' health characteristics, and daily time use. So this was particularly important for understanding how people spent their time on a daily basis. And building on top of this, we had a spatial interaction model. So this took the data on how people spent their time, but really mapped it, looked at where they spent their time and how people interacted with each other. And then building on top of this, we had the disease model. So looking at those interactions and looking at where transmission might occur, and they're kind of using a kind of compartmental model to look at the movement of the disease through the population. And then sort of a couple of sparklers on top, which I'll talk about, which was incorporating the Google mobility data into the model. So looking at real changes in behavior and recreating lockdown. And we also were lucky enough to collaborate with a couple of great research scientists from industry who took our model, which was previously only really useful in an academic environment, and sped it up a huge amount and made a nice user interface to make it into a tool that could really be used by policymakers, I think. So first of all, looking at the synthetic population. So this was a pre-existing project and model built led by Nick Lomax at the University of Leeds. And it essentially takes the UK 2011 census data but models it down to the individual level so that you would have individual level on sex, age, ethnicity, and socioeconomic status. And Nick projected this forward to 2020 for us to use in this project. But as I mentioned, we also wanted to include information on individuals' time use. So Karen Morrissey, who was at Exeter at the time, used propensity score matching to essentially match individuals in the Spencer population. So we had 600,000 to 700,000 individuals in Devon, and kind of link these with individuals in various surveys. So particularly the UK time use survey, which is made up of about 16,000 very detailed time use diaries. But from this, we could kind of aggregate time use. So the amount of time people spent at work or at school or in retail environments, we were able to kind of ensure that these individuals were statistically represented in our MSOAs. So on the right, we have figures showing the county of Devon, and each land parcel was an MSOA, which is an area of approximately 6,000 people, but this does vary a bit. And so you could see that there's spatial differences in the amount of time people spent at work and the amount of time people spent at home. So in the southern tip, you could probably guess that this was maybe a retirement area with less time spent at work on average and more time spent at home. And another survey that we incorporated was the Health Survey of England. So we looked at matching variables. So these were sex, age, and socioeconomic status, and matched based on these, and then incorporated information on individuals' BMI, diabetes, and cardiovascular disease into the model. So to, there we go, validation of the enriched population. So to check that our synthetic population actually looked sensible and wasn't just completely, didn't make any sense, we could did some external validation of the matching work and looked at variables that were in both data sets, so that we used to match on. So this was the socioeconomic status variable, NSSEC. And you can see the two columns in the table for the Devon census 2011 and the enriched data set populations, our synthetic population. And we ideally wanted these to be as similar as possible. And you can see, thankfully, they are quite similar in both columns. And then a harder test was to test this on a variable that wasn't used in the matching process. And this, we used the general health variable. And you can see the proportions of the population in both columns are fairly similar. So this is good news. Our synthetic population is pretty well representative of real Devon. So that's kind of completes the bottom layer of the cake. If we move up to the next tier, this is the spatial interaction model. So at the moment, we have a static population. We know kind of how people spend their time, what their health statuses are, but we want to get them moving. We want them to interact with each other. So for this, we had a pre-existing model built by Mike Batty and Richard Milton, who were based at UCL and CASA. And this, the quant model, essentially is a very large matrix which looks at trip probabilities between land areas, typically MSOAs, but some other intermediate zones as well, and looks at the likelihood of a given type of location, so schools or supermarkets from each of those land parcels. So you can estimate the likelihood of someone in that area traveling to a particular school or supermarket. And this map shows the southwest, and with higher trip probability shown in red and lower ones shown in blue. So it's essentially a type of gravity model. And so what this looks like so essentially like a row in our data set. So for the number one activities, this is where the synthetic population comes in. We know how this person spends their time, 65% of their time at work, 30% of their time, 65% of their time at home, 30% of their time at work, and 5% in a retail environment. They don't spend any time in a school environment, so they must be an adult. And then if we zoom in on retail, this is a list of possible venues they might go to, and the flow estimates is the probability that they will travel to each of these venues in a given day. So, for example, they spend 5% of their time in retail, and within this, they would spend 7% of their time at venue 98, which might be Tesco's or whatever. So that kind of completes the second layer of the cake. We kind of have a moving population of Devon interacting with each other. Now we want to kind of add the final layer, add the disease model on top. So these figures on the right, I'll just describe them briefly. So the top one kind of shows how the kind of daily basis. So stage 1 to 3 show what a daily iteration of the disease model looks like. And then the bottom one is just our kind of classic SEIR model, and shows the stages each individual would go through if infected. So first of all, so stage 0, almost this is how we seeded the model, how we initially got COVID into Devon, and we randomly seeded COVID within a subset of individuals. So typically in areas which were richer, better connected by transport, and more densely populated, and within individuals who spent a higher proportion of their time outside of their own home. So if we go into the daily disease model, stage 1 is where we look at infectious individuals, and this is what we say that they have hazard. And so for every venue that they visit, they would give a little bit of hazard. They would, proportional to the amount of time they spend there, they would give hazard to that location. So if they, in their home where they spend typically a lot of time, they would allocate a lot of hazard to this location, but maybe to a supermarket where they might just pop into for a short amount of time, less so hazard. And then if we move on to stage 2, this is the non-infected individuals. These also move around the same venues as the infectious individuals, and dependent on how much time they spend there, they would kind of accumulate exposure throughout the day. So if they happen to share a home with an infectious individual, they would accumulate a lot of exposure by sharing the same environment for a long time. And then essentially at the end of each day, there is stage 3, and this is the disease estimation. So for every individual that's been exposed, this is where they would become, it would be decided whether they are then infected with COVID. And this is essentially a Bernoulli trial weighted by the amount of exposure they've allocated through that day. A couple of more points that I thought were interesting to talk about in relation to this model. We've already seen the Google mobility data today, but we use this to kind of recreate lockdown within the model. We simplified it quite a lot. So anything that was residential, we said people were spending time in their own home, and everything else became outside their own home. So we basically just multiplied the amount of time in each of these categories by this aggregated variable to recreate lockdown for individuals in our population. And lastly, which I think is probably the most important part of our model, what really pushed it over the line into making it something useful and good, is that we, from July 2020, we collaborated with a gaming technology company called Improbable, and Charlie Shenton and Rory Krieg in particular. They essentially took our model, which was initially written in Python and R, and would take probably about 40 minutes to do a full run for 90 days or something, for like 90 synthetic days. And they refactored it into a language called OpenCL, which is based on C and C++. And this sped up the model dramatically. You can see kind of the UI they built for us as well on the right. I should run now. And yeah, you can see that's it basically. It's done a full model run in just about 4 seconds. And it can run on CPU and GPU. And this UI they built allows you to kind of play around with the parameters, which is quite useful. And I think potentially a very good policy tool. If you're interested in more of the documentation, there's a link at the bottom there. If I've got a little bit of time, I'll just talk about the scenario we ran with this modelling framework. So you can kind of move lockdown around, and we did that in the paper that published. But another one that we looked at was looking at the health characteristics of the individuals. So I mentioned that individuals had an associated BMI group with them. And we know that a higher level BMI or obesity is linked with a higher mortality rate if infected due to COVID. So in this scenario, we used the kind of base Devon with the kind of estimated levels from our synthetic population in each BMI group. And we also had a scenario where we essentially moved everyone down a level and reduced the BMI of Devon. And this table just shows the numbers in each group for each scenario. But we basically just reduced the obese population from 27% to 7% in the adult population of Devon. And this is some of the results from this scenario. So the baseline population is shown in grey, and this is the estimated infection fatality rate. And then with the reduced BMI population shown in gold, we found that on average there was about a 30% reduction in IFR. And using the kind of model that Improbable built for us made this much more feasible. We were able to run each scenario 1,000 times in just, could complete it in a day, and it was no worries. So just to wrap up now, I think reflecting back some lessons or if we could go back in time and start again, some aspects that we didn't do so well within our framework was that it's actually surprisingly hard to model workplaces. Unlike schools or supermarkets, there's no real canonical list of workplaces. So we ended up creating a virtual workplace for each employment type per MSOA. So every day, like all accountants would go to the same office in a given MSOA, which isn't ideal, but it was the best that we could do at the time. And then we also didn't cover atypical events or large gatherings really in the model. It's very much like a Groundhog Day model or daily basis in the modelling framework. And we also didn't capture care homes very well, which is obviously a big missing part, particularly early on in the pandemic. So I think you'll hear more after lunch from Hadrian and Fernando, but the next stage is, I believe, is scaling the model up to a national level, and then the calibration and validation of the model. Thank you very much for listening. Happy to take any questions, or please do get in touch.
Thanks, Fiona. I think we've got 30 seconds for a question, if there's a question. Everyone's kind of ready for lunch. I wanted to ask about whether you were able to attribute most infection to different locations in your model.
Yes, we certainly found that, yeah, typically in city centres. I think Exeter was a real hotspot for us, but in terms of locations, I think we found, yeah, workplaces and schools were definitely, very key hotspots for infections.
Great, thanks very much. Thanks, Fiona. So we're running a little bit late, so we're going to have lunch now, which is in the City of London rooms, and then come back, reconvene here at 25 past, not quarter past as it says on your timetable. 25 past, back here. And yes, Emma Davis and Chris Banks, slides, please, over lunchtime.
Welcome back, everybody. Apologies for the slightly tight timetable. One of the reasons for this is that Patrick Vallance later on has a time constraints associated with a meeting in number 10 straight after he finishes here at 5:30. So I'm just going to hand it straight over to Robin Thompson to chair the next session.
Hi there, everybody. Welcome back to session 2 of Modelling the COVID-19 Pandemic Achievements and Lessons. My name is Robin Thompson. I'm an assistant professor of mathematical epidemiology in Warwick. Welcome to everyone here in the room, and welcome to everyone online too. I hope everyone had a good lunch. We certainly did here, and hopefully you did at home as well. It's great to be here to acknowledge the contributions of early career researchers to the UK's research response to COVID-19, and that's what this session is all about. It's a series of early career researcher talks. A quick note for the speakers that towards the end of their talk, I'm going to hold up a piece of paper that looks a bit like this. This means that you have 2 minutes left, so if you could please start to wrap up at that point, that would be great. So the first talk of this session is by Hadrian Salat and Fernando Benitez from the Alan Turing Institute. They're both research associates there with a range of interests, including agent-based modelling and developing spatial modelling methods to tackle policy questions. So without further ado, I'll hand over to them. Thanks very much.
Hi. Yeah, so my voice is mostly good. So as far as I'm aware, it's only me, and Fernando is probably online following this thing. It's his birthday today, so just in case you want to know that. Right, so first thing is everything I'm going to present today is derived from an earlier model, which is the one that Fiona presented just before the lunch break. So in case you weren't there, it's called the dynamic macro-simulation for epidemics. And so the idea is to fit an SCIR epidemic model to pre-existing models of human social behavior. Right, so we've been extending this model. It was only working in Devon. But we don't repeat the messages already done. So if you want to check how the details, probably you want to check that reference that's on the slide right now. Right, so what we've been doing is extending the model to national level, improving the methodology where we could, but also we've been working on trying to make the model more reusable for things that are not necessarily concerned with the pandemic. So we've repackaged the model into several models. First one is the SPC, the synthetic population catalyst. So it's the part of the model that generates the initial synthetic population with daily activities. So then we also have a module that's called large events modeling. So the idea is the SPC is going to predict what happens every day, but we want to be able to break the routine, so that module does that for you. Then we have the aspects, agent-based simulation of epidemic and national level, national scale. Right, so that's the original epidemic model, which is our main application of the SPC. And then we have some other projects that are mostly starting or right, so I'm just going to mention them rapidly at the end of the presentation. Right, so the synthetic population catalyst. So it starts at the bottom of the slide with the red box. So the idea is the user inputs a list of MSOA, list of MSOAs, which can be anything in England. We do provide a lookup table so you can find the proper MSOA codes for any area that you might be interested in. Then you also have to indicate some parameters that are related to how precise you want the modeling to be. And then what the model does is the blue part. It fetches data that's stored on an Azure repository, and it contains population data. So that's coming from the Spencer macro simulation model, but it's been enriched with health survey, the time use survey, and also some modeling of income based on ONS data. So that gives you a static population. It's supposed to be the population of England for the year 2020. Of course, you can update it to 2021, 2022, but the way it's produced is supposed to be 2020. So on top of that, we add daily activities, which are to retail and schools, and also commuting flows. We also have geographical data that's used to geolocalize these daily activities, also to precise buildings, and also where people live. And we've added to it, because it's supposed to be 2020, we've added the Google mobility data that's been a bit reworked so that it fits directly into the model. So the model outputs protocol buffers that are a very convenient way to store all of the modeling inside one file. And it has a lot of metadata, but we do provide tools to convert the protocol buffers into CSVs and JSON if you don't want to work with protocol buffers directly. So this file is supposed to become the main input for some application models. Right, so the main modeling concepts are the Spencer and Quant projects. So those were initiated before the pandemic happened, and they are quite independent. So the first one comes from the University of Leeds. There's a reference if you want to look into it. The Quant is coming from CASA UCL, and same thing. You might want to. I'm going to refer you to their main website. So the more original stuff is the commuting modeling. So this is based on a recent Nature paper. It has the advantage of not having as much calibration needed than, for example, gravitation models or things like that. So that does the commuting modeling. And so the income modeling is also original. It's quite technical, so I'm not going to explain how we do it, but we've added that to the data. So the current outputs are a repository where you have the model itself, so you can run it. We've been working a lot on having fast run times. So currently, an area that contains about 2 million people is going to run in 30 seconds, which I think is quite okay. Then it's not strictly linear, so for London it's going to take a couple of minutes, probably a bit under 10, maybe 8 minutes, something like that. You could technically run for the entirety of England, but if you do it with your personal computer, you're definitely going to run into memory issues. If you have a computer cluster or something like that, then probably you could try to run it, but then the output file is going to be gigantic, so probably you don't want to do that anyway. So that's if you want to run the model yourself, but it still requires some installation, and there are dependencies, etc. So if you don't want to run the model at all, we have a detailed documentation, and within the detailed documentation, you can find some already compiled areas which are the ceremonial counties of England. Right, so that's ready for download. In the future, we want to have something that's directly accessible from a browser, so you can visualize things. Right, so on top of that, we've been adding some large events. So one of the main drawbacks of the SPC currently is that every day of the year has to be the exact same. So this here is meant to break that routine and also allow mixing of some demographics that wouldn't mix otherwise. Right, so the way it's done is very similar to the commuting modeling, except we have some higher probabilities if you fit into the demographics that are expected for a particular type of event. So the idea is to have different applications at different resolutions. So you can look, for example, for a pandemic application, and you would start introducing large events and see if you can spot some breaking points in the transmissions of the pandemic, right? But you can also apply a clustering algorithm and try to identify communities and see if those communities interact in a way that they wouldn't without the events. So in the case of a pandemic, obviously that's something you don't want, these kind of interactions, but if we get to a broader context, that maybe that's become something desirable, that these communities can actually interact. Right, and you can, of course, also track individuals and see where they do catch the virus. So I'm not going to go into the detail of how it works, but the point of this slide is just that these events are actually quite parameterizable. So you can, it's called large events because it's the original aim, but you can model an evening party between 20 people and fit it inside the model. It's no issue at all. So this part is coded. It's not yet included in a released way, but that's going to come quite soon. Right, so the applications, our main application is still the agent-based simulation of epidemics at national scale. So that's the same model that what Fiona explained just a bit earlier. So as she mentioned, it's been coded by Improbable. It's very, very good quality code. So we haven't touched it much. The main difference is that there will be the large event modeling at some point. And also it takes the SPC outputs directly as input. And it's available at national level. Right, and the other thing that we've been adding is calibration methods. So that's not finished and not entirely finished yet. But it's going to be based on approximate Bayesian computation. It's supposed to be, you're supposed to be able to run it for any specific area. So we're going to do a calibration at national level for different areas and try to check the work on other areas, etc. But you would be able to run your own calibration if you want something really specific. Right, so the output, all of this is stored inside a repository. It's still work in progress, but the model does work, so you can run it. It just doesn't have the calibration yet, and it doesn't have the events yet, but otherwise you can run the model. Right, so another application, and this is really different from the pandemic, is supposed to be climate change. Right, so this is a partnership with other people working on different, on different topics. So the main interests are rising temperatures, but the main point of the SPC is that you can try to identify if populations are differentially affected by the rising temperatures depending on their health vulnerabilities or socio-economic characteristics. Right, so I'm not going to read all that, but so why the SPC is needed here is because you need to have a personal exposure to heat, so you need to know where people are and how long they are going to stay in those locations and get exposed to heat, and also you need the vulnerability of individuals. And this is given to you by the health data of the SPC. Right, so application 3 is a project called Energy Flex. So this is a bigger project also that involves different universities. And then again, the idea is to introduce this, this idea that people might be differentially affected depending on their socio-demographic characteristics, right? Last application is to study spatial inequality. So because everyone is geolocalized, you could apply directly segregation measures, but we have this income modeling, so you can actually apply economic segregation instead of just categorical segregation. But the real strength here is that we are identifying how people are interacting beyond where they live. So you could have patterns of segregations that are not due to people, that may be due to people not interacting in a meaningful way. So for example, if the model tells you that people don't work together, that they go shopping at different places, and they don't interact at events, they might live close to one another, but they don't actually interact. So this is a case of segregation. And so the SPC is particularly well built to identify this kind of problems. Right, so this is all for me.
Thanks very much, Adrian. We have time for one quick question, if anyone has one, please. There's a question right at the very back in the middle. Please. Very good, thanks.
How would you change the model to account for changing behaviour over time during the pandemic?
Can you repeat the question, if you don't mind?
How would integrate change of behavior during the pandemic? So currently all we have is the lockdown modeling thing. So it's based on mobility data. The problem at a national level is the data only exists at county level. So what we're doing is, if your area is across several counties, then we're doing a weighted average. So it's not very precise modeling, yeah, this is all we've planned for now. And also, we don't take into account vaccines and things like that. This is a plan for the future, but it's low priority for us right now. So, yeah.
Great. Thanks very much. We can thank Adrian again. Okay, so the next talk is by Dr. Rajesh Bhagat from the University of Cambridge. He's a Leverhulme Early Career Fellow in DAMT, and his research interests are in fluid dynamics and ventilation, and he's going to talk about built environment, pandemic preparedness and sustainability. So, Rajesh, over to you.
Thank you. So my work is motivated by two most pressing problems of our time, the pandemic and global warming, because when building ventilation has been studied in the context of energy efficiency and so on, and during the pandemic we all felt the need for higher ventilation, but also the fact that we can't keep on heating air and just exhaust it from our houses and other places. So my presentation has these four elements. Essentially, I will talk very quickly about airborne disease transmission and where fluid dynamics comes into the picture, and some of the exemplar work which we did during the COVID-19 pandemic, and then the future work which I've been doing, and so on. So there are three key elements from my point of view for airborne disease transmission. First, you have to be in close contact, or you have to be in contact with somebody who has the infection. You have to spend some time there, and then how it is transported towards you, and how if you have inhaled these three things. So, for example, workplaces and commute. These are quite important places where we interact and meet with other people. And I'll show that during the COVID-19 pandemic, we went to different places just to assess the ventilation, how the ventilation, the state of ventilation is in different places. So time spent in public spaces are important. Ventilation is a very big, very small part of the very big puzzle. Whenever we do this kind of modeling, we find that one of the parameters which you use to model this is called infectious quanta, and we really don't have very good idea of infectious quanta. So I'd like to show you one of the where fluid dynamics comes into the picture. During COVID-19 pandemic, we did these experiments where we were looking at the effectiveness of a mask, and this person will be laughing, and then this person will produce all the expiratory fluid. So essentially, fluid dynamics comes into the picture in the form of the droplets and aerosol which we produce in our respiratory tract and lungs is kind of interfacial flow problem, and when it is transported and taken to other places, it's a ventilation flow problem, and that is where fluid dynamics comes into the picture, and that is where I work in. We all have seen these pictures where during COVID pandemic, these hospitals, makeshift hospitals popped up everywhere. And we were quite concerned about the ventilation of these because, COVID-19 patients should ideally be kept into a negative pressure room, whereas we can see the hospitals were built in trains and in tents, and we were concerned about particularly the health of the infection, spread of infection in these setups, particularly for the healthcare workers. So I will talk very quickly about building ventilation. Building ventilation, very broadly, if we ignore wind-driven ventilation, etc., can be classified in two types of ventilation. One is mixing ventilation, where we forcefully mix the whole environment. We bring some fresh air, and then we remove some diluted air from the space. And second type of ventilation is displacement ventilation. So essentially, hot air rises, and we are all hot surfaces. So I will show you in my next slide. And this hot air rises, and if we if we create openings appropriately, then we can take everything to the upper level and we can remove that from the space, and that is displacement ventilation. So here I'm showing you one of the experiments. So we fill the room with a neutrally buoyant fog, and then a person will enter into the room, and you will see that essentially what we do is our presence drives the flow. And as soon as he would enter, you can see that the flow is created around this person, and actually this fog acts as a tracer here. And the velocity here is quite high. Essentially, it is 200 millimeters per second above the head of this person. Whereas mixing is quite energy consuming. So you can, even in this room, for example, even if we assume that this room is mixed ventilation, if we put a thermostat, we will find some kind of stratification in this room as well, actually. So for example, for a room with 5 air change per hour, the bulk velocity in the room would be around 4 millimeters per second, and with 10 air change per hour, it would be 8 millimeters per second. Whereas the velocity above this person's head is 200 millimeters per second, so it is quite dominating velocity. So displacement, we found that displacement ventilation could be used in those makeshift hospitals. Whereas there was one of the questions which was raised for about 2 decades, and it's called lock-up effect in displacement ventilations. So essentially what happens is, we are hot surfaces, we produce a plume, this plume rises, and then the hottest air settles near the ceiling, and we remove everything from near the ceiling. But when I'm speaking, I'm also producing some kind of secondary plume, and this secondary plume is lighter than my body plume, and it can settle at a lower level. So essentially, imagine if a patient is lying on the bed, and if this patient's expiratory fluid is locked in a layer in doctor's breathing zone, that is completely undesirable. And this was cited again and again in order to discourage this type of ventilations in hospitals. So what we did was, we essentially found the exhaust mechanism, and then we can say, then we were able to say, okay, what kind of ventilation we should have in order to keep everything above people's head. So here I'm showing you one of the experiments which I did in water bath. So this heated cylinder mimics a person, and this person is kind of producing this expiratory fluid. And you can see that at very upper level, liquid is locked in upper level from where it is removed, the hottest layer, and then the expiratory fluid is locked in a lower level. And essentially, the fluid in this expiratory layer is entrained into the plume, and it is taken to upper level and removed from the space. So once we know the exhaust mechanism for this, we can build a mathematical model and suggest what sort of flow rate we should have in order to keep everything above occupant zone. So we built that, and essentially it's a very simple model. I will not go into detail of this model. It's easy, but the idea is that displacement ventilation was a viable solution for these kind of hospitals. It also has a very desirable property. So in occupant zone, displacement ventilation produces negative pressure, which is quite important. Essentially, it doesn't allow any contagion to escape from the room. So that was also a very desirable property, and it is very easily implementable. As essentially, we suggested people need one exhaust fan and some opening. So this is second exemplar problem. So we went to many different spaces in hospitals, in trains, and in pubs to test what kind of ventilation they have. And this is one of the examples where we carried out these experiments in a pub during the match. And what we found was, whenever there was a goal, there was a spike in PM concentration, but carbon dioxide concentration remained the same. And we all know that carbon dioxide sensors were used to actually assess the ventilation level, which is quite good actually. The carbon dioxide sensor gives us very good indication of ventilation level, but carbon dioxide is not particulate matter, which essentially causes the infection. So we did these experiments, but then we did experiments in trains, and this is one of the experiments we carried out in train in London, and we saw how ventilation, how effective the ventilation was in train carriage. So wintertime ventilation is, as I said in the very beginning, that we can't keep on heating, can't keep on heat air and then exhaust it from the space. So even if the UK and across the world, buildings are getting upgraded, but upgradation at the moment means having better insulation, and essentially what we have shown that ventilation should be supplemented with filtration and other methods, actually. So ventilation is not the silver bullet to all the problems. So scientific advances which are needed, which we learned from COVID-19 pandemic, is that interfacial fluid dynamics of this non-Newtonian fluid, of non-Newtonian respiratory fluid is needed to develop better model. We also need to understand the flow inside our respiratory tract. And there are some non-ideality in different ventilation flows. For example, a person moving in the flow in ventilated room. All these things are not understood. And then one of the last thing which I want to add, for example, in this particular room, if there are 2 persons, the ventilation need and heating need for this room will be completely different as compared to if the hall is full. But at the moment, the ventilation systems don't know, actually. If you talk to your BMS, they don't know. They ventilate at same level, which is undesirable. So we need smart buildings, essentially. And as I said, that UK is going through this building upgradation, and we would like to develop retrofitting strategies which would fit into this picture. And thank you.
Thanks very much, Rajesh. That was great. We've got time for a quick question if anyone has one. Question from Ellen, just on the middle.
This might not be a very good question. Because of your videos of movement in the room were brilliant, are taller people more likely to be exposed and infected to things like to airborne diseases than shorter people?
Yeah, we can maintain we can actually keep. So our theory suggests at what height we will keep these contaminated zones, right? We can keep a contaminated zone at above everybody's head, let's say a 3-meter height or 2-meter height. And I think taller people will be protected from that sense, right?
Great. Thanks, Rajesh.
Thank you.
Thanks, Ron. Very good. All right, so the next talk we have is from Dr. Chris Banks, who is a research fellow at the Roslin Institute at the University of Edinburgh. I understand from following him on Twitter that he's also a keen mountaineer and cyclist. But he's not talking about that, he's talking about modelling the pandemic in Scotland. So over to you, Chris. Thanks.
Thanks. So, well, I don't have quite as many cool videos, but I'm going to tell you a bit about the modelling work that we did during the pandemic in Scotland. So the main thing was a large individual-based model called SCOVMod, which was the Scottish coronavirus model. And we used this in kind of medium-term projections and scenario modelling to provide input to Scottish Government and Public Health Scotland. I'll tell you a bit about the results of one of the kind of scenario-based case studies that we did, and that was during the onset of Omicron, looking at what the sort of the peak of that the peak of that epidemic wave was going to be. And in the spirit of this meeting, I wanted to tell you a bit about what we kind of learnt along the way, what our achievements and lessons were. So SCOVMod, as I said, Scottish coronavirus model. It was adapted from an existing agent-based model, which is spatially heterogeneous, and it involves a kind of a local transmission layer and a national a national network layer. So originally it came from a model called TBMI, which was a model of bovine tuberculosis in cattle, and it was at the scale of individual cattle in herds and holdings, and the movements between herds and holdings are all catalogued in the cattle tracing system. So it's very easy to know exactly where cattle are and where they move to during their lifetime. So this is kind of a relatively easy thing to model. We were able to take that same structure and very quickly apply it when the time at the time when COVID kicked off, and we needed to sort of very quickly adapt a model and get something running to provide estimates. But the challenge, of course, was how do you account for human mobility, whereas cattle are pretty completely specified. Humans, we know very little about where they move. So, as I said, the model structure is kind of is split in two ways. We have local transmission at the census output areas. So census output areas are groupings of roughly 100 population that come from the 2011 census statistics. Within each of those areas, we have a compartmental model, which is a fairly standard structure. We have a susceptible category, an exposed category, a pair of infected categories, which are sort of mild infectious and severe infectious, from which you can recover, be hospitalized or die. And this is age structured as well. And then, excuse me, on top of that, we have national transmission. So this is a network model of movements between each of these compartmental model locations. And those we took to be, so the movements between each area are weighted by the census workplace movements. Of course, that doesn't completely capture human mobility, so we included non-work movements within the intermediate zones. So the intermediate zones in Scotland are kind of neighbourhood level groupings of census output areas. So we then have some proportion of movements are allowed to move freely within those intermediate zones to account for people going shopping, going to school, and so on. And then we have a time variant weighting according to Google Mobility. And given the number of people who have mentioned this already today, I guess that needs no introduction. As part of this model as well, we took into account something that became apparent during the pandemic, was that there's a significant correlation between deprivation and COVID transmission and outcomes. We found there's a significant correlation between the Scottish Index of Multiple Deprivation Health Index and transmission rates within sort of council area groupings. So council areas are, there are 32 council areas within Scotland, so that's a larger administrative grouping of the census output areas. And then, as I said, we didn't actually include vaccination in the compartmental model, but because it's an individual-based model, we have a flag on individuals that says whether they've been vaccinated, with how many doses, and then for each of those doses, there's a time-varying efficacy associated with that, which comes from mostly from the UK HSA vaccine surveillance reports. And then what we needed to do was fit that model. So the data that we fit it against was, initially we fit it against mortality rates before accurate testing data was available. And then later on in the pandemic, we were able to fit it against testing data. And a big part of that is estimating the true or the likely number of infections that arise from the cases that you see reported. So we had a case ascertainment model that's described in this paper at the bottom here by my colleague Ewan Coleman. And that's essentially a statistical model that takes as input the case data that was coming from Public Health Scotland and the ONS infection survey to account for the prevalence within the population. And we found that actually, interestingly enough, the case ascertainment, although it fluctuated during the pandemic, it remained around 25% for the whole time. I suspect that's no longer true. And then so we take that as the basis for doing parameter estimation. we do an ABC SMC based fit over the 9 epidemiological parameters in the model, along with a whole load of other fixed or kind of interval parameters that we have from the literature and so on. We did that in a kind of distributed fashion in the Amazon cloud, so running on about 300 machines, each with 8 cores, each running a simulation contributing to the ABC fit. And that took roughly to fit this kind of large national scale model 12 to 24 hours of running in this manner. And for that, so the ABC fit we generally did on just the initial outbreak, and then over time as the epidemic progresses, you get changes in the transmission rates, which are associated not with epidemiology as such, but with other outside factors that you can't necessarily model for, so MPI events and so on, or even just kind of voluntary measures that happen within the population. So to do that, we basically post that ABC fit, we take a kind of piecewise, very simple least squares fit, just on the transmission rates going forward in time. And inflection points in that do largely correspond to the MPI events that we're seeing in reality. So the fit that we get, so this is just an example from the Delta variant period. So we get a reasonably good fit, and you can see, so certainly in the larger areas like the city of Edinburgh that's highlighted, we get a big, so the red crosses here are the outputs of our infection case ascertainment model. So that's coming directly from the cases that are observed. And you can see the inflection points where the transmission rates are being altered. You can see, I guess you can see that there are kind of fairly steep changes in that. That comes from altering the transmission rate over time. It works pretty well in the larger areas, and then some of the smaller, lower population areas like Orkney, so you just end up with really wide confidence intervals. That's the way it went. So we took that model, so we were using that to provide kind of medium-term projections to Scottish Government and Public Health Scotland on the number of cases that we were expecting, and then translating that into hospital occupancies and so on. The next thing we wanted to do was when Omicron broke out, and we were seeing kind of worrying figures coming from the likes of South Africa and so on. We wanted to see what the outbreak size was likely to be in Scotland from very limited data. We had about a couple of weeks worth of data from the initial index case of Omicron in Scotland. So we took a range of scenarios based again on the estimates that were coming out of UKHSA, so for transmission rates and for the likely level of vaccine evasion that Omicron had over Delta. We took a selection of different scenarios based on those estimates. So we had 3 vaccine escape levels, one where there was no vaccine escape with respect to Delta, and then 2 others where there was a kind of a lower vaccine escape and a higher vaccine escape. And then 2 levels of transmission advantage, which were estimated to be between 2.25 and 3.2 times that of Delta. So we ran those as a range of scenarios. We also included the second set of scenarios there, including transmission, an extra MPI that was being considered by the Scottish Government at the time, just before Christmas, which I don't think they implemented in the end. But you can kind of see why it didn't really appear to have much effect on the outbreak size. So for those of you who these numbers are ingrained on their minds, you'll instantly realize which of these scenarios was the most likely. It was, of course, the one with the largest outbreak size. We then took that most likely baseline scenario and fit the growth rate to the initial growth rate that we'd seen. So here we can see the prior to the vertical line, this is where we have data for, and then beyond that is projections. And although we didn't quite fit the growth rate, the kind of explosive growth rate of Omicron when it happened, we did get the size of the epidemic not too far off. And we estimated that the transmission rate advantage over Delta was somewhere between 3.6 and 4.0, depending on the vaccine escape level. So in the spirit of this meeting, I just want to wrap up by saying what some of the kind of achievements and lessons that we took from this were. So we had this kind of ready-to-go model, and this was useful for running these kinds of scenarios and for informing policy and giving advice to the Scottish Government, providing weekly modelling outputs, and being able to actually capture this kind of complex spatial heterogeneity in both disease and mobility, and doing that all with quite a small team. There were quite a few lessons, and this is completely not exhaustive, but the key one was being prepared and having a model that was ready to go, and I think that's something that you can probably all agree with. But second to that was having people who are able to do this modelling work and having the availability and the appropriate funding to be able to do this work. So we had a research software engineer who was not funded on a specific project, so was able to jump in and do this. I'm a core scientist, which is a centrally funded Rosalind Institute position that allowed me to just remove myself from other projects and get on with doing this. And then we had other people like Ewan, who was funded by the Wellcome Trust, and they were quite happy to allow people to shift into doing this kind of work and take a hiatus from their funded projects. The real key to this was having a good software engineer, and I can't stress this enough. I think you probably all know this, but that's about it. The other things were that we did find it kind of hard to publish as we were doing a lot of work, producing a lot of outputs, but it wasn't scientifically groundbreaking. And we're now kind of getting some publications out. But, yeah. One final point of note is that fitting a time-variant, spatially heterogeneous, event-driven transmission rate is pretty hard, as you'll all know, and labour-intensive, and I think that should be quite an active area of research going forward. Thank you.
Thanks very much, Chris. Thanks for a great talk. I think in the interest of time, we might move straight on to the next talk. But if anyone has any questions, if they could perhaps catch up with Chris in the break, if that's all right, that would be great. Or send him an email if you're joining from home. Great. All right. So the next talk is going to be given. It's another double act. It's going to be Emily Nixon and Ed Hill. They're postdoctoral research associates at the Universities of Bristol and Warwick, in that order. They're interested in developing models of infectious disease dynamics and using them to explore control interventions, which is what they're going to talk about in the context of SARS-CoV-2 in universities. So over to you guys.
So yeah, as the theme for today is achievements from modelling the pandemic, we wanted to talk about achievement that we thought was really good, which was collaboration between modellers answering the same research questions but using different modelling approaches. So we're going to kind of present an example of when we did this as part of the Isaac Newton Institute Higher Education Working Group. So these are the names of the members of the group there. And this was looking at modelling SARS-CoV-2 in a university setting. So to give a bit of background, this group formed kind of around in the summer of 2020. In the first national lockdown, universities had closed and there wasn't any face-to-face teaching. And kind of looking forward to September 2020, people were asking whether there should be mitigations in place at universities to control transmission. So this working group formed to kind of look at these sorts of questions. There were a number of papers that also came up at this time here. And yeah, a number of different events that that were looking at this. And after these events happened, there was a weekly meeting with all the people that had been involved to continue talking about and exploring these sort of questions.
So as we moved into December 2020, the intention of the working group was twofold. One was to look back at the autumn academic term and the learnings we could take from that. And the second was to start discussing the measures that might be brought in to support the return of students to higher education settings in January 2021, including whether there could be, we could offer modelling inputs on proposed plans for testing, return testing programmes, and for the staggered return of students. And the collection of work from the group on these two areas has been published in Royal Society Open Science, and we'll show this publication again at the end. But what we're going to discuss in further detail in this talk is our contribution to that second area, specifically exploratory modelling of the impact of staggering the return of higher education students in the UK in January 2021. But to stress a couple of caveats, the analyses we present, these were prioritised using data from specific higher education institutes, and we were focusing on the high-level qualitative insights rather than specific quantitative figures from the individual modelling contributions. So the remainder of this talk, the first couple of parts, we will overview our respective modelling contributions and the findings on the impact on the epidemiological outcomes of staggering return of students, and we'll then conclude with our own view of the achievements and lessons from having conducted this work.
So I'm going to talk first about a stochastic compartmental model that I used to answer these questions in January 2021, looking at staggering return. So this was an existing model, the model from Brooks Pollock et al. And the model uses realistic data on social contacts, and there are 160 groups in the model, and these are based on school and year groups. So, for example, one group could be first-year mathematicians. For each of these groups, there are different compartments describing the disease state of individuals in these groups. So we used university data on a particular university with a student population of 28,000, and we calibrated our model and estimating using an R of approximately 3, and calibrated to estimations of initially infected students at the start of the academic year. And we ran the model from the start of the academic year for 300 days. So as this was a rapid response, we were interested just looking at the impact of staggering, because this hadn't been looked before, and we didn't have the right kind of data to look specifically at January 2021. So we instead just looked back and thought, hypothetically, in September 2020, if staggering had been implemented, what would the impact of this have been? But because of that, these results are to be interpreted qualitatively. So I'll just run you through the different staggering scenarios that I looked at, and also Ed was looking at with his model. So first of all, no stagger, which is when all students return on the first day of term. Then we also looked at a 14-day spread and a 28-day spread. So for that, when the day that students would return was sampled from a uniform distribution and happened evenly over this time. And then we also looked at a 3-weekend pulse, so kind of 3 weekends in a row, different students coming back to university. And this was based on, at the time, the kind of data that universities were providing on which courses they were kind of most important that they came back to face-to-face teaching. So in the first weekend that we looked at having medical, dental and veterinary students returning, and then all other practical students, and then finally all remaining students. And we also looked at having no testing or testing of asymptomatics as part of, alongside the staggering scenarios. So actually, I found that there was no there wasn't much difference between the different staggering scenarios, and that staggering didn't really have much of an impact. So you can see on the graph on the right-hand side, this is the relative risk reduction compared to a no stagger scenario. And relative to no stagger, if you did have these staggering scenarios, you did see a lower prevalence in the early phase, but then this was paired with higher prevalence later on in the term. And these figures are when no testing is used, and these figures are where testing was used. And again, I didn't find that testing of asymptomatics in this way we saw kind of similar patterns. So there wasn't much difference between these. So I'm now going to pass over to Ed, who's going to talk about his network model.
In our network model setup, the disease statuses were similar to the ones described by Emily for her model, but to characterize the contact structure, we instead used a network. And in our setup, we had a population of about 25,000 split into on-campus and off-campus residents. And we had 4 different layers to capture contacts in different settings where the transmission risk and contact rates may differ. So these were household, your course friendship groups, society and sports clubs, and then other social contacts. And within the household layer, for on-campus residents, we had an accommodation hierarchy where an individual would be in a household unit within a block within an overall hall of residence. For our time horizon, we were running forward from January 2021 for 11 weeks, and we explored the same 4 staggering scenarios that Emily has spoken about. One difference was for our 3-weekend pulse. The data we used was from a different institution based on their proportions within each of the respective courses for the return weekends. And our default testing strategy was to assume that those students who would adhere to the isolation test and trace guidance would also participate in a return testing program, which would be 2 LFTs spaced 3 days apart, and those who were positive would then undergo a confirmatory PCR. So what did we find in the network model? So some temporal profile aspects we were interested in included in the left panel infection prevalence, the central panel the cumulative infections amongst initial susceptibles, and the right-hand panel is effective R. And what we find looking at the infection prevalence is having staggering, particularly the 3-weekend pulse and 28-day uniform strategy, could delay and perhaps slightly reduce the peak in infection. However, long-term impacts were minimal. So when we look at cumulative infections, by the end of the term, across all the strategies, the cumulative amount of infection was broadly similar. And this was under assuming there was no return testing program and test, trace and isolate was not used. If we now had all students adhering to return testing and following isolate, test and trace guidance, we get a very different picture, where now the outbreak is now massively reduced and cumulative infections are much lower, relatively speaking, than the no adherence scenario. But again, between the 4 staggering strategies, the outcomes were broadly similar, and this is then exemplified if we inspect relative attack rate distributions. So for a given adherence probability, here I've boxed off the 0% adherence scenario. Across the 4 different staggering strategies, the outcomes across our distributions are comparable. It's only when you go to the higher echelons of adherence, this is shown to be critical to actually get a lower infection burden among the student population, rather than the staggering strategy itself. So naturally, there are other considerations beyond infection burden, and one other measure of interest would be the time students might be expected to spend in isolation. And in brief, we showed the benefit of a collective response, so high adherence, in reducing the time each adherent would be estimated to spend in isolation. And we found here there wasn't impacts of having staggering return of students, which would generally lead to a lower expected time for individuals to be in isolation.
So kind of reflecting again on the achievements from this. So we were asked to look at staggering as a potential strategy for mitigating SARS-CoV-2 in students in January, and our work was presented to SPIEM along with the work from the others in the group. And because we both found kind of similar results, this gave kind of quite a lot of confidence in helping to inform policy and provided new understanding. So also these models that we presented today have been used in other papers presented here. And yeah, I think a big achievement really is that these independent modelling approaches, when looking at the same research questions, really very strong, because if you have similar results, that kind of provides further confidence. And if you have different results, then you can kind of look into that more and think about why that's happening, and different kind of results can help you to understand more about different areas of the question. So we think this is a really good approach.
And to finish, a couple of lessons we'd like to take away. So we were focusing here mainly on the transmission dynamics and epidemiological outcomes, but it's imperative when viewing these results in a broader context that we take into account multiple other important attributes and aspects, which could include educational needs, long COVID, and mental well-being. And also there's a need for data access procedures that will enable prompt collaborative analyses. Cool. And with that, with thanks to funders and the various groups that have helped contribute to this work, and thank you all for listening.
Thanks very much, both. We've got time for one question, if anyone has one. There's a question at the back in the middle, please.
Sorry, if anyone else has a question, I'm happy to pass over. Otherwise, really good assessment. I wonder two things. One is, did you consider staggering geographically rather than by areas of groups that needed practical involvement in their lessons? And number two, given that adherence was such an important factor in reducing transmission, what considerations have you made for using your model for transmission of other well-known contagious diseases in the university setting?
In terms of the question about the geography, I do remember at the time there were discussions about this, because obviously different regions had different kind of prevalence, and also if international students were coming, then obviously there's different prevalence there. And I think that was kind of taken into account when estimating in my model the initial incidents at the start of September 2020. So that was included there. But sometimes when looking at different things, if the data weren't available, then that was more difficult to do. But yeah.
And on the second point, brilliant question. I think moving forward, it's translating findings applied to like this respiratory infection, what could be, perhaps more generally applied to other respiratory infections would be of great interest. So thank you.
Great, thanks both. Excellent. So now moving on to the next talk. The next talk is by Dr. Emma Davis, who is currently at the University of Oxford. She's a postdoctoral researcher with an interest in neglected tropical diseases. Today, of course, she's going to be talking about COVID, and specifically the impact of contact tracing and isolation on the pandemic. So Emma, over to you.
Thanks. Good afternoon, everyone. So I'm going to be talking about modelling the impact of contact tracing and isolation on the COVID-19 pandemic in the UK. And this work is something that my group became involved with initially through the RAMP initiative. So contact tracing, in theory, is a really neat and useful idea. And the concept is that you identify an infectious individual, and then by talking to that individual or using an app, you can then determine who that individual might have contacted, and then you can ask all of their contacts to isolate and therefore not infect other individuals. And then while they're isolating, you can then determine which of those individuals
actually contracted the disease. And this is a method that's been used historically across a number of infections. It's quite common with sexually transmitted infections. And early in the pandemic, there was quite a lot of hope that this would be a really powerful tool to control infection and transmission, but also to prevent wider spread measures like lockdowns. However, contact tracing in practice looks a bit different. So you might identify an infectious individual, but then of that individual's contacts that they could have transmitted to, you might only identify some proportion of those contacts. And then when you ask those individuals to isolate, some of them might isolate and some of them might not when you ask them, which then creates like quite a leaky process where you feel like maybe you could have identified all these individuals and prevented the transmission, but you don't actually know how much transmission you're preventing. With this in mind, the ideal pathogen for contact tracing would have a short, well-defined infectious period, have obvious and specific symptoms, no pre-symptomatic transmission, and also have no asymptomatic cases. Whereas COVID-19 has an infectious period of 5 to 11 days post-symptoms, so not the longest, but it's quite a long period to ask people to isolate. The common symptoms are shared with other infections, for example, flu, and there are quite high proportions of pre-symptomatic transmission and asymptomatic infections. So just a brief, throwing our minds back to remember the timeline of the UK approach to contact tracing. So just a few key changes across the pandemic, starting with the start of the NHS test and trace system in England on the 28th of May in 2020. And then this carried through to September, where isolation became legally mandated. And this is where we were doing some work looking at adherence and looking at potential trade-offs between different behaviours that you might see due to legally mandating isolation. And then there were also various support schemes and changes in the length of the isolation period across the following year. However, in 2021 and onwards, lots of other things kept changing, and it was really hard to keep the models up to date with all these changes that were being made very regularly to the contact tracing process. For example, all of a sudden in August, double vaccinated individuals no longer had to isolate, and then a couple of months later in November, all Omicron contacts needed to self-isolate, but not all cases were being sequenced, so it wasn't always possible to tell who were Omicron contacts and who weren't. And then isolation was replaced with daily lateral flows only a month later. So most of the analysis I'll be talking about here happened in this earlier period in 2020, but I just wanted to highlight how difficult it is to keep continuously updating these models so that they represent what's currently happening. So the main approach that we modeled was manual and app-based contact tracing, where a new case is identified, so a contact either through being a contact of a case or self-reported symptoms, or being identified in potentially through hospital testing or other testing. And then that individual would then be asked to isolate for 10 days from the point of contact or test. And then their households and household occupants at that point don't isolate. And then if that individual has symptoms that emerge, then they then take a test. So this is a potential case that's then isolated, and then if they develop symptoms, but only then they're asked to take a test. And if that test is positive, then their household then have to isolate. And if the test is positive, you also trace their contacts and you isolate for a further 10 days. But if the individual tests negative, then the household then stops isolating, but the traced person finishes their 10-day isolation, and then you restart the process with any traced contacts. So some of the reasons why contact tracing might not have been as successful as originally hoped in the UK kind of centres a lot around adherence. So isolation adherence was really poor, with some estimates being as low as 11%, and self-reporting rates were seen as low as 12%. So that's 12% of individuals who had symptoms identified themselves to NHS test and trace, and
said, I have these symptoms, I might have COVID. Also, not all individuals provided full details of their contacts, and testing and tracing was often slow, frequently being more than 72 hours, which can then cause quite a big delay if you think about pre-symptomatic transmission. And also, as we knew from STIs, asymptomatic tracing is a key benefit of contact tracing, and we weren't doing any asymptomatic testing, which meant that any asymptomatic individuals, we then weren't then following on from their contacts because they never took a test and we never knew whether they had COVID or not. So most of our assumptions were around the 2020 variants, and we had profiles for the incubation period and the infectivity profile relative to time from exposure and time from symptom onset. And we made assumptions around the number of asymptomatic cases, the time it would take to test. And then we also looked at low sensitivity tests and high sensitivity tests, choosing 65% and 95% to roughly approximate LFDs and PCR. And we also considered a negative binomial offspring distribution. So we put this into a branching process transmission model that was originally presented by Helliwell et al. Early in 2020. And then we used this model to then simulate forward and look at things such as the probability of a large outbreak and the effective reproduction number. So looking at the outbreak risk, so this grid here, the top row is poor reporting and adherence, so 11% as quoted on the previous slide, and then the bottom row is good reporting and adherence, so 50 to 65% adherence to isolation and reporting of symptoms. And you can see that in the top row, as you scale contact tracing coverage along the x-axis, there's almost no observable benefit of test and trace, and there's no observable benefit of faster tracing. However, if you have good adherence and reporting, then you do see a visible, if small, benefit of contact tracing. Similarly, looking at the impact on the reproductive number, if you have low adherence and reporting, again in the top row, then you see no observable benefit of test and trace and no observable benefit of faster tracing. Whereas on the bottom row, you can see up to a 14% reduction in R in some scenarios if you have good adherence and reporting. So we also used this model to have a look at the trade-off between a higher accuracy test and a faster test. And what we found is that a higher sensitivity test isn't always better, but that there was actually very little difference between these scenarios, and it was really quite highly dependent on other parameters in the model. But if you see in both of the plots, the solid lines represent the higher test sensitivity, and the dashed lines represent the lower test sensitivity. And there's really not a very big difference between the 2-day delay higher test risk and the instant tracing, so lateral flow, lower sensitivity risk. So our key conclusion really was that adherence is the single most important factor of contact tracing success. And particularly as the pandemic went on, there was definitely less appetite to adhere to these restrictions, even though they were legally mandated. And we also saw that faster testing and tracing is beneficial, even potentially at the cost of some sensitivity in terms of the test. And also the higher coverage of contact tracing, as expected, results in a higher impact. And we also saw reductions of R in up to 15% in some scenarios. But it's really important to iterate that we found at all stages of the pandemic that contact tracing was not appropriate as the sole control measure. So I just threw a couple of extra slides in thinking about monkeypox. So if we think back to our ideal pathogen, we want a short, well-defined infectious period, obvious and specific symptoms, no pre-symptomatic transmission or limited pre-symptomatic transmission, and no asymptomatic cases. So the first one, monkeypox does really badly at. So you have a long incubation period of 5 to 21 days and a long infectious period of 2 to 4 weeks. But you do have obvious and specific symptoms, limited pre-symptomatic transmission, and few asymptomatic cases as far as we're currently aware, or as far as I'm currently aware. But there are, this potentially means that monkeypox could be quite a good situation or a good scenario for applying contact tracing. But there's a couple of challenges around things like adherence, which we saw was the most important thing with COVID-19. And this is going to be a huge problem if you did ask people to isolate with monkeypox, because you have the very long period you would require them to isolate for. And also this idea of pandemic fatigue, because we're all tired of isolating and having our lives restricted. But also there's going to be uncertainty around animal reservoirs and key parameters, and also complexities in contact type and risk. I'd just like to acknowledge my amazing group that have been working on this with me, and also the rest of the team at Oxford.
Thanks very much, Emma. That was great. We've got time for one quick question, if anyone has one, please. Maybe over there on the right-hand side.
Thanks, Emma. Very nice talk. I was wondering how useful or usable would this approach be if you had issues with privacy? Do you actually need to know the details of the contacts themselves, or can you do this in a kind of hidden way?
So the contact tracing app is decentralized. So this approach works perfectly fine using that. So there shouldn't be any privacy concerns as far as I'm aware. But obviously, as everyone knows, it's very hard to access the data even when it does exist. So.
Thanks, Emma. That's great. Okay, so the final talk of this session is from Chris Overton. He's based at the UK Health Security Agency, and he's going to talk about forecasting hospital admissions with COVID-19 in the UK. So, Chris, over to you.
Cool. Yeah, so I'm Chris Overton. I'm a principal modeller at UK Health Security Agency. And before that, I was at University of Manchester, which is where I spent most of the pandemic. I'm going to talk about some forecasting models we've made for COVID-19 hospital admissions. Though, as Laura mentioned earlier, these are really more projections, though there are some forecasting elements to them, but call them what you want. And it's probably the third forecasting model that I've written for COVID-19 hospital admissions throughout the pandemic. I'd say this is the fastest model. It all runs from data processing to spitting out output figures, takes about 5 minutes. And I really like models that run quickly. One, because I'm very impatient, and two, it's nice if you have an output, you can run it as up to date as possible, and it gives you a lot of time to then come up with effective narratives that you would want presented to policymakers, and to really think and check through all your results, rather than waiting hours, something goes wrong, and you don't have time to redo it before important meetings. So the structure of the talk is I'm going to take you through the first model, which is a hierarchical trust level generalized additive model. Then I'll take you through another model, which is a hierarchical age level generalized additive model that uses PCR positivity as a leading indicator. So that's why you could also get away with calling these forecasts, because it does have some leading aspect, but it's still mostly projections of trends in the data. And then we'll go through some model scoring and ensemble modeling approaches. So for the hospital level model, basically, if we're in an exponentially growing or exponentially declining epidemic, we could assume, for simplicity, that we've just got a nice expression where hospital admissions at day T are some exponential function of time multiplied by your initial conditions. And so that's fine if things are growing exponentially or declining exponentially. But as we've seen throughout the epidemic, growth rates change quite a lot. So instead of assuming that we've just got a exponential of r times t, we could instead assume that the exponential is growing according to some smooth function of time. So in this case, r of t. So then we have the expression here on the central line. And if we take the log of both sides, we end up with the log of your initial conditions plus this smooth function of time, rt. And the idea of that, we've got that expression there, and that's very easy to fit with the generalized additive model, where we'll just have an intercept term and then a spline, which will be our smooth function over time. So that's the general gist of the model. I mean, you could just take that and fit it as you want to individual trusts or hospitals or whatever. But if you try fitting that to a trust level, the noise and the overdispersion in the data are just going to give you confidence intervals that are just a cone expanding to plus or minus infinity, and it's not really going to help anything. So we've added a hierarchical structure that brings in catchment areas and brings in information from trusts in the neighbouring regions. So what we've done is we've constructed these catchments of similar trusts with similar epidemic profiles, and this is through looking at the mobility data. So this one's not Google mobility, which we've heard a lot about today. This is from Telecoms mobility. So it's basically looking at how people have moved during the pandemic between the different regions in England. Well, it's actually down to LTLA level. We've used a mapping from the London School that converts LTLA level to trust level, and this allows us to build a contact movement matrix between all of the different NHS trusts in England. And then we've done some spectral clustering on these and optimized across the number of clusters that we want to consider to create these catchment regions of trusts where we would expect the epidemic trajectories to be similar. And so we can then plug that into our generalized additive model. So instead of just having F1 as being a smoother over time, it's a smoother over time with a catchment level effect and then a trust level effect. So we've basically got a combination of these two splines across each trust, and it allows you to borrow information from your neighbouring sites. And this helps to bound your uncertainty for one, and it also allows you to pick up information from the others. So say you've got 5 trusts in a cluster, 4 are going up and 1's going down. Adding this hierarchical level will help bring that other trust up and predict that we're probably going to see a similar trend across all the areas. These other terms here, we can then add random effects for day of week, which is D, and random intercepts for the trust and the catchment. That's the idea. Originally, we assumed the catchment or NHS regions, but using this mobility data, we've got better performance. I think we have 15 catchment areas is what we've found as the optimum number. And this is the type of results. You can get some nice pretty plots. So on the left, we sum everything up to England level. What we've got is the sort of purple curve is the fit to the data with a 2-week forecast thrown onto the end. And then the backwards shaded plots are historical forecasts generating the data with the data overlaid, so we can see how things are going. And generally, the performance looks reasonable. These are region level and national level. But you can see it struggles a little bit around peaks and turning points, which is what I'm saying. It's a projection. So it takes that exponential trend in the data and it's projecting it forwards in time. So if you look at the turning point, obviously the data's going up. The model doesn't know it's about to turn around, so projection goes up in that sort of turquoisey blue third one across zone, and the data starts to come down, and we see that the performance starts to drop. So what we really want to do to make this more of a forecast rather than a projection is to bring some leading indicators into the model. Just before I show you the leading indicators, here's how it looks at the individual trust level. As you can see, it does a reasonable job of projecting the trend at each individual trust, and the uncertainty isn't crazy, which is why it really helps having that hierarchical structure. Because if you just fit any of these data sets individually, treating them as isolated trusts, you'd really get something that doesn't help public health professionals and policymakers decide where they think the epidemic trend is going. So the next model, we wanted some leading indicators to try and help that turning points problem. So this was constructed, I think, back in February, when we had lots of PCR testing data, and so it seemed like a great place to go to look for that leading indicator data. So again, we can assume some exponential trends in the data. So on the left, we've got our exponential function of time for hospital admissions, and on the right, we've got our exponential function of time here for PCR positivity, which I've called P. So we can fit GAMs to both of these, following a similar structure earlier where we have the hierarchical term for clusters, and we'll get these smooth time series H tilde and P tilde, and we choose that we want P tilde to be a bit more flexible than H tilde to get as much power as possible out of the leading indicator, so we add twice as many knots to that spline, just so that it can be more responsive and pick up trends in the data sooner than the one that we've got for the hospital admissions. We then assume, from a nice easy, semi-mechanistic point of view, that hospital admissions are some linear function of PCR positivity some days before. So this expression at the bottom where we've got hospital admissions are basically lambda times by positivity delta days ago. And basically from fitting the PCR to specimen date to hospital delay from all of the Pillar 2 data, we see that a delay of around 6 to 7 is consistent with the data streams. So we chose 7 because it's bigger than 6, which means we get more of a leading indicator and we get a slightly more responsive model. So we assume delta 6, we fit the model just using a linear regression that adjusts for age and region. And then we can take the projected spline fit to positivity. So this is why it's a semi-projection, semi-forecast, because we only have 7 days of data, so we project forwards another 7 days to get 14 days of positivity leading on admissions. And then we can take this and we can put it back through the linear regression to get this hypothetical admissions H2. Now, we could just trust this H2 and use that as our forecast for admissions, but that would assume that this linear relationship is perfect over time, which often isn't the case because severity could change if we're getting different variants, demographics could change. We do adjust for age, but in 25-year age bands, which are quite broad, so distributions of the age within each age band could change this linear relationship, and so just assuming that might not give you a great fit to the data. So we then take it and we throw it back into another GAM. We quite like using GAMs in our team, so forgive us. I think that comes from working with Ian Hall in Manchester, who also loves using them. So basically what we've got is now this GAM structure at the bottom, where we have the first 2 terms are familiar from the earlier model, but now we have age instead of trust, so we've just got this spline that assumes admissions are some approximately exponential function of time, broken down by age and catchment. But we now have a second smoother, which is applied to the logarithm of our hypothetical admissions H2. So this is assuming if H2 is a perfect predictor of what's actually going on in admissions, the model will lean more heavily on this second smoother, and it will provide a really good leading indicator. If those relationships start to break down, we're going to get that being weighted out of the model, and it's going to just bounce back to that exponential trend over time. So, it's basically the idea of this model is to be flexible and to always work regardless of whether that relationship is good or not about our leading indicator. And again, we just got some random intercept terms. So we've got more nice pictures again. So if we look at that turquoisey blob, we can see now it really is pretty centered nicely on that line compared to where it was before. And again, if you look at the more recent trend, it's now picking up. The epidemic did start to turn around in this couple of weeks, so the central estimate is still a little bit pessimistic, but it entertains the possibility that the epidemic was turning around compared to just the pure exponential model. And so if we put the plots side by side here, we can see that a bit clearer. So around the turning points, it definitely does a better job. The downside here is pre-turning point, sort of at the start of January. The model was very pessimistic compared to just the admissions model. And the reason for this is that linear predictor about the relationship between PCR positivity and admissions was parameterized to mostly Delta data, and this was the Omicron wave. So it really overestimated that conversion rate between positivity and admissions, and the model then struggled to catch up. But then by the time it turns around the turning point, there's been enough data to reparameterize it to that new relationship. Trust level, again, I won't go through those. And then, so we've just done some model scoring to evaluate performance. So this is scoring the central estimate 14 days ahead. So it's just comparing the relative error between the forecast and the actual data. And so we've run this since July and basically scored the target relative error and then counted the proportion of predictions that are on target. So the target relative error is the relative error between the prediction and the observed value. And then we're saying, okay, what proportion of simulations met that threshold? And the key thing here is the one we've called first derivative model. That's just the hospital admissions GAM, which is in blue. And we can see that all of these leading indicator models are increasing the performance, the predictive accuracy of that model. And I'll stop there.
Thanks very much, Chris. We've got time, I think, for one question, if anyone has one. Graham at the front.
Could you just put up the last, sorry. Do you mind putting up the last slide again, the summary slide? Another one?
There we go.
Not that one, the one that came up after that.
This one?
Yeah.
Yeah.
So looking at the thing on the left, it appears to me that you would track that much better if you just fitted, if you didn't fit the logarithm, if you just fitted the, just assumed that the thing was going to grow linearly.
Yeah, yeah.
Have you tried that?
So we've looked a bit. It struggles with the curvature a bit. So I mean, it's the type of thing you probably could get better performance at times, but that's sometimes anticipating that we think it is about to slow down. But yeah, it'd be interesting to compare how it scores against.
Just the sort of explosively high things, which unfortunately newspapers are quite keen on reporting, seem to follow from having the exponential in there.
Thanks very much. Thanks, Chris. Thanks for a great talk. If we could just thank all the speakers from this session again. Thanks, everybody. So that brings session 2 to a close. So I'm going to pass over to Deirdre Hollingsworth now for session 3. Thanks.
Great. Thank you very much for all the fantastic talks. I have the easiest chairing job of the afternoon, so I shall start that very shortly. But for those of you joining us online, welcome to this opportunity to acknowledge and celebrate the diverse uses of research and the contribution of researchers during the pandemic. And it's been fantastic to have so many early career researchers presenting. And I'm about to introduce a compilation of flash talks. So those are 3-minute talks by early career researchers on their work they've done related to the pandemic. And I'm going to hand over to the control room to take it from here. Thank you very much.
Hello, my name is Joseph Haley-Bullock. I'm a research scientist at United Nations Global Pulse, and I'm a research affiliate at Durham University. And I'll be talking briefly about modelling of vulnerable populations in context using the June model. At the beginning of the pandemic, under the RAMP initiative, we launched the June collaboration. June is an agent-based model which simulates the movement of people at the individual level and is informed by census data, time use surveys, and other additional data sets. The model can capture a range of attributes at the individual level, including age, sex, ethnicity, socioeconomic index, as well as how different populations mix. June was first deployed in the context of the UK, in which we can model populations down to the level of the output area, as well as locations people mix and attend during the day. This was to support NHS decision-making, especially around hospital demand and service delivery, and has since grown into a larger collaboration with Public Health England. June has also been deployed in parallel to model COVID-19 spread in refugee settlements, including a deep collaboration with teams of the United Nations. There have been many results to be presented. However, I will focus briefly on the importance of modelling these vulnerable groups, either explicitly or in the context of wider populations. So firstly, in the case of the UK, while we do not fit to any socioeconomic or ethnically disaggregated data, we found that an emergent property of our model was its ability to capture the profile of the differences in infection and death rates by ethnicity. We naturally reproduced the prevalence rates measured at the end of the first wave in the UK, as well as the death hazard ratios calculated from clinical records, here compared against those from the Open Safely collaboration. This allows us to query the model and dig deeper into the reasons behind these differences, what's bringing them about, as well as explicitly assess the impact of interventions on these vulnerable groups. Secondly, in a very different case and environment, such agent-based approaches can be used to explicitly model vulnerable populations, such as refugees, which can have very unique cultural and community behaviors, and we can capture these different behavioral dynamics in the model. In the case of the Cox's Bazar refugee settlement in Bangladesh, we modeled a range of interventions, including, for example, the reopening of schools or learning centers. In this example, we found that due to the overcrowding in shelters, the regular intergenerational contacts, as well as very young demographics in the settlement, that the infection will quickly spread and break out of age strata once they've been reopened, the learning centers have been reopened. Additionally, we saw that alternating the days in which children can go to school, as well as layering various interventions such as increased ventilation, social distancing, etc., can help reduce infection levels. And we also measured the feasibility of these interventions, given financial, logistical, and other constraints. To conclude, different kinds of models have different advantages, and we should make use of the whole suite of models available to us for different kinds of decision-making. Certain subpopulations may have distinctly different behavioral patterns, which can make them more vulnerable to infection, and we need the explicit inclusion of these vulnerable groups into disease models to be able to have better and more effective public health programming. Thank you.
Hello, everyone. I am Mohammed El Khalifi. My talk is based on a joint work with Tom Bretton and aims to model gradual loss of immunity. Actually, standardized ARS model assumes that recovered individuals stay completely immune before they lose all the immunity to become fully susceptible. And such assumption is represented by the blue curve in this figure. In reality, immunity drops in a gradual way, and for instance, it could be lost according to a linear mode or an exponential mode as represented by the red and the green curves respectively here. Here we assume that the immunity is lost in a linear decay mode, and we approximate it by a stepwise function in k steps. For instance, a linear decay in 5 steps could be represented by the following immunity levels curve. But for general k, the mode we propose splits recovered individuals into k classes, such that the same constant immunity portion is lost at the same constant rate Ck, which we calibrate such that the average immunity, the average accumulative immunity is the same for any value of K. The basic reproduction number does not depend on K, but when it's bigger than 1, our model admits an endemic level that satisfies the following monotonicity property. All the new model parameters affect the value of the endemic level, but only R0 has the largest effects, and it can imply an endemic level 3 times higher than the one from the standard model. Here we assume that k equals 100, that could be sufficient to approximate the linear decay function. If we only know the values of the mean infectious period, the average immune period, and the life expectancy with values in agreement with COVID-19 epidemic, for instance, then with a given observation of the endemic level, the realistic model implies an R0 that can be very smaller than the one from the standard model. I think I should stop here, but we have also investigated the exponential decay mode and discussed the implications of the corresponding model with vaccinations. Thank you.
Hello everyone, my name is Susan Farhang. I'm a postdoctoral researcher at the University of Manitoba. Today I would like to talk about mathematical modeling of SARS-CoV-2 immunoscape. In this work, we aim to determine some specific characteristics of the immune response and also coronavirus fitness that enables viral escape. In this work, we have started with 8 ODA equations based on the recent host viral infection pathway. So in this model, we have assumed the target cells are infected by the coronaviruses. So then we will have the first infected cells, and then during the eclipse phase, we will have the productive infected cells. I1 and I2 actually are secreting the interferon 1, which is the main cytokine in order to stimulate the innate immunity. So then it induces some conversion between the resistant cells and the target cells. So then, and also we have assumed some initial values for CTL and antibody because we are looking at the post-infection or post-vaccination in this model. 2 main terms that I would like to mention them is that this term, which is the disinduced by CTL for the productive infected cells, and also the neutralizing rate of viruses by antibody that we have added to this equation. So then based on those equations, we have some other predictions. In the first plot, I have looked at the before infection. There is when we don't have the viruses, so then the antibody and CTL are decreasing exponentially. And then actually it's just a natural decrease in immune response. So, but if we have the infection, so the dynamic will change, and then you can see here for different initial values, we will have different immune response, and then the actually lower initial values, the higher CTL are activated. And also the second main message is the correlation between viral load that you can see. Maybe it's not more clear here, but there is a correlation between the peak viral load and also the basic reproduction number. The higher viral load, actually the higher basic reproduction number. So to this correlation between viral load and the reproduction number. So we would like to define the immunoscape based on the reproduction number. So we have calculated the reproduction number, and if we look at the reproduction number based on the parameter mu and the delta, which are the two main parameters that are playing a role in RC, we can see in the darker area the reproduction number is smaller than 1, and we would like to say that when the reproduction number actually is smaller than 1, there is no immunoscape. We are defining based on the reproduction number. So in these plots, you can see also there is a threshold for mu and delta that for mu and delta greater than those threshold, the reproduction number should be smaller than 1. And in these plots also, I have played around with the parameter mu and delta, and from panel A and B, you can see that the parameter delta, which is the CTL induced, the set has more effect than the parameter mu. And for RC when it equals to 1, we can find some equations for mu and delta. So far we have looked at the, we have defined the immunoscape based on the reproduction number in this work. I have some special thanks for my previous supervisor, Professor Jane Heffernan and Professor James Ottman from the University of New Brunswick. And this is my poster. So I will be happy to take your questions if you have any. And this is my email address. Thank you, everyone.
Hello everyone, I'm Guilherme and I'm going to talk to you about Comorbus. So Comorbus is a biosocial agent model for the design of public health policies. And what sets it apart? Most importantly, it's based on a full description of the city infrastructure and the average period on utilization of this service by the community. This way, the encounters and the ensuing infections happen organically as the agents live according to a stochastic model for their behavior. The contact networks are fully local and they respect the different social roles of the agents in that locality. In this way, it's distinguished the role of waiters, doctors, cashiers in supermarkets, professors and students in any other setting. Also, the code is extremely modular and we can easily add and mix features such as different biological models or infection models. We can also easily simulate other diseases in communities given the necessary data. We, in this way, can simulate any type of public intervention, such as behavior interventions, testing, contact tracing, and quarantines, changes in service infrastructure, non-pharmaceutical interventions, or vaccine and drug testing and deployment. All these interventions can be set dynamically based on observable criteria to test different health policies and decision making. Here we show some behavior interventions in the study we're trying to publish right now. In this study, we evaluated how different scenarios of interventions in school setting, the classroom setting, increase the total number of infections in the city compared to the infections that happen naturally if the school was still kept closed. We also measure how the effective teaching hours decrease with different policies to evaluate the loss of teaching time. And most importantly, we see that safe activities are still possible even in the middle of a full-blown infection wave, provided that the correct protocols are followed. We also evaluate the robustness of the protocols with respect to changes in classroom airflow and quality masks. Here we elucidate that we used an aerosol infection model in the classrooms, and we also test robustness of the vaccination coverage and susceptibility of the population to variants. Most importantly, we see that bad protocols are disastrous to the whole community, but we also see that there is a safe path for activities even with low vaccine coverage, which is very helpful for countries with low coverage. But we must be very careful on the choice of protocols applied. Lastly, I thank everybody for their attention and our team. Thank you.
Hi, I'm Tristan Lang. I'm a researcher at Imperial College London, previously based at the University of Warwick. Throughout the 2020-2021 academic year, a wide range of measures were implemented to control transmission in secondary schools. In the UK, two measures were central: the isolation of close contacts, implemented throughout the academic year, and regular mass testing with lateral flow tests, implemented from March 2021. Alongside my colleagues at the University of Warwick, we designed an individual-based model of transmission between secondary school pupils in England, and we used this model to evaluate the impact of control measures involving either the isolation of close contacts, reactive or regular lateral flow testing, or a combination of these. Within this model, pupils mixed with their close contacts at a high rate, with non-close contact members of their year group at a lower rate, and with pupils from other year groups at a yet lower rate. Alongside transmission from other pupils, pupils could be infected from non-school contacts, with the probability of this depending on case rates within a school's local tier local authority. And we fitted this model using an ABC approach, positive PCR and lateral flow test time series obtained from community swab testing data in 11 to 16-year-olds, alongside the distribution of peaked confirmed COVID-19 cases before and after the introduction of regular mass testing. And this was recorded by the Department for Education. We used this framework to compare the impact of four strategies: the implemented strategy of twice weekly mass testing plus the isolation of close contacts, a strategy of isolating close contacts alone, a strategy of twice weekly mass testing alone, and a strategy combining twice weekly mass testing with serial contact testing, where instead of isolating, close contacts could take a lateral flow test and attend school if the test was negative. Comparing the implemented strategy in purple to a policy of isolating close contacts alone in blue, we found that the introduction of twice weekly mass testing helped to control pupil-to-pupil transmission over the study period. However, the implemented strategy also led to higher levels of absences than any of the other considered strategies. A strategy combining twice weekly mass testing with serial contact testing in green marginally increased pupil-to-pupil transmission compared to the implemented strategy, but substantially reduced pupil absences. Our studies provide a flexible framework for evaluating the impact of school-level control measures and demonstrate the conflict in the competing aims of minimising transmission and minimising pupil absences.
Dear colleagues, my name is Micha Sofonia. I'm an associate professor of evolutionary epidemiology at the University of Montpellier in southern France. I greatly thank the organizers of this meeting for letting me present here at this honorable house my lesson from the work we have done with the rest of the modeling team I co-lead with Samuel Alizon on anticipating the critical care impact of the COVID-19 to the main French health authorities and institutions. I also take this opportunity to express my gratitude to all the British colleagues involved in collecting, analyzing and communicating data on this pandemic, whose admirable work has not only been inspiring but also enlightening and decisive for the rest of the world. As the epidemic unfolded, a number of essential processes involved in the dynamics of bed occupancy, such as improved care, combinations of non-pharmaceutical interventions, variants of concern and vaccines have gradually accumulated. However, up-to-date field data required to set up key parameters were either lacking or too dispersed in many cases. Moreover, future dynamics depended on numerous uncertain cases. Facing this multiplicity of degrees of freedom, epidemiological modeling found itself having to choose between precision and robustness, between objectivity and utility. Here, I present achievements of a parsimonious discrete time framework developed in March 2020 and gradually improved since, that combined the computational and tractability benefits of deterministic systems and the short-term accuracy of non-Markovian dynamics, taking into account the effect of age of infection on the natural history of the disease. By analyzing the hospital time series of COVID-19 in France, we were able to provide early estimates of the main epidemiological parameters with only limited publicly available data. Since then, the model provided an everyday robust framework used to nowcast the epidemic in France, investigate counterfactual scenarios of public health interventions, and anticipate critical care overload, while gradually updating hospital care kinetics, variant of concern dynamics, and vaccine rollout. The model translated into an online forecasting application, and several published projections and support to decision-making at both local and national scale, including the dynamics of the Omicron sublineages. As a conclusion, I would recall that understanding epidemiological phenomena solely from an empiric approach is almost impossible, and highlight that while models provide suitable frameworks for extracting signal from limited and biased data, they should not be considered as ends but means confronted to reality and applicability, which parsimony as a guideline can ensure. Thank you very much for your attention, and see you at the poster exhibition for discussion.
Hi, my name's Amy Thomas, and I'm a postdoc at the University of Bristol and also a member of the Juniper Consortium. My poster today is on understanding the limits of lockdown through characterising essential social contacts. So back in April 2020, the UK went into a national lockdown, and shortly afterwards we deployed a social contact survey. And with this, we aim to quantify the number of contacts during this unique period of strict physical distancing and understand what factors might affect the ability of somebody to limit their social contacts. So we deployed the survey as part of a COVID-19 questionnaire to the Alsbach longitudinal birth cohort, which is based in Bristol. You might know them as the children of the 90s. And around 6,500 individuals participated and responded to the questionnaire. We simply asked them, how many people, apart from those you live with, did you speak to yesterday? And this allowed us to quantify social contacts into either those with conversation only or those involving physical contact. And we found that on average, individuals had just below 4 contacts a day, which is significantly fewer than 10, which individuals were having pre-pandemic. But we found for a small number of people, there were high numbers of contacts, so up to 250 in some cases. And to understand these drivers, we had a look at what might be influencing them. So healthcare workers in particular had 4.5 times as many contacts as non-essential workers. And this was also true for key workers with 3 times as many contacts. So occupation was a large factor in individuals who were still maintaining their contacts during this period. Because of the rich demographic data, we were able to have a look at household sizes and household compositions. And because of the intergenerational nature of this cohort, we are able to also capture contacts of children, their parents, and their grandparents. And so in January 2021, there was a call for evidence on the relative contribution of nurseries to transmission. So going back and utilising this cohort, we were able to assess potential impacts of school closures on both the contacts of children, but also their parents, and in relation to key demographic characteristics. So this gave us a timely response and gave us detailed insights into drivers of differential infection risks. So I'd be really happy to talk to anybody any further if you're able to come by my poster later.
Hello everyone, my name is Dongni Zhang. I'm a third-year PhD student at Stockholm University from Department of Mathematics. Today I'm going to present our recent work, which is about epidemic models with manual and digital contact tracing. First, let's start with the epidemic model. So we start with an SIR epidemic model in a homogeneous mixing population. Then we add testing to this model by assuming that infectious individuals are tested positive and immediately isolated. We will also refer to this as diagnosed SM rate delta. Then we introduce 2 different types of contact tracing to this model. So we have this manual contact tracing model. We assume that once an infectious individual is diagnosed, each of these contacts will be reached by manual contact tracing independently with probability P, and such trace contacts will be immediately diagnosed if tested positive. Then we have the digital contact tracing here. So we assume that there is a fraction pi of the app users. So once an infectious app user is diagnosed, all of its app using contacts are traced and immediately diagnosed if tested positive. So we focus on the early stage of the epidemic, which can be approximated by a branching process relying on large community. So limiting branching processes are, however, not for the individuals, but rather for we call this the to-be traced components. So we derive the component and the individual reproduction numbers, but I will not show any details here because due to the time limitation of this talk. So first, we compare the manual and digital contact tracing. So here is a plot of the necessary delta measured by the testing fraction here to the corresponding reproduction numbers. So one for manual and one for digital contact tracing equals to 1. And we can see that for any given testing level here, we always need less implementation of manual contact tracing to reduce the corresponding reproduction number below 1 as compared to the digital contact tracing. Finally, we analyze the combined effect of manual and digital contact tracing. Before showing any results, first let's have a naive guess. So if the effects of reducing R0 when having only one type of contact tracing are independent, then if the relative reduction of R0 by manual or digital contact tracing are M and RD here, then we would have the reproduction number of the combined model here in this product form. But is that the true expression for it? The answer is no. And we can see from this heat map of the true values of reproduction number RDM here, we can see, for instance, for this black point here, the reproduction number is below 1, while the naive guess is above 1. So we may conclude that the combined effect of both manual and digital contact tracing is actually bigger than the product of each of the preventive effects. Thank you for listening. If you have any questions, please feel free to contact me by this email here. Thank you.
Thank you very much to all those presenters for excellent presentations. And thank you to the control team for making my job so easy. Thank you. So I think these talks, which were very well timed and paced, thank you all very much, illustrate how the pandemic has stimulated a lot of new thinking across very diverse areas, and really the role of RAMP and other opportunities, convening opportunities to stimulate those discussions. And we're going to take that theme into the next session, where we're very lucky to have Sir Patrick Vallance chairing a discussion on how the scientific community responds to emergencies, lessons from the pandemic. So I hope to see you all back very soon. It will start on time at 3:45. So those of you in the room, make sure you come back in time. But before then, make sure you speak to a number of the poster presentations are here. They're ready next door for your questions. So thanks again, everybody, for the time. They said 3:45.
3:45 it is.
Yeah, so 2 minutes then.
Yeah, you have just time to grab a cup of tea if you need one.
In video form.
Welcome everybody to our afternoon or tea time session. It's a great pleasure to welcome to chair this session Sir Patrick Vallance, who scarcely needs an introduction, Government Chief Scientist, just been knighted for the second time. And without further ado, I'd like to hand over to Sir Patrick to chair the session.
Thanks very much, Mike, and good afternoon, everybody. And can I just start by thanking, I think, lots of people in this room who were so important doing work right the way across the pandemic. And it wasn't just, a few people who might have appeared on the screen or in other places, it was a massive, massive team effort across a very wide community. And I know many of the people here were deeply involved in it and spent all hours of the night and day rechecking things, creating models, looking at data, and I'm deeply appreciative. But if I think about the last couple of years, it's very obvious that the modelling was central to lots of the discussions. It was central to many of the ideas. And of course, it's also worth saying clearly that it was part of the scientific input. And this meeting is about learning the lessons of the pandemic and from a scientific perspective, but it's rather focused on the modelling aspects. But of course, there were many other parts of scientific input which were crucially important. And actually, that integration of different areas is a really important way to get to information which can then be synthesised and put in front of ministers. So I look forward very much to the discussion today. I look forward very much to what our very distinguished panel has to say. And I was asked in my brief to give, one of the things that I would hope for in the future of a pandemic. And I have to say, if there was one thing, not just for a pandemic, but for national emergencies, that I would wish to have right at the beginning of an emergency, not halfway through or at the end, it would be great to know which data you need for decision making because of the information you require, who actually thinks they own those data, how would those data flow somewhere and which ones need to be integrated, where does that get analysed and how does that analysis reach decision makers? Now, a lot of that was present and some of it wasn't present at the beginning of the pandemic. But if you took the National Risk Register and asked the question, as I work through the National Risk Register, is that true for every aspect of risk? The answer is definitely not. So there, I think, is my wish for the future, that sort of structured approach to understanding first the information you think you're going to need in an emergency, and related to that, where are the data that come through to that. But with that, I'm going to shut up and go over to the panel. I'm going to briefly tell you who we've got here. So we have Mike Cates at the end, who's actually was the, as you know, the chair of the RAMP committee. And Mike, I want to take this opportunity to thank you and RAMP. Actually, really, really important, the work you did throughout the pandemic. We have, and Mike is Professor of Mathematics at the University of Cambridge and, as I say, was chair of RAMP. Next to him, we have Professor Oliver Johnson. Oliver, thank you very much. Professor of Information Theory and Director of the Institute for Statistical Sciences at Bristol, who became very well known for his models and commentary on the position throughout the pandemic, and, of course, got quite a big following for that, and is part, I think, of a really important principle in science and science during emergencies, which actually you want lots of people looking at a problem. You just don't want a few people looking at a problem. So thank you very much, Oliver, for what you did. Next is Steve Riley, who, of course, was absolutely instrumental in the REACT study and was an important source of information right the way through, but has now jumped over the fence and is Director General for Data and Analytics within UKHSA, and I have to say was a very, very welcome addition to government. So, Stephen, thank you again. Next to him is Sir John Aston, who is an erstwhile Chief Scientific Advisor from the Home Office, now Professor of Statistics in Public Life at the University of Cambridge. And John actually was involved on many of the SAGE meetings early on, because he was still a chief scientific advisor then, and when he left government and went back to Cambridge, he thought he'd escape, but I knew he lived, so that was okay. And it wasn't long before I was on the phone to him for all sorts of things, including very, very helpful advice on how one might think about presenting some of the information that was coming through. Next to him is Fliss Benny, who is former co-chair of the Welsh Government Technical Advisory Cell and Deputy Director for Technology, Digital and Innovation for Health and Social Services in the Welsh Government. And Fliss was an absolute stalwart on SAGE. She was there pretty much every meeting and brought a very important perspective from Wales, but also brought her own insights on all topics, and I think was an active and very valued member and a great colleague to work with, Fliss. So it's great to see you. And last, but by no means least, is Elizabeth Richards, Libby, who was an absolute star. She was head of the SPI-M Secretariat and Scientific, which is the modelling group. And when we say she's head of the SPI-M Secretariat, it might sound like her role was just making sure the papers for meeting were prepared. Well, I can tell you it was far, far, far more than that. And she has great scientific insights into the issues as well as fantastic organisational skills. And I don't think this audience needs me to say this, but getting a lot of mathematical modellers, epidemiologists and others to work together in the same place over many, many weeks makes herding cats look incredibly easy. And you did a brilliant job, actually, of making it all work, and were a great source of knowledge, information, and extremely responsive. So fantastic panel. I think we're going to have a great discussion. I hope that you are primed with lots of questions you want to ask. I'm going to say what I always say at these types of meetings, which is if for some reason you feel too shy to ask a question in the room, just remember that however original you are, the chances are the question you ask is something somebody else would also like answered, and therefore if you do ask it, you're doing everybody a favour. So please do go ahead and ask the question. With that, I'm going to hand over to each of the panellists to give a short statement, and then after that we'll go into a few questions from me, and then we'll open it up to both the room and those online. So I'm not sure whether we have a specified order for going through this, but I shall start at the end, Mike, with you.
Thank you very much. So we were asked to come up with one highlight and one lesson, roughly speaking. So for me, my experience from RAMP, the highlight is the sheer scale of the willingness of the scientific community to help, right across all parts of the scientific community, every career stage, the modelling community in the case of RAMP, but I feel the same was true beyond that. And the lesson, which I will elaborate on a little bit, is that it's hard to convert that scale of goodwill and expertise into coherent force, which, as some of you may know, we had when we had the original call for the voluntary phase of RAMP. We had over 1,800 responses, many from teams of up to 50 people at a time, which obviously is not what we were expecting in terms of the scale. So we did our best, but I think with a bit more planning, one could be ready to utilise that kind of community power in any future emergency. And of course, future emergencies is not just pandemics, could be anything. Patrick already mentioned the National Risk Register and his thoughts about, where's the data and so on. I was also thinking about that question in a slightly different way. And it occurred to me that something which the scientific community can do, in principle, given an identified risk of, at the national emergency scale, whether it's pandemic disease, a nuclear leakage, whatever, is to identify the scientific uncertainties in advance to the extent that they can be classified into two types. One is the elements of that which can be researched ahead of time in principle, epidemic modelling, etc. Also, in the case of COVID, aerosol transmission, behavioural effects on pandemic disease. These are all general questions which are not specific to a particular incident. And then there's a whole other set of scientific questions which will be incident specific. So it seems to me that for the first type of science, we need to be aware of what those key areas are and to make sure that that research is kept healthy and looked after, even when it's out of fashion between emergencies, shall we say. That involves some, prioritization and strategic thinking at the level of, say, UKRI. But I also think that in those areas there should be an understanding that, in principle, when it comes to modelling, you have software infrastructure which is being created that could be the basis in future of decisions involving millions of people's prosperity, billions of pounds, and that the investment to make sure that software is fit for purpose in that sort of setting is something that needs to be made as we go along and not try to cobble together at the last minute. And then secondly, for the incident-specific science, what it seems to me is needed is an expandable expertise base, whether that, which is what RAMP managed to do the expansion of, to some extent at least. So that means, I think, having some idea nationally of where the expertise is that you might need for different types of emergency, and also possibly in the kind of spirit of the territorial army or something, at least at senior level, people who would be willing to convene or bring together task teams if and when a response like the one to the COVID pandemic is needed again, possibly on a completely unrelated aspect of human endeavour.
Thank you. Oliver.
Okay, thank you. I guess I'm going to find out today whether it's possible to actually have fatal imposter syndrome. I've been experimenting with this for a while. I have to say I'm not in any sense a modeller, so what I'm doing sitting here on a stage full of distinguished modellers is a slightly strange question for me, but I guess I'm here as a representative of COVID Twitter, which some of you may be aficionados of, some of you probably are lucky. Twitter is a wonderful place where you can type your thoughts, and people from around the world will misinterpret them back at you very fast. And, you know, around this time, a lot of days over the last 2 years, I've been plotting very bad graphs of numbers as they've come off the dashboard or from wherever, and, you know, trying to give some kind of commentary, say how things are going. So I think the lesson I would like to propose is that actually this has been a wonderful community. I mean, we've heard a lot today about RAMP and what a wonderful community that's been, how academia has been mobilised into this. And some of the talks from early career researchers in particular is very inspiring, how, you know, early career people stepped up into this. But also in parallel, there's been this community of, I've used the word nerds before and nobody's complained too much, so community of nerds who are, you know, from a variety of backgrounds, often people who've done a degree in a numerate subject, but not people who are in academia. And there's a lot of people out there with very impressive skill bases, interesting perspectives, and because of lockdown, a lot of time on our hands. So sometimes we've had the time to go and find strange sources of data that nobody else had particularly thought of looking at. And I think it is this many eyes principle that has been valuable. So we were asked to propose a success. I think one of them, the one I'm perhaps most proud of, was when I realised sort of early on, when lateral flow tests were still quite controversial, there was a sort of sense that lateral flow tests maybe weren't so useful because the false positive rate was too high. I realised that on the Scottish Government website every week, they put out data for how many lateral flow tests had been taken and how many were positive. And they broke it down by region. And so I realised that if you went to the Orkney and Shetland data, and you assumed that every positive test in Orkney and Shetland was a false positive, you could get an upper bound on the false positive rate of about 0.03%. You could see that no more than 0.03% of lateral flow tests could be false positives. And so it's the kind of thing that you could do, you know, with time on your hands, a bit of creativity, and the wonderful sort of public data that we were being given. We had the opportunity to do this. And there are a lot of stories like this, a lot of kind of cases where people have spotted something, the bar to entry is very low, you can spot something like that, you can put it on Twitter, somebody will retweet it. It's, like I say, it's sometimes been an unpleasant place to be, but overall it's been a very positive place. And so I'd like to think about ways in which we could bring that community into the discussion in the same way that academia has been brought into the discussion through RAMP.
Thanks very much. And as you say, a very clear demonstration of why making data public is rather important. Stephen.
Thanks a lot, and thank you everyone for coming today in person. I've just realised I think it is my first in-person talk for a very long time, so suddenly feeling very different from the screen in front. I might, just before I start, echo Patrick's thanks. For me, the pandemic was spent mainly as in a kind of scientific advisory role, working in an academic team, but then the last part of it was kind of within government, and I really got a very keen appreciation for the value of the work provided by the academic community. So I would echo that thanks, and we, people in government really do understand the intense work that goes into every single line, every single point, and every single conclusion. I think so. We were asked to pick one thing that went well and one lesson to be learned. I might do one thing that went well and two lessons, if that's okay, as quickly as I can. The pre-printing really worked this time, and we've been trying for a long time during public health outbreaks to get pre-printing to work, and I think it properly did work this time. So the quality of, either formal preprints or reports put onto group websites, the quality of that work was very high, and it was very, very fast. And then we had Twitter, which acted as the vetting service in real time. And then these papers went into peer review, and there was a lot of additional value through peer review, which we saw when the final articles came out. The younger people out there, don't underestimate how long it's taken us to catch up with physics, who I think arrived here in about 1990. So that was really good. I don't think we'll ever go back. And most of you out there wouldn't even think about not pre-printing something really interesting now. And that's a fantastic place for us to be. And the editors at the very influential journals have got no recourse anymore, I hope. So that's something that went really, really well. I'm going to try and be a little bit controversial in my lessons learned. So the first one, and it makes sense to talk about modelers and groups of modelers here today, because this is a modeling science meeting. And we all understand what it means. We love to create artificial representations of a system and play with it and do results and generate experiments. I love that, and it's my favorite morning is to sit down, do a little refinement on a bit of code and get some new results. A lesson learned for me is that when we communicate outside of our community, we need to really focus on the system that we're generating evidence for rather than the method that we're using. And it sometimes feels like a subtle point, but I think it's really important. We're asked questions about what might happen next, why something's happened, and we just need to consistently frame all of our communication in terms of the system that we're generating evidence for. And then just to reflect some of Sir Patrick's earlier comments, it will all fit nicely with evidence from other sources for that same system. I feel a little bit at times the method we used got way too much weight rather than the questions that we were attempting to address. So that's something that I would really urge people to kind of try and promote as we go through, and then into the next emergency. Let's just really focus on those systems that we're generating evidence for. And then finally, and I was a little bit late this morning, but I did sense somebody distinguished between forecasting and projections. So I'm going to be controversial again here. I don't think we can redefine commonly used words. I think if we have a chart that's got time access, the time axis goes past the current day, and there's a line going off to that side of the chart, then we are making forecasts, whether we like it or not, and sometimes we really don't like it. And I think we need to, as a community, think a lot. Some of those should be tested, calibrated, run against historical data until they bleed, and we should be able to say exactly what all of those lines are doing. And then some of them can't be. When we're really doing what we call scenario analysis, we can't validate those in the same way that we can validate short-term forecasts. But at least when we've got both types of projection or forecast out there, then we can really say precisely which type of output that we're doing. So those would be my two lessons learned: focusing on the system and being just a bit more streetwise about the use of forecasting.
Thanks, Steve. John.
Thank you. And so, likewise, I would like to say just how much I personally was amazed and so grateful for so much of the input that came in while I was CSA at the Home Office. And, the modelling that we had access to was, pivotal in actually being able to make the decisions. I think for me, the sort of things that went really well and the lessons are sort of linked together. One of the things that worked really well was the fact that the Home Office is predominantly a social policy department. and the things they think about are social policy problems. Yet suddenly modelling became massively important, and I think it had the opportunity to change the culture of how people saw the link between modelling in all sorts of areas of government, not just within very specific areas. Suddenly, routine questions that what were usually deemed outside the sort of scope of science had the question of, but what's the COVID implication? What's the models going to say about this? And that was a hugely powerful thing to actually change how people thought about the use of modelling in many, many areas of government, and particularly in areas which traditionally hadn't had that kind of access to modelling and thought before. And I think part of that was the fact that suddenly there were some really, really strong collaborations going on within government and academia together. I mean, I think you've heard many already. One that I want to particularly draw out is the COVID infection survey that ONS did, which had huge academic input behind it from Oxford and Warwick and Manchester. And really, the way that was brought together to get a set of data that really, was, basically unique to the UK, but that gave so much insight into what was going on, but really couldn't have happened without really good collaboration. And I think that is, something that is testament to the fact that government and academia in times of crisis really can work together. And if they do, they can have all sorts of really lasting impacts. And that wasn't just in that area, in many areas of the Home Office, being able to ask academics to really sort of pull information in a very quick time and then push that through into the policy process was really, really important. But the lesson I learned was actually sort of on that subject too, and that was the feedback mechanism. The feedback mechanism in academia and the feedback mechanism in government is very, very different. I put a paper in academia for review. I expect someone to come back and tell me what they think of the paper. That's not always what happens at government. You put a paper in the system and sometimes you don't hear back what happened to it. Now, many people commonly assume that means that it didn't go anywhere, it was ignored, disappeared off the radar. In some sense, some of the most influential papers were used and taken forward, but I'm not sure that people ever knew that. And I think that understanding that in actual fact feedback is important in both ways, that academics really do need to understand how their work is being used, because then they can design better models the next time and they can help answer questions that came out of their thinking is really important. But it's not always going to be possible that you get all the feedback you would want from government, and I think understanding that that's a difficulty is something that both sides can work on, and similarly for policymakers they can work on. In actual fact, it is worth spending that time giving feedback, but also understanding that hopefully academics won't necessarily think that just because they've not heard back immediately about a piece of work that work is not considered useful. So I think learning that lesson of the fact that feedback is very important and it really should be shared as widely as possible, but it's not always the two different cultures don't always come together perfectly is something that I think is worth everybody knowing.
Thanks, John. Fliss.
Thanks. Not wanting to go over things that other people have said before, and really I think agreeing that many of us learnt the same lessons. I was really interested in the number of people who've spoken on this stage today who've talked about the fact that no matter how many different factors they took into account, it ended up being adherence that was the one overwhelmingly that made a difference in what our models were going to show looking forwards. Apart from the sort of basic lesson that we all need to be educators and communicators to help people who are not specialists in our areas understand that a model, even when it looks into the future, is not a prediction. I'm not telling you what the future is going to be. I am telling you what the future could look like under a very specific set of circumstances. And understanding that there are going to be different users of the models that we create. Our operational users in the public health sector needed to know what the reasonable worst case was going to be so that they could plan for the worst thing that could happen. Actually, it probably took us a little while longer than it ought to for us to realise that our policymakers wanted to know what was the most likely scenario, something which is obviously far harder until we can get enough data to start to iterate our models. I think, building on what colleagues have said, one of my lessons is we need to have better baselines. We need to have a combination of data that shows us what a regular day in UK society looks like across as many different data points as we can, so that when something happens that's an emergency, we can see how far we're diverging from that and how fast. And I think we put so much effort into gathering as much data as we possibly could from the start of the emergency, but we find ourselves quite loose on the ground. The other two things are psychological safety and well-being. I think we should have made sure that scientists, specialists, analysts had a space where they could discuss and interpret and peer review the findings that we had from as many sources as possible before we went to people in the policy sphere and the operational sphere. Because having people who talk different languages in the same room listening to the same things can lead to unfortunate misunderstandings that it takes unnecessary time. Also, even though we weren't on the front line, the many people across academia and across the public sectors who were working on really quite terrifying models that showed a huge amount of harm, especially when we were looking exponentially at things that were already baked in for 2 or 3 weeks. We offered, and thanks to Patrick and to the whole of the Go Science community for offering sort of support to people. But I think if we had been able to, from the beginning of the emergency, bring in more people from early and mid-career up to observing and buddying and deputising for and being able to take part in the senior peer review and advice giving functions, then we would have been in a situation where if somebody got tired or got overwhelmed, they didn't feel that they had to stay. It was brilliant that everybody stayed, nobody quit, but we shouldn't have had to keep going for 2 years without a break. So buddying, baselines. Thanks.
Please, Libby.
Well, I mean, if Oliver's got imposter syndrome, I think I definitely do on this panel, but I think I very much saw, as Fliss has just described, the effort that was put in by a lot of people in this room and the rest of the wider modelling community that was spectacular. Our role in the SPI-M Secretariat was very much as the translators of both the questions coming to us to try and make something that was actually modelable and be able to take that analysis and turn it into something that people with very different sorts of backgrounds and generally limited numerical understanding or scientific understanding to be able to actually make very important decisions off the back of, and yet for that to be usable in the public domain as much as it was by those decision makers and still make scientific sense. I have never seen a community work quite in the way that SPI-M's contributors did, and I echo everybody's thanks along that what we've already heard. As Steve said, we were asked for one highlight and one lesson, and I'm also going to steal and have possibly 2 lessons. But my main highlight actually was around the period of the roadmap out of lockdown in 2021, simply because we'd almost had a year of doing stuff. So we knew how to get the best questions. We knew how to turn those into modelable questions to academics like yourselves in the room. The modellers had had practice at being able to actually answer the question in ways that were usable, could still communicate the uncertainty and actually put that across in a way that we were then able to take back up the chain. The systems and governance in government itself had sort of made it, had turned into something usable rather than a bit of a panicky mess, which it was more like at the beginning. And as a result, actually that period was very sensible decision-making, very much based on evidence. I would go so far as to say some of the best that I've seen in government. Slightly looks Patrick as to whether or not that's a fair comment. But it really was. It was fantastic. And I think the fact that, if those of you who remember, step 3 happened, but step 4 was delayed. A lot of that was based on evidence from people in this room, but also that cross-specialism that both Patrick and Fliss have mentioned as well. When it comes to lessons, I think there is one for government and possibly one for the scientific community. Again, building on what Patrick was saying earlier about data, getting the data right, getting the data accessible, getting it to everybody who needs it in a safe, secure and fast way made all the difference. And actually, I would really like to thank some people who I don't think are probably in the room, who are the Defence and Science Technology Laboratory, without whom we wouldn't have got data to SPI-M, we wouldn't have been able to do what we did. And they were absolutely fantastic. Also, thanks to UKHSA, because they're still doing it. But again, that importance of data in the pandemic was absolutely vital. A lesson for the scientific community, and I've slightly hinted at this already, is if you are dealing with anybody in government, the odds are the last science qualification they have might be a GCSE. And that means the way to communicate is very different from probably everybody in this room. I think actually one of the reasons SPI-M Secretariat worked really well is that the three leaders all have PhDs in science subjects. Even our analytical community is very heavily maths and not science. And I think that integration of science and analysis into policy is one of the interfaces that you guys can help us by, as Steve said, thinking about the system rather than the model, if that makes sense.
Brilliant. Sorry.
No, that was it.
That's brilliant. And thank you very much, all of you, because I think that's given a glimpse into how you saw things. And just, a few things that came up in this notion of community power, I think, is incredibly important, both in terms of this scientific community, but way beyond that, out to others as well. The notion that actually making sure that data are public, I think, comes out as crucially important. The ONS study, which John mentioned, very often we're given to hyperbole and saying something was world-leading and incredibly valued around the world. That actually was valued around the world. People looked at that, and indeed the REACT study as well. They looked and said, we can see what's going on in the UK, we can't see in our own country, and they learned a lot from it. And I was at a meeting of European science advisors on Friday in Paris, and they were all saying they looked at this regularly. And then Libby's point about the importance of the way in which the knowledge had been accumulated to allow that release from lockdown to occur in a sort of an appropriately staggered way. And you sort of casually said, and the last stage was delayed. That was not an easy decision, and it was only possible because of the quality of the data. So let's move on, and I'm going to start on the optimistic, positive end of things, and we'll see where we go thereafter. But what do you think, as individuals, have been the biggest achievements of the model-based research that's taken place over the pandemic, either in terms of how the scientific community might see it, or from those in policy? And we've just sort of had one in a way, the last one, so I won't come to you first, Libby. You've leant forward, Steve, so you're going to go first.
I was just looking forward, thinking I won't have to go first, so I can think of a highlight and not claim to have thought for long, because that's what I'm going to do. There are lots and lots of highlights, but I am going to call out the app work. I wasn't really involved in that. We did some work in the mop-up after SARS-1, thinking about features of pathogens that might make them controllable or not controllable. And I think a number of groups, not just the Oxford group, but a number of groups really piled in on those ideas. And they discovered some really fundamental relationships between the contact networks, the pathogen, and likely impact of high coverage, fast contact tracing. And then the app went into the field, data were gathered, how very difficult to access and analyse with lots of, but data were gathered and it's been analysed. And we've got some absolutely concrete estimates based on these data for how that system proposed. So I think there's a complete life cycle of idea, impact and measurement there that I think is a really nice case study. So that's not necessarily the best thing, but that's my first highlight.
And as an achievement, what allowed that to occur?
So, an awful lot of resource went into it very quickly, and there was some fantastic science at the very beginning, and then I think from what I could see from the outside, a lot of very talented non-scientists, programmers, business people, marketeers, a very large team went onto it very quickly, and they achieved a huge amount. But I think the underlying science from multiple groups was very good as well.
Fliss, can I come to you? And what do you see as the biggest achievement for the model-based research?
So I think there are two sort of highlights that come to mind for me. One has been the work that we've done on NPI modelling, on the concept of taking research papers from across social psychology, across a variety of different health and behavioural areas, and turning them into a set of indicators that we can use to model the reactions to policy changes in government. Ellen Brooks-Pollock has been doing lots on that as well, and it's been fascinating seeing that interact. The other thing I think that's been an absolute winner for me has been seeing people from very different disciplines come together to change the way that they set their model parameters. So we had a fluid dynamics modeler who didn't have the power to model in 3D, so they'd set up a 2D alternative which they could run in a couple of hours rather than a couple of days. We had some data scientists who shared with some who shared with some of the bootstrap modelers who needed supercomputing time, and said, oh, you can do that with some virtual machines in the cloud if you want. You don't need a supercomputer. We can just do a distributed supercomputer. So expanding the bounds of what we can do, whether it's stochastic, whether it's Lagrangian, whether it's kind of different Bayesian models. The fact that we're able to take those and show a mixture of analysts and multidisciplinary specialists how to make something that's going to answer a question in real life and pragmatically, that's been huge.
Thank you. Oliver.
It's an interesting conversation because a lot of what we've been focusing on, I think, feels like phase one, that a lot of the discussion today has been the sort of modelling of NPIs up to July the 19th. And then since then, that hasn't been happening so much. And actually, the landscape feels very different. It's been driven so much by these variants that have come in at particular times and swept in. So I think one of the real successes, one of the things that's made it easier as a rank amateur to track all this, is to have the availability of these variant percentages. Once you were able to see those being released almost in real time and publicly, then it was possible to get a sense as to where this was going. So I think if there is a success, we talked already about releasing measures on July the 19th, and there's also another turning point, which is that when Omicron first came in the UK, if you were tracking those percentages, it was on something like a 2-day doubling curve, and you didn't have to look very hard to work out where this was going to go. I mean, I think the figure was going to be 1 million infections a day by Christmas or something, wasn't it? And actually that didn't quite happen. So I think the fact that, and I suspect it's people in this room that were responsible for this, but the fact that the brakes went on just enough that, whether it was the rolling out of the booster campaign, whether it was the just putting in the little extra bits of NPIs that did come back in, but somehow we moved off 2 days, we moved towards 3 days, maybe even more than that, and we did have some kind of Christmas. I mean, I think that's a success as well. It doesn't always have to be, we did everything, we put in maximum NPIs, that to come through with somehow the right level of NPIs, that we were still able to do things, that feels like a huge success to me.
Interesting. And in that context, the actual sort of self-modulation by the population is quite an interesting concept. Mike.
Interesting you mentioned that last point. So I'd like to think, well, obviously huge amounts have been done. I don't think, it's not clear to me, from my perspective, what the highlights are in terms of individual pieces of work. But there's something which is a little bit maybe more forward-looking, which I think is a highlight from the point of view of the emerging science. And that is the conversation which has really begun between quantitative social scientists who, you know, have models of cities and how humans move around in them and so on, and via the academic, but I think more generally the medical sphere. Because I think there's lots of questions in public health, not just transmittable diseases, but connected with poverty and diet and advertising. And there's this large community of people who are not thought of in the physical sciences and are not really thought of in the medical sciences either, with things that they can bring to the table. And I think for me that's opened a doorway to a future perspective on kind of integration of social sciences, mathematical modelling and the medical domain, which I certainly the start of this I had no idea was, you know, on the agenda even potentially.
I think it's a really interesting point, and it's true in other areas as well. This true multidisciplinary approach, interdisciplinary approach, people working together who normally wouldn't work together, has been really enlightening in all sorts of areas across the pandemic. And almost to a person, they've said, goodness me, this has changed the way I think and the way I work, and isn't that exciting? I really, really hope we can keep that. And I really hope that funders think about that as a particularly big advantage of what we've just seen. And, you know, three of you have just mentioned multidisciplinarity, pragmatism, sharing as issues. John?
Yeah, I mean, I was going to say exactly the same thing. I think at the beginning, you know, really early on in the pandemic, there were times when, you know, I would ask a question and I would be told, oh, sorry, my model doesn't do that. And it was very, very quick that people started to realise, what's the question you have? Oh, I'll try and find a model that does that. And that flip and trying to work out how questions from all over the place, many, many different areas, could bring, you know, questions that could then be turned into things that could be, that people were willing to have a go at modelling, rather than starting with the model and say, these are the questions that can be answered, and if this is not one of my questions, then sorry, was amazing. So I think that kind of willingness for people to try and, you know, really model the questions that were really needing to be answered was something that, you know, got steadily, you know, more and more impressive as the pandemic went on, and I think, you know, is now we're in a good, you know, good position, and we want to keep that going.
Libby, you sort of kicked this round off by saying what you thought the biggest achievement was. Is there anything else you would highlight? Or?
There is one thing which actually goes back to the collaborative nature of the community, in the fact that SPI-M's internal conversations were one of the few times, very sorry I say this as not a professional academic in any way, shape or form, but getting the community together in a safe space where you could bring early results, challenge each other in a way that was constructive and helpful, rather than possibly the more public image of research groups shouting at each other and you know, being adversarial rather than collaborative. And certainly within the SPI-M meetings, we very much had a culture of, I slightly wish Angela was here because it's her phrase, of tell me why I'm wrong. And that was a fantastic environment for all of us to learn where to go next.
Great. Look, and by the way, as we go through this, if you disagree with what somebody else in the panel has said, do feel free to come in and tell them so, because that will liven things up. But thinking beyond pandemics and thinking beyond simply this pandemic, what are the lessons that government and policymakers should take on board for how it uses model-based science advice? What would be your advice to government?
Can I jump in?
Have a go, Libby.
My first and foremost, I think one of the reasons the roadmap timing worked so well was because we had the most senior folk in the room with the decision makers. That's not just yourself and Chris, but also the Cabinet Office actually had an analytical and scientific centre at its heart that was talking to us, to SAGE, and were much more involved than they had been earlier in the pandemic. And having that nucleus so close to the key decision makers massively helped. We had those relations. They were coming to SPI-M, they were hearing it firsthand, and they understood it almost, I would say, as much as we did, and that helped in the conversations at the time.
also helped them, I think, be able to frame questions.
Absolutely.
Because they could understand what was possible and what wasn't. Oliver, what about you on this one? I mean, you may have observations beyond modelling as to think about other emergencies as well. What do you think would be a lesson that the government should learn?
I think there's maybe a lesson, and I think it's not just government, I think it's scientists here as well, about communication, because I think, so my job title is Professor of Information Theory. So information theory is to do with sending signals in the presence of noise. And so there's one kind of noise which is basically random noise. Things get flipped at random. And you can study that. That's relatively easy. And there's another class of noise which is adversarial noise, which is where somebody deliberately jams your signal. They do the worst thing to your message that they possibly can. And I think maybe some of the communications that were sent out in this pandemic were sent out in the spirit of, well, we're in this random noise environment, you know, it may not get through, but it doesn't matter. Whereas actually, I think some of the time people were deliberately misunderstanding, deliberately misinterpreting, taking the worst interpretation of these things. Yeah. So, you know, we've all seen these articles where, you know, scientists predicted 6,000 deaths and that didn't happen. Stupid scientists, how can we trust modelling again? And it's hard because, you know, that's in some level what the model did say, right? I mean, you know, if you went up to the top of the exponential curve, it was there. But I think somehow we have to do a better job of explaining uncertainty, you know, explaining that models come with a range of values, that you can't take the lowest one because you want to make one point, you can't take the highest one because you want to make some point, that, you know, all the things within the shaded bounds are possible. And then, I guess related to that, to bang my favourite gong, is the log scale gong, that I think some of these things would have looked maybe not so obvious to the public, but some of these things where the prediction was out by a big factor, we know as, you know, scientists and mathematicians that that's not so much the case. That what it is it's you have two slopes, you put the wrong slope on the graph and run it out for long enough. It doesn't look so bad on a log scale. You do it on an exponential scale, on a linear scale, it looks like that. So I think there are messages like that to do with just, you know, communication and the way that some of these messages can and should be put across.
Yeah, I think that's a really interesting point. And of course, I'm not sure that as a result of this conference we're going to be able to stop certain newspaper journalists and editors from choosing the thing they want to show. But you're absolutely right. It is key that we at least articulate that in a way that people understand it. And it's a big challenge, I think, for scientists that A, that communication of that uncertainty, and B, the scientific method means that when you've got new science, you're quite happy to overturn what you thought before. That is science. In politics and in the media, that's called a U-turn. And that is a really important sort of distinction to be aware of. Mike.
So, at the risk of slightly echoing something I said at the beginning, I think one of the things that the government needs to learn is that science comes in various types, and a lot of investment in science is thought of, if you like, as venture capital type investment. It's not hedging investment. So obviously, if you want, great discoveries, you have to fund blue skies research, and this is absolutely, we'd die without it. But at the same time, there is research which is needed as a defense against uncertainty, which may not be in fashion, may not look exciting, may tend to get negative referees reports from other parts of the scientific community because they see much bigger gains in their own areas or whatever. And that needs to be, those areas where that's important, they need to be identified and whether protected in some way, whether that's done through a different style of funding or something. But it's to whatever extent any big negative outcome is predictable, and most of them at least, they're not complete black swans. They're things that we knew could have happened. Then you want the science base to be there so that you have something to expand and build on. Yeah. I'm not saying that wasn't the case here, but I'm just saying that in many areas where that might apply, that's not seen as cutting-edge science at the moment.
Yeah, okay, that's important. You made that point. I think we'll come back to that in a minute when we think about funding mechanisms. Anyone else want to come in on this one? You know, a lesson for government for the future. John?
Just one thing is that, you know, modelling's not just for emergencies. I think that, in actual fact, the more we can have modelling as a sort of routine, that this is always incorporated into what's going on, the easier it will be for both sides. It won't be that suddenly modelling, you have to explain to every official, every public servant about what a model is and what it isn't, because they'll see them routinely, and therefore it will be a sort of natural thing. And vice versa, it won't be for you know, the academic community and others. This steep learning curve of what happens to models when they go into government and what happens in decision-making processes and how do they use models, because they'll be part of that too. So I think the more we can make it routine, the easier it will be when it becomes an emergency, because emergencies often just mean things go a lot quicker. The processes often, you know, are similar, but they just get massively compressed. And that means the learning time to be able to understand what's happening in that process is also massively compressed.
And actually, that's to some extent picks up your point, Mike, because if that were the case, you would keep some of those other disciplines going. Anyone else want to come in? Please.
Just briefly, trust is something that's built up over a factor of time, but we do need to maintain and develop trust between public sector officials and scientists so that they feel comfortable asking questions and testing and asking what's the opinion. I think in terms of our openness in relationships, we need to encourage that fundamental scientific principle that the spirit of curiosity is key. You can't trust in the science, you have to enthusiastically and curiously question to sort of seek to minimise over time those uncertainty bounds to come closer and closer into where the likely true point is. And being able to do that needs us to have relationships that go on over a long period so that people don't sort of go, don't know you.
Yeah. Okay, I'm going to move on to the next question. So here's an observation followed by a question. Colleagues in the weather forecasting world would look at what was going on and say, well, we don't do it like that. We do it a different way, and we interact with each other in a different way. Do you think that the pandemic and what has happened, and to some extent you sort of started to touch on this, Mike, you touched on it a bit, do you think it's changed the way modelling in this area is going to be done going forward? And if so, can you give me an example of where it's changed? And Steve, you're again in the middle, so I'm going to come to you.
So I think weather forecasting and the models used for weather forecasting is a good analogy. The models are not the whole of forecasting. If you put someone outside and they look at the sky, they're going to make some kind of forecast. And then if you need more accurate information, you go looking for better forecasts, and often you'll end up getting a numerical forecast that's going to help you with some decision. It's taken well over 100 years for that data and tech to evolve together so that we can all rely on it and trust it. So I think for epidemic modelling, we've got to acknowledge that we're at least 50 years behind, and we've got to invest in both the data and the analytics. I think that's the other point that gets forgotten. We've mentioned REACT and ONS quite a lot. They both came into being at a point in the pandemic where a lot of the current situation was being informed by models, and it was a very difficult modelling question to disentangle the different biases in the other data sources. But because resources were available, the decision was made to just go and get the data that would tell us how much infection there was in the community right now. So going forwards, we've got to think about investing in both the data and the analytics. And, you know, the kind of peacetime analogy, we've got to find the problems where it's worth investing and kind of get on and do it. And then that'll be the platform for the next emergency.
Did you see anything change in the way modelling is done during this pandemic? Did you see, or was it basically people came in with what they did and they just did it faster and interacted with each other?
I think over the course of the pandemic, it was much more collaborative in the true sense. The vast majority of code was open, it was discussed across multiple groups. Important problems had multiple modelling evidence provided for them, and they could be compared, and it all happened in a very transparent and rapid way. I don't think that was the case prior to the pandemic. So I think that general way of working is new, and I hope that that will continue.
Please.
I think, I don't want to say the destruction of the ego, but it really was interesting. And by the way, uncertainty comes out in weather forecasting as well, doesn't it? Because people look at their app and they say, oh, it says 80% chance of rain, so it's going to rain. And then when it doesn't, they get furious that they brought all of their wet weather gear. You know, we need to better understand uncertainty. But we've really only seen it from within the UK. I'm sure you've had much more conversation, Patrick, with people outside, but I've had colleagues in Australia who've said, we didn't get to the point of having multiple models because nobody would agree to let anybody who wasn't a specialist in their area peer review their model. One of the things that we really did very, very well as a community was accept that whilst some models are going to be particularly good for assessing very specific things, actually there is a huge benefit to all of us from taking in lessons from people who use very different techniques and technologies. And I think the whole community is strengthened because of that. Long may it last.
Libby, did you see any changes in the way people were working or types of approaches they took?
In some ways, I slightly wish, and somebody I definitely should mention is my full-time job share, Tom Irving, who, again, many people in this room know, because I started working in SPI-M on the 20th of March 2020, and therefore I am less aware as to exactly how stuff was done in peacetime. But I think one of the... well, there are 2 points to it. One of them is how SPI-M came to a consensus is bringing different models together to basically come up with the principles of this is what the modelling can tell you and that is why it's helpful for a decision. But SPI-M as a group grew over the course of the pandemic very deliberately to bring in that diversity of approaches. We had different people doing more localised models or slightly more statistical rather than EPI, and that diversity and, again, we go back to the collaborative point, I think really strengthened as time went on. It sort of started with 2 or 3 groups that did a huge amount of work, and the smaller groups got bigger and bigger and bigger in their impact as they started doing different things, and that diversity was brilliant.
And that sort of specialism was important. And actually, it goes back to Oliver's point. You know, one of the reasons that there were multiple different models was that. But of course, you could look at it and say, well, no one knows what they're talking about because they're all so different.
Indeed.
Anyone else want to come in on this question of how things might have changed in terms of the way in which modelling is done?
I think Mike touched on it already, but I think there's maybe, certainly from my point of view, a greater appreciation that this isn't like weather forecasting because it involves human beings, and human beings, God bless them, are messy at the best of times. And, you know, there's presumably a version of the SPI-M model where Harry Kane didn't score the rebound against Denmark, and therefore we didn't go through to the European Championships final, and therefore the peak was 5 days earlier and lower. You know, there are things like this that you cannot legislate for, you cannot predict. And so I think we almost have to have some humility in the face of that. And I think, I wonder whether there's sometimes a problem, again, it comes back to communication, but sometimes it's a sort of top-down thing that, you know, for example, I think people had this idea that, well, everybody will get the vaccine if we just explain it to them properly. You know, if enough people with fancy titles explain to people who haven't had the vaccine, everybody will eventually get it. And I don't think that's the case. I think that you have to engage bottom-up as well. You have to find the people that don't want to take the vaccine, to understand what their reasons are, and, you know, to understand that it's not going to be 100%, and these kinds of things, that people are difficult.
And actually, that interaction between social sciences and mathematical modelling was something that was very, very clear during this. It was really important, and I think both sides have said how much they valued that, and I hope that's one of the things that will be kept going forward. If no one else wants to come in on this one, I'm going to give you one last one before we open up to the audience, and both online and in the room. So what are the implications, do you think, of what we've just discussed for how funders, UKRI and others should think about it. And don't just say they need to give more money to modelling, please, but I'd be interested in your thoughts about what needs to happen. Mike, do you want to kick off?
Well, I don't think I have to repeat myself for a third time, but as I say, I think there are certain areas of science that you can identify as consistently long-term requirements for, if you like, as a hedge, and the way in which funding is put in those areas needs to be more managed and less dependent on the vicissitudes of just unmoderated peer review, which does not mean take lots of money and throw it to second-rate people. You know, these are not second-rate people. But I'm just worried about areas where, in fact, maybe the science barely exists anymore because maybe it was all worked out in the 1950s, as far as we know, for certain kinds of chemical leak or something, and we'll be faced by maybe a slightly more black swan style emergency, and we'll realise that actually the science we have is 50 years old and there's nobody doing it anymore, and that's a bit of a worry for me.
John?
So, I mean, I think for me, and we've mentioned it a lot, is the collaboration point, and the fact that, you know, the pandemic was not answerable by a single discipline. And I think that, you know, the remit of UKRI is to try to bring multiple disciplines together, but I think we need to fundamentally work out what that means and how we go forward. And I think that we've seen that it really can work, and there are now really good examples of, you know, multiple disciplines coming together and really solving problems. What made that really work, and can that be replicated outside a pandemic? And if so, what are the mechanisms that UKRI and others need to put in place in order for that to happen? And I think really recognising that an awful lot of science, as really, really well demonstrated by the pandemic, is no longer fitting in one little box, is going to be really important, and understanding how to do that is going to be, you know, one of the big challenges.
And as you know, bringing together the national core studies of different disciplines to bring people together to try and answer problems turned out to be a way to do that. Interesting to see what can happen during normal times, whether that can be maintained in some way. Steve?
So, should be more data for modellers, obviously. But there might be high value in trying to fund the glue to create the data sets that will bring modellers together. So weather's not the only example that's really useful to look at. There's protein structure prediction. It's got a long history of quantitative work that was pretty bad to begin with, but they organise a central agreed data set, some formal forecasting challenges. People kind of find their own funding, and then that field powered forward around these agreed data sets and agreed questions. So I think that's somewhere to put a relatively small amount of resource and let it kind of attract in funding from other places. For stuff that government agencies can't really spend on money just in the hope that it creates a community, but maybe the funders can look at that.
Yeah, that's interesting and important, because that's often the most difficult thing to get funded, actually. Fliss, do you want to come in on this?
I think we need to think not just about data for models, but models should be more like data. We have the FAIR approach. Models perhaps should consider being free, accessible, interoperable and repeatable. How do we make it so that a model that's been created doesn't just live and die with one group of researchers, but is something that can be modified, added to, taken to another set with easily exchangeable underlying factors? So why is it that I have to build a new model in Wales because the one for the UK is skewed towards the population? Why can't I just change it and plug in the geographic and the demographic data for the model that's been created in Nigeria or the one that's working in Utah? I'd like to see us being coming down more towards openness and collaboration than towards closed and proprietary. Thanks.
Okay, I'm going to open this up to the room now and those online as well. And you can either just ask your question to anybody, and I'll direct it towards somebody, or you can choose somebody and put it directly to that person if it's a specific question. And I'm not going to ask everybody to answer every question. So I hope that the Slido system is open for those online. I've got mine open here, and I hope I'll see them when they come through. Who'd like to kick off in the room? There's a question at the back there, and then one with Julia here afterwards. One at the back.
Two quick micro questions. The first one is, and this follows on from the repeated comments about the accessibility of data. So people, PhD students, master's students only get good at stuff by doing it again and again and again, including model calibration or inference of parameters. But when I was a PhD student, that was probably the smallest part of becoming an epi modeler, simply because there weren't that many data sets. Would funders consider shifting their funding to require a certain amount of model calibration or inference and force people basically to tie up with stats departments? And the other real micro question is, CDC in the States had, I think, a really cool resource on pooling all the different modelers and their like 4 weeks ahead forecasts, using that word. And I didn't see that in the UK. I may have missed it, but it wasn't heavily publicised, didn't exist. Would that be something people would want going forwards?
Okay, good. So on the first question, I'm not sure anyone can answer on behalf of the funders, but they could say whether they think it's a good idea or not. John, do you want to have a go at those?
Yeah, well, as a statistician, obviously anything that says that stats is important, I'm not going to disagree with. But I think that really working out how we can make all the parts of the model building process important is really key. And I think that is having access to good data is really important in model building. And so I think that different ways of doing that is important. You can get good data, but you can also work out how you build, particularly if you're trying to train students, how you can build representative simulated data sets that could potentially be shared very widely. And I think that we shouldn't just think about sharing data in the sort of gold standard of collected data. It can be shared data in many different ways. And I think, good shared simulated data sets are often as valuable because you actually know what's going on in them, as data sets that are, coming from the population.
And Libby, do you want to forget the second part of the question?
Yeah, I am going to slightly disagree with Stephen on language around forecasts versus projections. From March 2020, we started doing sort of 3-week forecasts that did combine as many models as those that SPI-M gave us into a 3-week forecast. Circa August, we turned that into 3 to 6 week projections because we had to make a few more assumptions than we did in the forecasts, which were just given delays in the system, this is what's going to happen, versus there's a few things we have to assume. They were published every week through SAGE, and Patrick has signed off many of them, so I'm sure that's why he has to come to me. But how useful they were outside of government, if people like yourselves weren't seeing them, I guess is a question for us as to how we could promote them, such things better. I think there is a question back at Stephen for UKHSA as to what the future of such products look like in peacetime and how often they are needed, what they look like, as I say, in peacetime rather than in wartime.
So, I should probably come in there. And be careful not to say anything that boxes me into a corner. I've taken part in the CDC flu challenge over the years. So I actually was, I was the second, we've competed since the second year, and I remember watching the first year of that exercise. And it wasn't just a technical science exercise, it was designed after the 2009 pandemic to try and create a community around a specific task and to provide them with a single data set. And therefore, when the pandemic came along, the CDC just kind of copy-pasted that. And I think you're right. I think it was a great example of the use of modelling science during the pandemic. There were very good reasons why, if you didn't already have that, you might not want to suddenly spin it up in the middle of a crisis, which is perhaps why the UK solution was a little bit different, but was extremely successful in its own way. Without committing anyone to anything, I think it would be a great idea if we could formalise that. And there are independent efforts already along these lines. So I know that London School has got a kind of ensemble scenarios of forecasting as well. So there are some independent exercises which are already ongoing, and it's something that I would like to see us look at in the future. But we've got to find the problem and the data and the people to do it. Thank you.
I was going to use the D word as well. I think from a sort of public engagement point of view, I think the absolute success of all of this has been the dashboard. I mean, I think it's been an astonishing resource for all of us. It's probably been one of the most hit websites in the UK at 4 o'clock every day. And I think we should be looking to think, what else can we dashboard? I think it shouldn't be we come to the end of this, we mothball the dashboard, we stop doing this. I think we should be looking and saying, okay, what other UK government data sets can we put out? And they don't all have to come out every day. A lot of them won't. But one of the astonishing things on COVID Twitter in general is how determined people are to get hold of data. I know people who've spent an entire evening measuring the position of pixels on graphs in order to get the height of points, in order to recreate the data set. Now, people will do that, but they shouldn't have to, right? If you can get stuff that's out there, and to move from however many hundred Excel files there are scattered across different government departments, websites, put out by the ONS, just put everything out the same API. That was the key, I think, for a lot of this, was putting it out by an API that people could hit, people could get what they wanted. I think to make that data more accessible, and if we're talking about wider lessons, I'm not just talking pandemic data. The more data that we have, the more informed we'll be, the more people will think about it, the more people will model it, the more we'll learn. That's my manifesto on this.
Progress towards net zero being an example where that would be extremely valuable. Liz.
Given that I'm a massive open link data fan, I just wanted to put a counter in that says there are different qualities of data available, and there is a huge responsibility on all parts of the public sector to provide appropriate and correct statistics. What we found a lot during this emergency was that we were using operational data that we knew had a certain degree of uncertainty or a likelihood of being corrected further down the line. And the question about how responsible it would be to publish something which you knew might be changed significantly in the next couple of days, I think is one which needs to be continually considered. And that's really a question for ethicists as well. So there needs to be a way by which you can make as much data as possible available as swiftly as possible to as many individuals who are wanting to use it as possible, but to be able to say these are not, we were talking about this earlier, I think the ISO for clinical coding is like 3 months. So when my minister says you've only just published something looking at the social cost of a case of COVID in January, can you do it a bit quicker? My response is, I'd love to do it more quickly, but those data only become available at the end of April. So I can't start before then. And we need to be able to understand that there are going to be different timings associated with it.
And that's particularly important when you look at international comparisons as well, as to when data becomes available. Julia.
And thank you all, panel. That's been amazing. I'm very excited to ask this question of you, which I've been pondering for some months.
Oh, God.
It's about how UK academe interfaces with UK scientific advice for government. And we've been literally thrown together in the same room in so many ways over this emergency. But what have we learnt from it? How can the UK academe, thinking from the academe side, be better placed to contribute usefully to government scientific advice? We've talked a little bit about funding, but I'm interested in also the pressure on individuals who are involved, the constraints on our institutions of all varieties here. What have we learnt from this that could help in the future?
Let's start at this end. Libby, do you want to kick off with that?
I mean, Julia, start with an easy question. I think we have learnt a lot having been thrown into rooms together that is the starting blocks. And actually, I think Steve was talking a little bit about this in introduction as to how academics think about the problem, and that clashes with how policymakers do. To be better placed, you need to understand where our questions are coming from. And I'm not sure at the start that was where we were, but I hope after 2.5 years we do understand a little bit more.
Please.
Yeah, go on.
Cultural exchange programmes. I've been thinking about this a lot, Julia. Obviously, I'm not going to be able to come and teach in Cambridge anytime soon, but I think there is far more opportunity that we're not taking advantage of, particularly given that the other great problem for academe is often coming to the end of grant funding and spending all your time doing grant funding applications. Why on earth aren't we getting people at all levels of academia to come and do placements with policy makers who are interested in the outputs of their research, to talk through with them, to learn with them, to start off on different things, to find places where we can come together, and indeed for policymakers to spend more time in placements where they come and do periods of time. What's the Science Policy Institute and so forth. There should be so many more opportunities for us to get to know each other's cultures, and indeed for scientists and analysts to be able to understand the different benefits that they can bring to problems. So modelling community is right in the middle of that. You've unfortunately just had the whole of government's eyes opened to the amazing benefit that they can have if they model literally everything. If you look on the TAG website, you will see many papers about the potential risks of opening ice rinks, saunering and steam rooms, and all kinds of wonderful things that you can model with fluid dynamics or with population sort of considerations. So I think we need to use this as the crest of a wave and make it benefit all of us and make it continue. And if the public sector needs to put more money into maintaining those wider communities of interest and cross-interest, and to encourage academia to have more multidisciplinary and cross-disciplinary symposia, then that would be money very well spent.
Well, I'm going to get a couple more on this because, John, you spent many years as science advisor in government. You may want to comment.
Yeah, no, I mean, so I think I'm going to, so two things. I absolutely agree with this, and that collective memory is going to be exceedingly important. I mean, there are so many people who've been involved in COVID, but probably the next time it will be slightly different and they won't necessarily be involved. And so how do all the people that will be involved next time learn from the people who have been involved now without having to, go back and do it, just by learning through experience? And I think trying to understand how we get that idea and particularly how I think some of the most valuable learning will be from students and postdocs who've been exposed to this. How do we keep them interested? How do we keep them thinking this is actually an important thing to go through and, tell their peers about? They should be incredibly proud of the work they've done. And it should be, filtering through not only the direct scientific benefits of the work they've done, but also the benefits of learning how to tell government, tell other people about the work they've done, and really try and focus on that. I think secondly, for me as science, when I was doing science advice, the most important thing for me was to try and understand what the collective position was, and then any real marked deviations from that collective decision. So synthesis of data and synthesis of evidence is hugely important and not valued very much outside an emergency. So this collaborative nature, which we've all been talking about, is brilliant. Will, in next year, when people are producing lots of models, will they still produce collaborative summaries of this is where we're at, this is where we're best at? Or will they back to, well, my model's better than your model, or my idea is, and I think trying to work out how we keep synthesis going is really important, because particularly when I had a question, I'd want to know what everybody thought, not what one particular group thought or what another, because you then get a real idea, and you'd want to know what people thought, but also what the divergences were, because they're going to be the uncertainties that really, really matter. And I think also allowing people to be comfortable with saying, I don't know something about this, or I'm uncertain about this, or, you know what, this is my best guess, but the quality of the evidence about it is pretty rubbish. They're all really important things. I want to know, I need to know what the best evidence you have, but I also want to know whether you really believe it's cast iron true or it's your best guess. because that's really valuable. And trying to have that sort of culture, being prepared to do that is something we've had lots of in really, really good form during the pandemic, but I don't want it to then slip back into, well, we've done the pandemic now, let's go back to business as usual.
Might get the probabilistic yardstick tattooed on parts of our bodies just to make it easier.
So it is a really important question. Interesting, I was speaking to somebody, a very senior civil servant from another country recently, and he said, he was asking about science advice and how it works, and he said, the problem we've got in our country, and it's not unique to his country for sure, is scientists don't know how to talk to the civil service, and ministers and civil service don't know how to talk to scientists. So your point is very well made, Julia. And I think I'll give a little plug here for the UKRI internships, which give the people during their PhDs an opportunity to come and spend 3 months in the Government Office for Science. And I can tell you they are A, remarkable people who come and do that, and B, learn an enormous amount and give an enormous amount when they're there. So there are schemes there, and I think there's an interesting question about how these might be scaled. Right, I have 2 questions online, and my machine has just asked me for a code, which I will get in. So I'll take both of these together. One I think is I don't know quite. I think it's a slide rule question. So I'm going to warn you, Oliver. I'm coming to you with a slide rule question. So the question from Susan Gale Graef is if there's a discharge of electricity, so let's start, I suppose it's a solar storm or something, and given the technology then doesn't function, is there a plan B? Okay, so that's one for you, which would become relevant perhaps in that specific situation. And then there's a second interesting one from Tom Robbins, which is, in finance, there's a separation between people who do modelling, the quants, and people who make the buy and sell decision, the traders. We have plenty of quants in emergency modelling, but do you think they ought to advise on policy? Is there a missing discipline between science and politics? Sort of a follow-on in a way to Julia's question. But Oliver, I'll give you the slide rule question.
Well, I think, I don't know, maybe I'm talking myself up here, but I feel like what I've been doing is the slide rule. I mean, I think that, some of these models that people have been showing today are just incredible, huge data, downloaded, synthesized, put together, massive hierarchical models. The stuff I've been doing is literally plotting it on a log scale, drawing a straight line with a ruler. And to be honest, I think there is a place for that kind of stuff. I mean, I'm not saying that it outperforms these models by any sense, but I think it's often been the case that if you wanted to know where you were going to be in a week or two's time, then plotting it on a log scale and, extrapolating, particularly, now when I say a lot of it's being driven by variance, I think if you have a sense of, well, the numbers are here, the variants are doing this, sticking together. I talk about back of envelope, so I don't know if it's the same as the slide rule, but I think there is a place for that stuff. I'm not saying it should replace any of the more sophisticated things, but I think some of what I've tried to do sometimes is just to be a sort of sanity check on some of these models. Because if somebody's got a fancy model that's come out on a computer that doesn't match what the slide rule is saying or the back of the envelope is saying, then that, it raises a question. So in terms of the sort of tire kicking that I think we should be doing on these models, I think the slide rule thing is definitely part of it.
Yeah, and I think you're absolutely right. If it doesn't match, there's at least a question to be answered. Mike, can I get you to do the quants and traders question? Because you've suddenly been exposed to this world of interacting with government.
Yeah, well, interestingly, there were a number of quants who actually joined RAMP and started epidemic modelling, and they did a very good job. So the natural analogy then is to say, well, the quants are the scientists and the traders are the politicians? I don't know, actually, but one thing, it does connect a little bit with the previous question, and also with what John was saying earlier about whether the civil service is about to open itself up to a more modelling culture. Because if you think about the role of modelling, if you're an academic and you're used to interacting with industry, then you, particularly with the bigger companies, you generally find people in those companies who are modelers, who speak our language and can play the role of being discriminating buyers of our product. And do you need to have discriminating buyers? Because if your organisation doesn't have the expertise to spot the charlatan from the genuine expert, you will get very low quality. Even from the better people, you'll get worse results because the incentive isn't there. You know, they're not competing against anything. So maybe the answer lies there as to strengthening that the level of modelling expertise within the government side, so that they can, they're a better impedance match with the academic community. And I'm not sure you want a broker in between. I think that could just slow communication down rather than improve it. But you do, I think, need a better receiving mechanism potentially.
John, anything to add on that?
Yeah, no, I mean, I really agree. I think that that it is really important that you have the mechanism to talk across, so that there are good modelers in government. I think that there are good modelers in government. I think that I've been fortunate to work with some really excellent modelers who are inside government. Sometimes they don't get the visibility because they're working inside government. They don't publish in the same way. You see a report and you go, "Oh, the modelling in that's nice." You won't know who did it. Whereas, if it's in academia, you'll see the name on the paper. And I think helping build the professions inside government is really important. So, I absolutely agree with that. And I think we need to champion those who are doing really great stuff already, and then help build the number of people and their ability to progress within government who are doing that. I also think that there is a role for helping people learn how to communicate complex scientific ideas in a way that is accessible to policymakers. I think many people have had to do it through experience during the pandemic, but I think there are people who look at how to do evidence communication, how you frame it in a way that is the best way to get the evidence across in a way that doesn't necessarily skew the decision one way or another. I think the sort of the classic cliche of advisors advise and ministers decide. You have to be very careful that the advisors do the advising, and I think I'd be slightly worried if there would be a view that well, in actual fact it should be the academics who are making the policy decisions or only presenting things that are one set of policy options. And I think but I think absolutely we can get better at helping people learn how to communicate evidence. So I think there are roles for people who can do that, and sometimes they are not the same people who are doing the modelling. And I think that there are some people who are really, really excellent at understanding the modelling and then being able to explain it, who are not the modellers themselves, and I think we should value them very highly as well.
Yeah, and I just want to add one other thing. I mean, I think it's incredibly important for science advice in government that science advice is science advice. It's not policy. It's really, really important, because the moment you start making policy recommendations, you are no longer independent in the system. You're no longer able to give contradictory science advice. It's really, and we again had this discussion on Friday with some other European science advisors. It's where in certain places things went wrong, where the science advisors stray into policy, and then there's really no way back from that, and you lose all credibility to be able to do the job. Now, Peter Bruce wants to come in. I think I saw Darren as well. Yes, Darren, I think you were first.
Yes, I work in a highly regulated industry that Patrick's more than familiar with, where we industrialise and standardise data. And as Oliver said, the biggest change to COVID data was the API. When week on week you'd get a column of data and it would appear or move around, or the data names would change. And then we got industrial data scientists involved, and suddenly things started to look like data sets. So we used industry to run the Lighthouse labs, because they needed PCR machines and scientists. But we could have had an army of data scientists who, with the best will in the world, modelers aren't data scientists, from industry. So what does the panel think they can learn from an industrial setting in peacetime, if you like, now, before we go into the next emergency?
That's a great question, and it actually matches one from Eric Chowdhury online, which is, were you aware of any modelling being done in the private sector, banks, consultancies? And Darren's raised data science as well in that sector, and what were the interactions like between the academic communities and the private sector? So we'll pick those two together in just a minute, and I'll take, Peter, your question as well.
Thanks very much. Thanks, Patrick. Peter Bruce, Physical Secretary of the Royal Society. Apologies, I couldn't be here for the middle part of the day, but we are having the annual meeting with the National Academy of Sciences in the US and running in parallel with this, I'm afraid. There is a reason why I mentioned that. I wanted to make a comment on the science advice to government. And the reason I mention it is Marcia McNutt, who's president of the National Academy, for other reasons, was talking today about the fact that at the early part of her career, her head of department called her in and said, I want to see your CV. And he went through it and said, what are you on this committee for? Oh, get that out if you're time, don't spend time on that. Take this out, take that out. In other words, the reward structure, the career progression structure is not going to incentivize people to give time to engaging with policy folks and learning and understanding their world and what their needs are. And I think that's one of the, it's not the only barrier, but one of the barriers to getting academia, to Julia's point, to advise better, I think, into policy, is it's just not part of the reward system for academic career progression. And we need to think about how we can perhaps address that problem.
Thank you. Right, so let's go to the questions about private and private sector industry experience, particularly as it relates to data science, but also more generally. We've already had a bit of an answer from that from Mike, saying you did have people on RAMP, and certainly in other areas we brought in private sector people with expertise, but interesting on the data science question. Mike, do you want to come back on that at all?
Yeah, I mean, this business about the data appearing in different formats every week or from different parts of the country and so on. Yeah, so it seems to me these are sort of some, and I think this lesson maybe has already been learned or is well on its way to being learned, but this is an area which there can be certainly peacetime improvement that would make the platform for the next emergency just so much easier for everybody. And it's not just the formatting of data, but who is allowed access to it under what circumstances. Of course, as much as possible should be in the public domain anyway, but there will always be some restrictions. And then there were a lot of issues this time because it's personal medical data about, who's trusted with it. So I think that is a low-hanging fruit, really, in the sense that it just needs a bit of joined-up thinking to make the data situation work. But certainly the lessons to be learned from the private sector are obvious there. I agree completely.
Steve, do you want to come in on this at all?
Yeah, so in my current role with UKHSA, so our group is data analytics and surveillance, and a big part of our plan is to try and improve the infrastructure around data within public health in the UK. There's a long tradition of fantastic analytical work, both within the old PHE, within the academic community. There's lots of fantastic work that has been done over many years, but I don't think as a community we've ever had the investment for those kind of large-scale IT infrastructures that pharmaceutical companies have, and that really enable you to bring in those data science specialists to add value. So we are definitely trying to do that, and with a view hopefully to making as much available to the public from those when we can. But it's not easy, and it's worth remembering it's expensive. So if you want something done at the same grade as a bank, then you might have to pay similar rates to the rates that banks pay, and that's not normally an option in government. So figuring out exactly how to get that done within a very austere spending review is not easy.
But it's a good ambition to get that in the right place. Yes, we can take just two quick questions and then short answers. Yes, and then behind you. I'm going to go to the woman behind you first of all, and then come to you.
Thanks. I have a question about how you think the UK modelling community did internationally, and what could be done in the future for meaning that more UK modellers can contribute to international policy and international modelling where they might not have the same kind of modelling resources that we have here.
Brilliant, thank you.
Hi, I'm Dirk Groen from Brunel University London. Quick question. So
Especially the first lockdown was very much shaped by a lack of knowledge about COVID-19, in particular about surface transmission, but also, for example, the risk of transmission outdoors versus indoors. And it shaped not only the official interventions, but also the way that the public handled it. A lot of sanitizer got sold, for instance. And I'm just wondering, as a community, I mean, I'm a modeler, but also on the experimental side, are we prepared to make such assessments much quicker when a new virus emerges? And is there anything in place to do that kind of assessment really quickly?
Great. Okay, so international question. Who wants to have a shot at that? What did we do in terms of international? There's quite a lot of connectivity that went on. You might be best placed, Steve, are you best placed, or Libby possibly might want to answer that as well?
So there were a lot of collaborations in place, and the flu community had a kind of international network trying to share data and be ready for modelling. I think that during the pandemic, the WHO coordinated some really useful networks, and a lot of work did go that way. And I think the UK was very influential there. And then I know there's a number of active grants since then. I think Adam Kachalski, who's speaking later, might be doing some work on this, and I'm sure there are others to kind of actively develop those networks. There's a ways of working angle to this, which is if the data are public, if the codes are accessible, understandable, and they're published in a really clear way, then the friction for enabling that capacity out into other countries is much, much lower. And coming back to Fliss's point, if they're designed in such a way that they can apply to different geographies, I think we can do that. But I think it's a priority area for the community to improve that going forwards.
Thanks. Fliss, do things much quicker next time?
Yeah, I think we've got a lot better understanding now of the things that are going to need to come into place. That sort of question that kept dogging us for such a long time was, well, what's the ratio? What's the split between fomites and aerosols and heavy droplets? Because what are we going to recommend is going to be the easiest fix. And in the end, we couldn't. So we had to say, well, everybody needs to stay into isolation. But the methodologies by which we develop vaccines take as long as they take. The methodologies by which we bring in assays and develop tests take as long as they take. We were pretty damn fast with them this time round, and I don't think that there's a huge degree by which we can speed up on those. But our understanding of behaviour in our own countries and our understanding of the way that we need to respond and where to look for things, and hopefully the understanding between scientists and the public sector means that we're going to respond much faster in terms of our international hygiene, and that will give us longer. And it's about giving ourselves as long as possible to understand something before it is on our doorstep. Can I just respond to Peter as well, if that's okay? We did a set of feedbacks with the subgroups for our technical advisory group, and basically apologised and said, you've been wonderful volunteers, but we feel like we've used you because all that we can do is write letters of ref credit to your vice-chancellors and say thank you. And the response was quite overwhelming, not just in modelling, but in our environmental group. They said, firstly, several of our subgroups want to just keep going because they really like being able to consider things together. But a number of people have said, and I don't know how much that's true for people in this room, that working academically, you don't always get a great deal of opportunity to see real-world implications of the work that you're doing. And the interface between the public sector and academia, not just for the emergency, but if we carry on in those longer-term relationships, not just the way that you network, the way you find out what the public sector wants in the same way as you find out what industry wants is going to improve your chances of applying for grants in the future. And it's a chance for you to see your work actually coming into the world and actively saving lives or improving lives. And I think actually perhaps we undervalued the exchange there.
Great, thank you. And just a word, making decisions in uncertainty is, of course, always the situation. And the question is where you want to put that boundary. And that is very much one for political leaders to make choices around about how much certainty they want before making decisions on interventions. But on speed, just to sort of throw down a challenge in this world of how we understand more about a disease quickly. Last year at the G7, there was an agreement on the 100-day mission which said, A, we've got to have a good surveillance system globally to pick things up earlier, but B, once we pick it up, we ought to, as a world, aim to be in a position where you could have vaccines ready to be produced at scale, an initial regimen of therapeutics, and reliable approved diagnostics ready within 100 days. And that was the mission which industry and others and many organisations across the world have picked up on, to say, what do you need to have in place? And it speaks to some extent to Mike's point about how you keep science going in between times to try and improve the platform from which you can move fast next time. And I think it is an interesting question about whether that applies to some of the things we've been talking about today in the modelling and projection world. Look, thank you very much, everybody. Thanks to the panel who've been terrific and to the audience for great questions. Lots of key areas have come up time and time again. This notion of community power, and particularly the link to a community beyond the one that you just see in front of you. So who are the broader community out there that could contribute to this, I think is incredibly important. That links to the question of data availability, and we've had a lot on the need to get high quality data, make it available and make it widely available. And as I said at the beginning, I think that's not just an issue for epidemics and pandemics, and it's an issue across the whole risk register space that needs to be looked at. In several different guises, we've touched on communication and the need to be able to communicate uncertainty, to be able to present things in a way that actually allows people to both understand them and not to make mischief with outliers and extreme results. And I think there's a whole question there that's going to come up as to how that's done better in the future. And a very important point about this question of keeping important science fashionable, I think as Mike put it at the beginning, keeping people who are able to do this quickly. And we were actually very fortunate in this country with the scale of scientific knowledge and expertise we could draw on quickly in all of the areas, including things like being able to rapidly get vaccine science going, rapidly be able to assess therapeutics, as well as the areas that we're talking about today. So that baseline of science is clearly important. And a final area which has been picked up, I think, repeatedly is trust, and the notion of how you build on open, good science in order to create trust and actually be trustworthy, which is clearly important and relevant to science, not just in emergencies, but right the way through, because science impacts virtually everything government has to do. And we don't live in a world where governments are primarily scientific, but we do live in a world where actually most of the problems that governments deal with are scientific or have a scientific answer or solution or input that should be made. So there's a big transition going on about the need for more science inside government. And I won't end on a down note of your comment, Steve, that you're 50 years behind the weather forecasters. I can see an awful lot of flinches in the room on that, and I don't think that's quite true. But thank you very much to everybody, and thanks again to a terrific panel. Thank you. And with that, we are done.
Thank you, Patrick.